Hello? Hello? उधर म्यूट है. हेलो. इसको क्या करूं, बंद कर दूं? हेलो.
Heard, but I don't know if all have joined.
I'm audible?
Yes. Am I audible?
And yeah, you are audible. Yes, you are audible, ma'am. म्यूट करते हैं.
List, and you can see that the list is enormous, and it affects right from the cornea to the lens, the adnexa, retinal choroid, the optic nerve, and even the entire globe. Most of these disorders are seen in day-to-day practice. They may affect from defects in the chromosome up to point mutations in our genetic code, and often they are associated with systemic associations. To highlight the importance of genetic disorder, diagnosing a genetic disorder in a clinic, I will share this case of a 26-year-old male who presented with a history of sudden onset, painless, yet slowly progressive, simultaneous bilateral loss of vision, which was around 12 years, history of around 8 years back, that means onset around 18 years of age. The old record showed that he had a bilateral optic neuritis, a diagnosis of optic neuritis, but the MRI at that time was normal. Yet he received IVMP doses, and current vision was 1/60 in both the eyes, and both eyes showed bilateral optic atrophy. So I was wondering what is atypical in this case. A bilateral optic neuritis usually will have a relapse progressive.
चार्ज है चार्जर भी है। Hello? Hello?
Hello, ma'am. Hello, ma'am.
I'm audible?
Yes, ma'am.
Yes, you're audible. Yep.
Okay. My slides are visible. I should share my screen
Share screen and check,
to see
and then unshare after that. Hello.
Good morning, ma'am.
now.
Good morning, everyone.
Ashu, hi, good morning.
Good
Good
morning.
morning.
Good morning.
Good
Ashu,
morning.
Ashu, can we start? Madhu ma'am is here, so we can start.
Ma'am, just give me 1 minute. I'm just coordinating with few presenters.
Right.
Good morning, everybody.
Good
Morning,
morning,
ma'am.
Dr. Madhu.
Yep. How are you?
Good morning, ma'am.
Fine.
Yeah. Good to see
Good
you
morning,
early in the
ma'am.
morning. Good morning, Jimmy.
Ma'am.
Ma'am, I always like your backdrops, ma'am. The books, huh? Good one.
The source of inspiration for all of us.
Good
Absolutely.
morning.
For me too, yeah, they're on my backside. I would rather have them on my front side.
You already have them imbibed, ma'am. You already have them thorough with yourself.
Nah, yeah, you are never thorough, you know.
Ma'am, we are ready to start. Should I start now?
Yes, we should start.
Ma'am, should I start now?
Ashu, please go ahead and the others can mute the mics. Right.
Okay, ma'am. So, warm wishes and a very good morning to everyone. I, Dr. Ashu Agarwal, welcome you all to this. Sorry, ma'am.
Your
Ma'am,
voice
am
is
I
breaking,
audible
Ashu.
to all?
No, your voice is cracking. I think now it's
Ma'am,
okay.
I'll just check the internet.
Speak where you are. Speak from where you are now.
Okay, ma'am.
Yeah.
A very warm wishes and a good morning to everyone. I, Dr. Ashu Agarwal, welcome you all to this promising session of WAS in the annual National Conference of Delhi Ophthalmic Society, where we look forward to academic feast and interesting discussions in the various aspects of ophthalmology. So it gives me a great pleasure to welcome and invite Dr. Madhu Baduria ma'am, who is President WAS, to tell us something about journey of WAS. Ma'am is a senior and a distinguished ophthalmologist, as we all know, an alumni of King George Medical College, Lucknow, and a fellow in glaucoma from Shankara Nethralaya. She has been a professor at the Army Medical Corps and is currently director at Regional Institute of Ophthalmology, Sitapur Eye Hospital. Welcome, ma'am, and please enlighten us with few words.
Thank you, Ashu. It's always a great pleasure to be on this forum because it's so dear to my heart, not because that I happen to be a president, but it's just that I love the people who are in this organization and who have started right from the inception, because from the conceptualizing to developing and going leaps and bounds year on year. All the programs that WAS is conducting and conceptualizing are truly innovative. It's not that we are copying anybody, rather we are creating a path, a journey which others can emulate. Simple things like a mentor-mentee program, WIN-R program, all these are really star programs, because whatever we say, women have not one role, they have a dual role in life. And because of this dual role, the most productive period, which could be professional productive period, is used for the reproductive period. So to balance these two things, a family, a profession, and still be on top, it's a challenge. And despite all the challenges, what we see in ophthalmology, that truly women are coming up. They're broken all the possible glass roofs, and they're really on the top. And I'm very proud of the people who are in the WAS, who are working for upliftment of women without competing with anybody, with the collaboration with every possible organization, whether it be IOS, DOS, or whatever. Collaborating with all the elements of ophthalmology, from clinical to business management to motivational leadership to research. So this is the kind of a collective collaborative effect is what is showing up. The numbers are going really in a big way in WAS, and I'm honestly really very, very proud of being a part of this organization. And all I would say, girls, keep on working. Your potential is infinite. The first thing we all need to believe, the potential is infinite. We should not draw boundaries. We should not draw the limits. It's only when we draw a limit that I can't do more than this, that is the day we start this thing. So keep learning, keep growing. And all I'll say is that I'm very fond of you all, and I'm always there for you for any kind of help, guidance, need. I really don't know how much useful I could be or would be, but all the same, I stand behind you. Even if you make a mistake of sorts, I'm not going to let you down. I'll be with you. So that is what is my message for you all, that I am with you and will be with you, right? And with that, with the upcoming Christmas and New Year, so I wish you all a very, very Merry Christmas and Happy New Year. And with this note, let's move on. And I let the show be with you. And let me enjoy now. Thanks.
Thank you, ma'am. Your encouraging words always give us a morale boost. So now let's start the session. It's a privilege and a pleasure to introduce the eminent ophthalmologists who are panelists for today's session. First and foremost, I would like to welcome Dr. Mohita Sharma. Ma'am is an inspiring ophthalmologist and a dynamic leader, an alumni of prestigious MAMC, Delhi. She did her ICO fellowship in vitreoretina from Germany. She is the founder and chairperson of Tirupati Eye Center, Noida. She has worked extensively and has been awarded multiple times for her work in diabetic retinopathy and AMD. She is presently Secretary and was founder of Women Ophthalmological Society. And she's also the core founding member of WIN-R Network. So we welcome ma'am to this session. We have amongst us another eminent ophthalmologist, an alumni of GSVM Medical College, Kanpur, Dr. Nilima Mehrotra ma'am. She did a retinal laser fellowship from LVPI and has keen interest in blindness eradication and has been an executive member at Eye Bank Association of India. She is founder and the professor and head of ophthalmology department at SRMS Medical College, Bareilly. We welcome you, ma'am, to this session. Another distinguished ophthalmologist who is amongst us is Dr. Jimmy Mittal. He is alumni of King George Medical College and a short-term fellow in glaucoma from Arvind Eye Hospital, Madurai. Currently working at Vivekanand Polyclinic and Institute of Medical Sciences as a senior consultant, and is active in academics and teaching DNB and optometry students. Welcome. We have today amongst us Dr. Iram Parveen. She did her MBBS from LLRM Medical College, Meerut, and diploma in ophthalmology from prestigious AMU Aligarh. She is right now private practicing in Moradabad and was scientific committee member UPSOS. She has been past secretary Moradabad Ophthalmic Society and has presented many a times in live surgeries and got WAS award for her surgical skills. Welcome, Dr. Parveen, as a panelist to this session. So after welcoming all the eminent panelists, now I would like to move ahead with the presentations from our young and motivated speakers, for which we all are looking ahead enthusiastically. So we have amongst us, first and foremost, Dr. Kavita Duraipandi. I have known Dr. Kavita personally also. She's a prolific vitreoretinal surgeon. You can say that she's the Iron Lady of retina. Her surgeries are flawless. Her ILM peeling is something which everyone can learn from. And it's a pleasure that she will be presenting a video on ILM patch graft in failed macular hole. One more thing I would like to add is that Dr. Kavita is presently in UK and it is 3 a.m. there right now. And it is her zeal and enthusiasm that she has woken up the whole night and she will be presenting her video in front of us. Thank you so much, Kavita, ma'am. Dr. Kavita, please share your screen and video.
There's some challenge, I think, with her.
Okay, ma'am, I'll just coordinate with her. Dr. Suma is there.
Hello, ma'am. Ma'am, Dr. Kavita is not here.
She just messaged me that she is there, but she doesn't have access to share her screen.
Can you just see if she's a part of the, if you've not promoted her from to a panelist?
Ma'am, I'll just tell her to join through the link.
Hardik, yeah, Hardik.
Yes, ma'am.
Please promote her to panelist. No, they have to do it. They have to do it from their end if she has to be promoted.
No, ma'am, वो attendees में भी नहीं है.
Attendees में नहीं है, अच्छा. Anyway, I think we can take the next one and then meanwhile can coordinate.
We can move on to the next, I think, and connect with her later.
And then you can coordinate. Somebody can coordinate with her.
Dr. Suma Ganesh, are you there?
Yes, I'm there. Yeah.
Okay. Ma'am, would you please go ahead with your presentation? Dr. Suma Ganesh will be presenting on 2 rings in pediatric cataract with aniridia. Ma'am, please go ahead.
I would at the onset like to thank DOS, Dr. Namrata Sharma. What a wonderful show. And WOS, I think I'm first time presenting, and it is good to be among the youngsters. I feel so young. I had just sent it and I was so glad that it got, So I will be presenting an iridia rings in a case of pediatric cataract with congenital aniridia. So we all know that congenital aniridia has these features of keratopathy, glaucoma, cataract, optic nerve hypoplasia, foveal hypoplasia, and nystagmus. So this video is like a child with a 6-year-old child with congenital aniridia. So preoperative evaluation, she had cataract, she had keratopathy, optic nerve has been checked and it was found to be normal, pressure was normal. So did a routine pediatric cataract first with, of course, there was hardly any iris stump. So the visibility was very poor because there was a lot of keratopathy with, you can see that there's limbal stem cell deficiency. So now this ring, there's an iridia rings. So we can see that the blunt end has to be put into the, so it is pushed, each fragment is put into the anterior chamber. Of course, the anterior chamber has to be filled with viscoelastic. So the fragments of these are very, they are very friable and they break easily. So we need to be very careful. Of course, a Simsky hook in the other hand would have been helpful. So this is the first ring which has been put because the child had a lot of photophobia and glare, and so they came up that these rings have to be put. Though I was very apprehensive because these children later on land up with glaucoma. So this is the second ring. So again, you take and now we have to ensure that this ring goes below the first ring, because this is very important that the ring has to go below the first ring and it should be in the bag. And otherwise, if it does not go in the bag and if it does not go below the first ring, you cannot rotate it easily later on. So these are rings which are made up of PMMA material. The overall diameter is around 10 millimeter. And these are available easily. And they're with, I have no financial interest, but with the care group. So these two rings are then rotated later on. Now, this is not as good as the Mosher rings, which are really available. I've seen the videos on YouTube of Mosher rings. I have not been able to get them. They have more bigger fans. So then these fans could have been, the pupil size is still not big enough, where you would have thought that the pupil size is not small enough, where you would have thought that this could have this will really make an effect on the glare. So this now you have to rotate the two wing rings and interdigitate them. The fins have to be interdigitated to form a confluent iris diaphragm. Now, whether these rings, these are PMA material, whether these rings, I have just a 1-year follow-up and the child is doing pretty well. But whether these rings on long term, how do they behave? I've searched literature and found that they do pretty well. But chances of glaucoma is something which we'll have to observe. So you can see that you have to rotate the rings to keep the fans interdigitate together. And this is only possible if the two rings are separate and they are in the bag. So now if you see, this is the confluent iris diaphragm which is formed. And then you can put the enfoldable intraocular lens into the bag. With the injector itself, you can push it into the bag. So this has to be rotated, and again, so the use of OVD has to be there because a lot of OVD is required for this. So this child has done pretty well, but long-term follow-up, the glaucoma experts may not agree with me in this because they would believe that long-term follow-up is really required in these cases. So this is the endocapsular rings. It is available as endocapsular rings, and it's not very expensive also, but we have to check the long-term results. Thank you.
Thank you so much, ma'am. It was really nice to see this video. Now I would like to call upon our next presenter, Dr. Kavita. She has joined the meeting now to present her video on ILM patch graft in failed macular hole. Dr. Kavita, the voiceover cannot be heard, so it would be nice if you would describe the video.
Hello, good morning. Can everybody hear me right now?
Yes, ma'am. Can you just increase your volume a bit?
Reduce the voice, reduce the volume of the voiceover.
No, increase.
Okay.
Increase it more, ma'am.
Increase it more.
We had a patient with
It is
pseudophakic
fine, ma'am.
retinal detachment with macular hole who underwent a pars plana vitrectomy with ILM peel and endolaser and silicone oil injection. He was posted for oil removal. On examination, his best corrected visual acuity was 616. Retina was well attached, well lasered with the presence of a macular hole. This is the pre-op fundus photograph and autofluorescence depicting the hole and the status of the underlying RPE. This is the pre-op OCT of the hole with a macular hole index of 0.19. So the options we had were to go in for a repeat vitrectomy and put a longer acting gas, to do an ILM flap or a graft. There are various case reports on successful autologous retinal transplant. So I took up the case. 3 25 gauge pores were made. BBG dye was used to stain the ILM. A good 1.5 to 2 disc diameter peel was noticed. A piece of ILM was picked up from the infratemporal arcade and was gently placed on the macular hole. Using a diamond dusted membrane scraper, the ILM was gently tucked into the macular hole, taking utmost care not to disturb the underlying RPE architecture. Fluid air etching was done and 25% gas was used as a tamponade and pores were closed. Post-op 1 week follow-up showed closure of the macular hole with RPE changes. There are many reasons as to why a hole wouldn't close after the primary surgery, despite a good ILM peel. But in our case, the fact that the hole was large and a pocket of fitness in the hole could have resulted in the non-closure. In our case, the ILM acted as a scaffold, leading to ILM scarification, waterproofing effect, and thus closure of the hole. Although manipulating a small mobile piece of ILM can be challenging, this technique allows the surgeon to salvage eyes with large and long-standing macular holes that have failed previous surgery. Thank you for your kind attention and have a wonderful evening ahead.
Thank you, Dr. Kavita. Wonderful video, very nicely presented and documented case. Any comments from any of the panelists about this? Any questions? Okay, so moving on to the next video presentation, we have Dr. Ritika. Dr. Ritika has done her fellowship in cornea and refractive surgery from Narayan Nethralaya, and she will be presenting on next generation calculator for thin corneas. Dr. Ritika.
Good morning, everyone.
Good morning.
I'll be sharing my screen now. Okay, so.
A new app for energy titration for cross-linking thin corneas. In the current time of COVID-19 pandemic, there is a paucity of corneal tissue. Thus, there is an increased need for cross-linking to save the thin corneas from progressing further. So what are the treatment options available to us? The current management modalities of keratoconus has been previously well established by our published work. So let's see a case of an 18-year-old male who visited us with complaints of frequent change of glasses. His retinoscopy showed a scissoring reflex with high cylinder. His topography showed advanced disease with the thinnest corneal thickness of 390 microns. So how do we proceed in this case? Do we go ahead and do a standard cross-linking in this patient? or do we post him for a keratoplasty? So this led to an idea floating in our minds. Is there a simpler way to calculate energy titration and time? A team of researchers have proved an algorithm which predicts the biomechanical effect of cross-linking by customizing UVA fluence to the corneal thickness after taking various parameters like UVA intensity, riboflavin concentration, and time into account. Our research also gave proof that cross-linking is more dependent on the duration of the UV light than the overall applied UV fluids. Thus, we developed a software known as the NXT UVA calculator, which gave us the fluence time for different epithelial of corneal thickness. Based on this app, we derived an algorithm which gives the fluence time according to the epithelial of corneal thickness and to its corresponding UVA fluence time at 3 milliwatt per centimeter square and 9 milliwatt per centimeter square. So how did we manage our patient in such a case? He had an advanced keratoconus with the thinnest corneal thickness of 390 microns and an epithelial of thickness of 340 microns. This was entered in the app that gave us the corresponding UVA fluence time of 21 minutes and 95 seconds at 3 milliwatt and 7 minutes and 30 seconds at 9 milliwatt. 0.1% riboflavin drops were instilled every 2 minutes for 20 minutes, followed by 7 minutes 30 seconds of UVA light at 9 milliwatt. Each patient underwent a detailed examination of the anterior segment and a customized cross-linking based on the NXT UVA algorithm was performed. All the patients were assessed at 1, 3, and 6 months for their surgical outcomes. So what we saw was that there was no significant haze noted on pentacam densitometry at the end of the 6 months. None of the patients had any loss of lines on the Snell's chart, and there was no statistically significant change in the endothelial cell count before or after the procedure. The efficacy was established by a stable keratometry at 6 months post cross-linking. A demarcation line was documented in 65% of our patients. Thus, we saw good clinical outcomes with stable topography, presence of a demarcation line, and no clinically significant haze. To conclude, what was known that standard cross-linking is not possible in treating keratoconus patients with thinner corneas. Various alternative treatment options are available, but they have their own limitations. What our study adds is that cross-linking can be performed in thinner corneas less than 400 microns. We provide a calculator which is simple and freely downloadable for use for everyone. This app will be an invaluable tool for delaying the need for a transplant in thin corneas.
Excellent presentation, Dr. Ritika. It is heartening to know the wonderful work you are doing at Narayan Netralaya. And I would like to invite comments from esteemed panelists. Any questions for Dr. Ritika?
There are no questions, but definitely it is a very, I'm very happy to see the innovations that are happening, and actually they're helping us in our daily life dealing with the patients of keratoconus, because we are at loss of words when we see these kinds of presentations, because all our residents also get inspired and the calculator is easily available. So that is a very important link I would rather like to know more about, and it's easily downloadable. So I'm sure my residents and all of us will be helpful. And I'm not a cornea person, so I can't comment very much on it, but still it was a very nice presentation, as well as the retina presentation also. So any comments from the retina people or the cornea people would be welcomed.
Ritika, I have a question for you. Yes, I just wanted to know this app, is it is it available, or how the residents or the, how they...
Yes, ma'am. So there is a link, which is a JSC calculator. I have shown it in the video and I'll share that link with you. So press on that link, it will just tell you to enter the thickness. So the thickness should be an epi of thickness. So whenever you have the thinnest TCT, you minus the epi. If you are doing a Schwinn procedure, which then you have to minus the epithelium and the stromal. So stroma and the epithelium should be minus at the end of the procedure. Whatever is coming at 9 milliwatt is your fluence time. So for example, the fluence will be given as like 7.80. So that means there's a 20-second excess. That means 8 minutes, 20 seconds.
Right.
So like that.
Any questions from panelists for Dr. Kavita and Dr. Suma? So moving on to the next presentation, we have Dr. Jyoti Shakarwal. She will be presenting a video on bleb rescue operations. Dr. Jyoti.
Good morning, all. Thank you, DOS, for giving me this opportunity. I'm sharing my screen. Yeah, is it visible?
Glaucoma surgery is fairly common with average glaucoma surgical rate 139 per million per year. Trabeculectomy is the gold standard surgery with ideal bleb which is diffuse and mildly vascular. However, the blebs may become thin, cystic due to overuse of antimetabolite and may have accompanying scleral thinning. When we come across cases which have a frank leak from the bleb or a large overhanging bleb, a careful examination of the case should be done for appropriate treatment. As in this case, the patient who had a frank bleb leak was taken up for surgery. The necrosed conjunctiva over the bleb was marked with the help of a surgical marker. Necrosed conjunctiva was resected and conjunctival advancement was done over a bare sclera. Bare sclera technique has chances of post-repair fibrosis. Therefore, there is another technique which can be used. It is called bleb-sparing epithelial exchange. Here, the conjunctiva surrounding the bleb is separated from the bleb area and undermined. The necrosed conjunctiva over the bleb is stained by trypan blue dye and removed from the underlying bleb structure. As we can see that the overlying epithelium can be easily peeled off from the underlying bleb structure. Total epithelial peeling is obtained. In patients who have full thickness scleral defects as seen on UBM, the necrosed conjunctiva is removed from around the bleb area, which reveals a full thickness defect in the sclera at the limbus. The surrounding conjunctiva is undermined. Here we use a trephine punch of the size of the defect to take out a scleral graft. The scleral graft is tucked into the defect after gently undermining the area. Ologen is sutured over the area of thinning. Ologen acts as a spacer for the bleb to function. Conjunctival suturing is completed. In few cases of thin cystic blebs, the scleral thinning may become evident only after the conjunctiva has been removed during the surgical procedure. Here, a partial thickness scleral flap is raised behind the scleral thinning up and rotated upon itself to cover the thin area followed by conjunctival advancement. Here, a pedicle conjunctival graft is taken and sutured to cover the area. message is that PLEB-related complications should be examined carefully to identify the cause. Surgical technique should be best suited to each individual case.
Excellent presentation, Dr. Jyoti. Really nice to see a young ophthalmologist like you doing such wonderful work. And I would like to please stop sharing the screen, Dr. Jyoti, so that, yes. I would like to invite any questions from the esteemed panelists to Dr. Jyoti.
Jyoti, what is another important take-home message which you have done yourself, but should be in your talk? Always keep a scleral patch graft as a backup whenever you're opening a PLEB. Because if that's not there, you can be actually sometimes in a really big soup. But all I want to say is I'm really happy to see you've done a wonderful job. You've been very discreet with your case selection and also using the methodology that you've used. And the partial thickness sclerograph is a really good innovation. It's from the patient's own body. So it's a perfect tissue to match with. And when the conjunctiva is short, you've been smart enough to take a patch graft and not just do that thing, because that conjunctiva would have retracted and gone back and wouldn't have even this thing. And in the other patch graft, you have used collagen to buttress because there were only 2 sutures on the sides. So the round thing could have, like tilted up and all that. So that was a really good thing. I'm very happy with you, child. Keep on doing it. All the best.
Thank you, ma'am.
Thank you, Dr. Jyoti. I have one question for Dr. Kavita. Ma'am, you had shown us a video of patch ILM graft for a failed macular hole. So what are your visual outcomes in such cases?
Oh, hi. Yes, visual outcomes in such cases are usually grave. They're not very good. That is why the case selection is very important. And one of the preoperative investigations, what we do in these cases are things like autofluorescence, which helps us to know the underlying RPE. So like in this case, it is a very long-standing hole and the patient had already undergone a primary surgery. So mostly the holes close by fibrosis, but it is also postulated that photoreceptors may follow this gliosis and some amount of visual recovery is anticipated, but not really, not much. Maybe 2 to 3 lines, 2 lines.
Okay, ma'am. Ma'am, it is very challenging that this patch graft stays at its place. So what do you do so that any procedure you adopt so that they stay in place? Because most of the time they displace from their position.
Yes. There are many case reports where you can use many adjuvants like PFCL and stuff. But in my case, I think what we usually do is we just switch off the infusion. So what happens is this friable thin piece of ILM, it doesn't float. And DDMS being a very non-traumatic, you can just gently place it and gently tuck it under the edges of RPE so that it doesn't move. So just switch off the infusion when you're handling the ILM.
Okay, ma'am, that's a good tip. Ma'am, one more question just for my curiosity. How many cases of ILM patch graft you have done with a failed macular hole, and how have been your results till now? Anatomically, have you achieved closure in most of them?
Anatomical closure is there, definitely, Dr. Ashu. But coming to the visual recovery or can I meet the expectations of a patient who is going in for a second surgery? It's challenging, I would say.
Okay, ma'am. Wonderful presentation by you too. Thank you, ma'am.
Such an opportunity.
So it has been an enriching experience seeing all these wonderful presentations and listening to the discussions. A big thank you to all the speakers and panelists. We come to the end of this first session of video presentations. Now, I request our dynamic secretary of WAS, Dr. Mohita Sharma ma'am, to conclude this session with her keynote address. Mohita ma'am.
Yeah. Hello, everybody. Good morning. Very happy to see you all here. And thank you to DOS and to Dr. Namrata Sharma for giving us this opportunity for WOS to be present as part of DOS also. So it's a very well done conference. And we are very happy to be holding this session here. So today I would like to tell you what WOS is currently doing. You know, WOS has been known to be a society which does different things, because we always felt that there are so many societies, so many conferences, so many meetings all over. Let's do something which would make a difference in the professional lives of women ophthalmologists. So that's what has been always our aim, and that is what I will tell you about today. If I share my screen. Sound, I'm not able to open my screen. Is that option open for me? Yeah. So let's look at what, is my screen visible?
Yes, ma'am.
Yeah. So let's look at, so sorry. So let's look at what WOS has been doing currently. Now there is a program which we are doing. Currently, we are doing 3 programs. The first thing that we are doing is Meet the Mentors. Since there are so many webinars happening all around, we thought, let's do something which is one-on-one. You know, so we invite mentors as volunteers every month. There are 4 to 5 volunteers as mentors, and these are men as well as women mentors. And we invite applications from mentees, and there is a one-on-one session with the mentor for 1 hour. So basically you can choose your mentor, because mentor-mentee program has been one of our important programs. So the basic idea is that you can choose your mentor, and whichever mentor you choose, you spend 1 hour with the mentor, and you can discuss with the mentor whatever you want as a professional upgradation in your life. So this becomes a 1 hour connection, and this is followed by a connection later also throughout the year, maybe throughout life. Whenever you want, our mentors are willing to provide you support in whatever form you need. So this is a very successful session, and we find that the mentees are really benefiting from it. And we also want that more and more WOS members should actually apply to be mentors as well as mentees, so that this program can be taken forward in a better and better way.
Mohita, use the arrows on the screen, left.
Okay. So the next thing that we are doing is another program called Rendezvous with Life. Now, this is again a similar kind of a program being done by our very active member, Dr. Aarti Nangia, where again, mentors are invited. And these are basically successful men as well as successful women in the field of ophthalmology. And they share how they reached where they reached, and they give tips to the members. And this is again something which is very, very inspiring when you hear these people talk. So this is another program that is being run on a regular basis. And the third program, which is happening currently, is the RED Group program. This is a rare eye diseases program. This is, you all might be aware about the Women in Research group or the WINAR group of WOS. And in this WINAR group, we are already carrying out research activities for the last 2.5 years. Now, we have recently launched a group called the RED Group, or the Rare Eye Diseases Group. And the whole idea about rare eye diseases is that there is nothing which is happening in India currently where work is happening on rare eye diseases. So was intended to start something to do with something in which we would be making registries for rare eye diseases and then studying these rare eye diseases, plus giving treatment to the patients who are suffering from rare eye diseases. So the concept of WOS and of WINR, or Women in Research, is such that for research, we feel that it is not that you have to be working in an institution and then only you can do research. Research is open to all members, whether they are solo practitioners or whether they are working in government institutions, they are working in private institutions, they are working in charitable institutions. So we have invited everybody to be a part of Women in Research and of this RED group also. And the RED group is all about collaborating, research, and reporting unique disorders. We are all aware that there can be rare and genetic eye diseases starting from the lid and the cornea going up to the retina. And there are registries which are existing across the world where these rare eye diseases are compiled and work is done on them. There's a very important registry which is there in Europe by the name of ERNI. Similarly, there are registries in Africa as well as America, but in India there is no such registry which is occurring at which is happening at the national level. Though institutions have registries for some institutions have registries for rare eye diseases. And this is an article in American Academy of Ophthalmology, which talks about clinical registries in ophthalmology. And it says that because of the digital technology and increasing use of electronic medical records, there has been a dramatic growth in large clinical data sets. Hence, there has been a rise in the number of registries that are also being made. And because the data is all available, and especially this is happening in the last few decades, and that's why we felt that India also needed to work on this. So what is the RED group ultimately planning to do? We will be creating national registries. We are initially starting with 5 diseases as a pilot, and then we would be for 6 months, and then we will be taking it forwards with more diseases. There will be genetic testing. Now, once the national registries are formed, we can do genetic testing and therapy. We can do counseling. We can do rehabilitation. We can form support groups, and we can be working on low vision aids. So for this, the future is in collaboration. So we will be looking for grants, which we are already doing, and we are almost there, and we are looking for collaborations for PhDs in universities. So these are all the activities that WOS is doing right now, apart from the webinars which are happening at the state level. And these are monthly webinars being conducted by various state chapters of WOS. So we all invite you to be a part of these initiatives, whether it is Rendezvous, or it is Meet the Mentors, or it is Women in Research, or it is the state webinars. We want all members to be actively involved in this, because ultimately the aim of WOS is to give opportunities to those who have not been able to perform to their full potential because of because of their personal challenges, which all women have to go through. And and along with that, we also always want to invite those women who have been very successful in their career, because we want them as mentors and role models for rest of the women. Thank you so much.
So wonderfully summarized, ma'am, and definitely RED is a mammoth task, the initiative for which has been taken by WOS, and we wish all the best to this, because it will be one of the kind in the world, and maybe in future the largest database in the rare eye diseases. So I congratulate WOS for this. And we will move on to our next session, that is difficult case scenarios. I hand over to Dr. Maya Hara to conduct the next session.
Yeah, thank you, Dr. Ashu, for wonderfully conducting the first part of the WOS session and being on time. So moving on to the second part of the WOS session, as we have difficult and challenging cases in this session, and we have 4 talks over here. I will first invite the eminent panelists for the sessions. We have Dr. Aarti Nangia, and she is the state chapter head of the WAS for Haryana chapter and senior consultant at the Center for Sight. Also, we have with us Dr. Chetra Jayadev. She is the senior consultant of Vitro Retina at Narayana Nethralaya, Bangalore, and very prolific academician, and she is also a joint secretary of AIOS presently. We also have Dr. Alpa Atul Purbia with us. She is heading the state chapter of Telangana. And we have Dr. Swati Fulijile from RP Center AIMS. She is associate professor over there in strabismus and pediatric ophthalmology services and neuro-ophthalmology services as well. Also, we have Dr. Smita Agrawal from UP chapter of the WAS, and she is a private practitioner at Muradabad. So I welcome you all on behalf of WAS. And there is a slight change in the order of the talks. With permission of Dr. Suma, can we have the first speaker, Dr. Rajwinder Bhattal, because she has another talk in the different session. With your permission, ma'am.
Yeah, sure.
Yeah. So I invite Dr. Rajwinder Bhattal for her talk on choroidal osteoma with CNVM. She is a consultant in Adesh Eye Hospital in Bhatinda. So you can start sharing your screen, Dr. Rajwinder.
Okay, I am sharing my screen.
Yeah.
I'm audible, ma'am?
Yeah.
I am audible, ma'am?
Yes. Yes, you are audible. Please share your screen.
Hello?
We can hear you, Dr. Rajwinder.
Hello? My screen is visible?
No, you are. Yes, now it is visible.
Okay, ma'am. Is choroidal osteoma with CNVM treated with ranibizumab.
You can make it full screen, please.
Is it visible, ma'am? Now, is it visible?
Yeah, please.
So my topic is choroidal osteoma
Yes.
treated with ranibizumab. Choroidal osteoma described by Guess et al. Is a benign ossifying tumor with mature bone replacing the choroid. It is usually unilateral, slightly irregular, elevated yellow-orange lesion in the juxtapapillary or macular region that typically occurs in healthy females who present in their second to third decade. Associated complications such as choroidal neovascular membrane, subretinal fluid, hemorrhage, and photoreceptor loss overlying the deossifying osteoma are factors responsible for the poor visual acuity. So the focal choroidal excavation is a recent SD-OCT finding. It is a localized area of choroidal excavation found in correspondence with the tumor decalcification in the absence of anisocleral ectasia and staphylomas. A 28-year-old female presented with chief complaint of diminution of vision with metamorphopsia since 2 months. Her best corrected visual acuity was 20 by 20 in the right eye and 20 by 600 in the left eye. Left eye demonstrated a flat, opaque, peripapillary orange-yellow lesion above the optic disc, 5-disc diopter into 3-disc diopter in size, with well-defined margins with the CNV at the macula. Pigmentary changes on the surface of the lesion suggestive of early decalcification and RPE trophy were noticed superior temporal to the disc. Fundus of autofluorescence shows the diffuse peripapillary hypofundus autofluorescence area corresponding to decalcification. Preserved fluorescence in calcified region, and CNV is also seen with irregular fundus autofluorescence in the areas of CNV with high autofluorescence outside the edge of the lesion. So fundus angiography was done, which showed the early patchy hyperfluorescent choroidal filling with the well-demarcated hyperfluorescent lesion in the subsequent frames, and late hyperfluorescence due to staining over the region of choroidal osteoma. So well-defined area of hyperfluorescence at the macula with increase in size in later phases suggested of a juxtafoveal CNV. So NCCT of orbit also showed the plaque-like calcification in the posterior pole of the globe in the region of the juxtapapillary region. And B-scan ultrasonography of the left eye also showed elevated choroidal mask with a high reflectivity and acoustic shadowing, giving a pseudo-optic disc appearance. OCT confirms the CENV with the altered foveal contour and the distortion of foveal architecture by the hyperreflective complex and FCE on its nasal margin. EDIA OCT was done to see more deeper, a well-defined subretinal hyperreflective material corresponding to the CNV with the streak of fluid. There is a depression in the RPE, Brooks membrane complex, and suggestive of conforming FCE adjacent to the edge of the CNV and over the areas of tumor decalcification. This is the 3D of FCE comparing it with the right eye. So the pre-injection, there was subretinal fluid, there was the CNV with the streak of fluid. And after 3 injection of ranibizumab monthly interval, the vision improved to 6/6 and it is maintaining since 6 months. And on the OCT, we can see the resolution of the subretinal fluid and the foveal contour regain its normal architecture. So the conclusion is our case had a rare combination of conforming type of FCE with CNVM with choroidal osteoma. Must be clearly looked for CNVM. Fundus fluorescein angiography really helps in picking up CNV. So these are the all collage of all the photographs. Thank you. Thank you.
Okay, thank you, Dr. Rajwinder. You can stop sharing your screen now.
Thank you. Thank you.
Yeah, thank you. I would request from our eminent panelist, Dr. Chaitra Madam, to give a valuable input on this case, please.
Thanks, Maya, for the opportunity, and DOS as well. I think it's a wonderfully conducted conference. Thank you, Rajwinder, for your case. I have a couple of queries. First and foremost, are you trying to make a correlation between the FCE? Did it have any bearing, or is it just an incidental finding? My second question is, why would you want to do a CT scan for a diagnosis that could have been made clinically or on B scan? Is CT scan mandatory? I understand it used to be being done for osteomas before, but do you think it's required now to do a CT scan, or was it for a differential diagnosis? Okay, I think the screen is frozen. Doesn't seem to be moving.
Maya, just get her attention.
Yeah, Dr. Rajwinder.
I don't think she's there anymore. Anyway, so just to quickly add up on Rajwinder's case, CNVM is an extremely known, well-known complication of osteoma, and osteomas, unless they're actually involving the central visual field, the posterior pole, they don't normally cause major visual hassles, except when there's a CNVM. So that's the most important thing about following up these patients on osteoma. And also, they are very clinically diagnosed now with the OCT and the B scan. They have very, very typical findings. Most often, we also can just do with an OCT for even detecting a CNVM and for the follow-up of treatment, which respond very, very well to anti-VEGF. So the two main causes for vision loss in patients with choroidal osteoma remains development of a CNVM and its complications. And the second one would be if the decalcification involves the fovea itself. That's when you can have decreased vision in these patients. And since they're young patients, young females, very, very important that we follow them up when there is vision-threatening chances. Thank you. That was my input for this case.
Thank you. Thank you very much, ma'am, for your valuable inputs and your time.
Maya, can I add something?
Yes,
Only for a theoretical interaction, because of course my experience is not of the retina cases of the sorts. What I understand is very rare. Chaitra would just elaborate on that. And it's like a choriostoma, which is like something which is not in a healthy tissue, an unhealthy kind of association. And is there a vitamin D or any kind of hormonal association? Because there's a lot of calcification, and I think the injections are only causing a decalcification, and that's how the vision improves, because how else a bone tissue can be removed from such a vital area. So
yes, so it is, they have done, the thing is, it's not a very common phenomenon for them to have done a correlation. Many hormonal studies have been done, but they have not found an exact correlation so far. As far as decalcification goes, that is one way to stabilize the disease. But then if the decalcification itself affects the fovea, they have shown that the vision goes down. So there have been various other ways to bring about the decalcification. Previously, even PDT has been used just to make sure that there is some amount of decalcification. But the best prognosis remains giving an anti-VEGF for these patients who develop a CNVM. Otherwise, most often it's just follow.
Yeah. Very interesting case taken up, yeah.
Yeah. Thanks, Dr. Aarti and Dr. Chaitra. So if we have any other question from any panelist, or we can move on to the next. I think we can move on. So next I invite Dr. Suma Ganesh, madam, and she is the Deputy Director at Shroff Charity Eye Hospitals, and she is heading the pediatric ophthalmology and strabismus services over there. So she'll be presenting an ESO-DRS case with abduction deficit. Yes, ma'am. You are muted.
Okay. I would like to thank WAS, and it is good to be among all of you. I will present a case of ESO-Duans with an abduction deficit and having -4 abduction deficit. So I would do, I'm planning to present a case with superior rectus transposition. So what is Duans? We are all aware that it is an absent or partially developed abducens nucleus and nerve. And here we find that there is branches of the oculomotor nerve, which is redirected to the lateral rectus muscle. So normally we have all, I think in our practice, done esotropia with Duans, like an ESO-Duans with a face turn. When they have a limitation in abduction, we do a unilateral or a bilateral medial rectus recession, which is preferred in an ESO-Duans case. So this case with an ESO of around 25 prisms and with an abduction deficit of around -3 with a forced duction positive, medial rectus recession was done, and we get a very good result, the face turn is corrected and also the esotropia is corrected. But the problem is parents always want what next, like can the limitation of abduction be improved? Can the eye still go out? And we're always been saying that, no, we cannot do anything for the eye to go out, just leave it alone. So the medial rectus recession has always been successful, that it improves the head posture, it corrects the strabismus, it maintains the good stereo acuity also. But there's always a problem that parents are still not happy with the abduction limitation, and they find, can we do anything to just improve the small abduction deficit? And we can also, the medial rectus recession does not improve the range of BSV. So Johnston and Crouch, there's a Crouch procedure which described superior rectus transposition, transposing only the superior rectus muscle to the insertion of the lateral rectus muscle along the spiral of Tilloch's. So this advantage is that it helps to, it improves the abduction and can also improve the binocular field of the patient. So this is a case with a face turn to the left, around having 25 prism diopters for distance and near. And there was no globe retraction, severe globe retraction, and there was no upshoot or downshoot, which is normally seen if there is severe globe retraction. FDT was negative on table, so a surgery was planned, medial rectus recession with a superior rectus transposition. Now, superior rectus muscle, so in this, I've done a fornix incision. This is a superior temporal fornix incision, and you take around 8 millimeters from the limbus. Now, when you're hooking the superior rectus, one has to take care that we do not include the superior oblique in it, because it's you have, when you're just swiping it, you may include the superior oblique. We have to be very careful when cutting, when we are isolating the superior rectus. The rest of the procedure, like the muscle, you are taking first a partial bite over the muscle, and then a full thickness bite. So this is how we are isolating the superior rectus muscle. Now, VRT or the vertical recti muscle transfer is also done in 6th nerve palsy, like both the superior rectus and the inferior rectus are transposed, but that is a palsied muscle. The 6th nerve is not, it's palsied. Now here is a case of Duans where we know there's abnormal wiring. So always there's an apprehension whether transposing the vertical recti will cause a problem, because will there be again a vertical deviation which is seen after the surgery when you are just planning to improve the abduction. So this is where it is transposed to the edge of the, to the insertion of the lateral rectus. Here you can see that. So you are measuring it along the spiral of Tilloch's. So this muscle is now present near the lateral rectus and along the spiral of Tilloch's. Now to augment this so that you can get more abduction, improvement. So you take a bite with the lateral rectus and the you take a bite with the transposed superior rectus. So this is a non-absorbable suture. This is called as a posterior fixation suture or the Foster's method, where you are fixing the globe, fixing the both the muscles you are tightening, so that you can augment the transposition. Then you suture the conjunctiva with the 80 Viper. So post-operatively, this is what you see, that there is ortho and there is an improvement. It is not total improvement, but there is an improvement from a -4, like it was not going at all beyond midline, to now it goes to around -2 beyond the midline. And there is some improvement in the binocular field. So in a similar case where only there was a 10 prisms ESO in the primary gaze, but an abduction deficit was there, you can see that a -4. We can just do a superior rectus transposition because there's not much of ESO. So this is the result with the no, and we can see that there are no vertical tropias created or no torsional problems created with this procedure. Of course, we have not done many cases, and this is the third case again. Now here we do a medial rectus recession. So what I find is that if you have more than 15 prisms, you need to do a medial rectus recession along with the SRT. You cannot do it just an SRT if the esotropia is large. So there are many papers published. It was, but a lot of papers they discussed of problems of vertical tropias and torsion. But we have seen that you have the case selection is the crux, that it should not have a very bad globe retraction or a severe globe retraction. You should not have upshoots or downshoots. If you do not have these, of course, the results are very good. So SRT is with or without medial rectus leads to better improvement in the primary position deviations, correcting the head posture and the abduction deficits with less complications. But appropriate cases should be chosen. Thank you.
Thank you so much, ma'am, for depicting such a wonderful surgical technique. And these are really some challenging cases. I would request Dr. Swati Fulichale from RP Center AIIMS to comment on this case.
Yeah, good morning, everybody. And I thank WAS for giving me this opportunity. This is my first association with WAS, and it's a pleasure to listen to all these young ophthalmologists, and indeed very interesting cases going on. Ma'am, it's always a pleasure to listen to you as well. And DRS, as we all know, is one of the most complex strabismus to manage. Whatever you may do, you may never satisfy patient completely. So this was indeed an interesting case. And as ma'am, Dr. Suma Ganesh has rightly pointed out, the case selection is the most important key if you want to do superior rectus transposition. And yes, there should be no retraction, no upshoots, no aberrant degeneration. And the squint amount of deviation should be very, very minimal, say around 15 to 20 prisms to get good results. If you have retraction, ma'am, I would like to hear your thoughts. How would you manage if you have, severe retraction in such cases?
Okay. No, in severe retraction, of course, I would not do a SRT, superior rectus transposition. I would either do, like, suppose if there's a severe upshoot, I would do a lateral rectus bisplit. Like yes. We have the lateral rectus, you can split it and you can position it so that the globe does not move up and down, like the brittle effect which is there. So you can do a lateral rectus bisplit. Or if you have a large exo, you find, then you can even do a large recession of lateral rectus and medial rectus together, which can also take care of the globe retraction.
Right. And so, how are your results comparing with VRT in these cases? You can do PPR.
I would not do VRT in these cases because transposing the vertical recta in a case with an abnormal, with a, this sort of disinnervation, I will not do VRT. There are papers published of, like, suppose if you have a hypo and you can do superior rectus transposition, and if you have a hyper, you can do inferior rectus transposition, yes. Like single vertical recti transposition. Yes. I think that works. And there are published, I have not done personally inferior rectus transposition, done superior rectus transposition. So it is also working in 6th nerve palsy. Along like VRT is when both the vertical recti are transposed to the lateral rectus. And in those cases, in 6th nerve palsy, I would do a VRT, but I won't do both superior rectus and inferior rectus in a case of Duane's.
Not even partial?
No, not even partial. Otherwise, I think what you can do is like you can just, you can just disinnervate the lateral rectus slightly, and then you can do a partial. Because I've seen that they become more the eye become more smaller cosmetically. See, ultimately even the parents look at the cosmetic appearance. It's not only like they are always after their thing that the eye is still looking smaller, the eye is still looking, they're comparing always the eyes. So
yeah, thank you, ma'am. Due to the paucity of time, we have to restrict the
sure.
discussion a bit. Yeah, thank you. I
Thank
request
you.
Dr. Iram to share her screen, please. She is the next presenter. Dr. Iram. Dr. Iram is a very active WAS member from UP State Society, and she is doing, consequently, 2 years, she is doing the mentored life surgery and getting awards for that in WAS. Yeah.
Good morning, everyone. I hope you can hear me.
Yes.
I would like to thank WAS and DOS for providing me with this opportunity. My topic seems to be quite out of place in this particular session, but because surgical aphakia management in itself is not difficult or a rare entity, but the circumstances in which we usually manage such cases are usually quite challenging, and especially if you are an anterior segment surgeon and a solo practitioner too. So I thought, why not a short presentation on this? So I have no financial interest in this, and the presentation starts with a smooth sailing story of a routine cataract surgery until an unwelcome complication arrives and the surgeon lands up with an aphakic patient in the OT. Now, what options do we have? Ideally, the best place for IOL implantation is obviously in the capsular bag, but when it is not possible, then the options we have for primary or secondary IOL implantations are, we all have had our experiences with ACIL implantations and its late complications. And for the SFIOLs for the last 2 decades have been quite a novel surgery for correcting the surgical aphakia, but it is a relatively specialized surgery. So today I'll be discussing in brief the posterior iris claw implantation. So the history goes back to 1954. It has quite a long history. We all know the indications for posterior iris claw implantations are senile cataract with severe zonular dialysis, traumatic cataract, secondary implantation after aphakia, congenital or juvenile cataract with subluxation, and the contraindications are recurrent or chronic iritis, severe iris atrophy, uncontrolled chronic glaucoma. So what do we need is an iris claw lens, an inclination forceps, and an inclination needle, or you can use a Sinskey blunt Sinskey. This is how the IOL looks like, and it comes in various sizes. This is the IOL holding forceps, Clayman forceps, and this is the way you hold the IOL with the forceps, and the forceps pointing towards the inclination, towards the claw of the lens. So what we do is we make 2 side port incisions posterior to the limbus, and then we confirm if there's any vitreous, we need to do an anti-vitrectomy, and then you can go ahead with your scleral tunnel. Now I'm going to show you a very short video of the surgery. I've taken it from YouTube because it looks quite genuine to me. So let's have a look. This is how you align the IOL in the AC, horizontally in the AC, and then go from the side port incision, hold the IOL, push the claw of the lens behind the iris, and then feel it with the Sinskey and tuck it, enclave it at mid-peripheral iris. It seems quite unpredictable and difficult, but it is a relatively simple step and it enclaves very easily. Then you form the AC and then again go from the other side, pull the IOL slightly to the side and then push the other claw of the lens behind the iris and then tuck it at the mid-periphery. This is the end of the surgery. After that, you can tap the IOL behind the iris, and this is all. So as compared to SFIOL. In the first case, you'll have a feel of the surgery, and after that, it will be a matter of just few minutes if you are planning a secondary IOL implantation. Obviously, you need to give a correction of -1 diopter power for a plano target, and you need to perform a peripheral idectomy. This is a small table for comparison from sclerofixated IOLs. The retropupillary claw implantation is an easier, shorter, and giving earlier visual rehabilitation to the patients with no significant difference in the complications, in the common complications of IOL dislocation, CME, and retinal detachment, and the complications specific to iris claw lenses are iris atrophy, pigment dispersion, ovalization of pupil, and endothelial cell loss due to the surgery. So, iris claw lenses have now matured to a stage when they can be used with considerable safety and efficacy, and the new designs as well as the evolution of surgical techniques and instrumentations have made them the best option for primary or secondary implantation in aphakic eyes. It is easier, shorter, and safer than SFIOL implantation. SFIOLs, though closely resemble the anatomical position of the lens, has a steep learning curve and a long surgical procedure, which is considered a major disadvantage. So lastly, coming to the log, if you do not have an intact anterior capsule and you have sufficient iris tissue, then you should go for iris fixated IOLs. If you do not have sufficient iris tissue, consider pupilloplasty. If pupilloplasty can be done, then you should go for iris fixated IOLs. Otherwise, you can go for SFIOLs. So recently, the trend is changing, and more and more surgeons are going for posterior iris claw IOL implantation.
Thank you.
Thank you for your patient
Dr.
listening.
Yeah, due to the shortage of time, we'll keep the discussion later. And I would invite the next speaker, Dr. Kriti Gupta. She is a fellow from Narayana Netralaya, Bangalore in Cornea and Refractive Services. Dr. Kriti, please go ahead with your talk.
Morning, everyone. At the outset, I would like to thank DOS and WAS for making me a part of their wonderful session, which is the difficult case scenario. So I'll be talking about circadian rhythm and biological clock, its impact on unhappy patient post-refractive surgery. So 35-year-old male visited us with complaints of uniocular vision, blurring of vision in the right eye. He underwent an uneventful refractive surgery, that is femtosecond LASIK in both his eyes 1 month ago. And his post-operative recovery and post-operative period was completely uneventful. He underwent an uneventful surgery. His uncorrected visual acuity at 1 month post-surgery was 6.6 in the right as well as the left eye. So we went ahead and did a detailed anterior and posterior segment examination which was within normal limit. His topography, epithelial maps were also within normal limit. We went ahead and did a test for his DLI on the eye trace, which was also normal. The point spread function was also within normal limit. Then we thought probably it could be an orthoptic issue, and we published the same in the recent issue of IGEO. So in order to unmask any non-strabismic binocular vision anomalies that the patient may be having pre-existingly, we went ahead and did a binocular single vision assessment for him, and that was also within normal limit. So this got us thinking, was there something that we were missing? What was the missing link? And why is the patient still having a blurred vision in spite of everything being normal? So we decided to dig deeper. That's when we thought we should go back and spend some more chair time with the patient. Let's talk to the patient. Let's retake the history. And while speaking to the patient, we realized that this patient was under a tremendous amount of stress. So all of this stress was coming out as a single symptom, that is, I can't see clearly. Although there were multiple small cues in his history that he had history of panic attacks which were associated with vomiting and nausea, and he was saying that because he can't see clearly, he's having these panic attacks. Then we went ahead and asked him about his job profile, and we came to know he had a very fairly abnormal job timing, more similar to a night shift worker. He used to work from 5 p.m. in the night to 5 a.m. He would use the screen throughout the night without taking breaks, and this was causing him to have insomnia and also sleepwalking. Apart from these medical issues, the patient was not having a very balanced personal life as well. So he was a US citizen who got recently married around 2 months ago, and he was unable to move back to his country because his wife was denied the US visa, and amidst this pandemic, he was stuck in a country where probably he didn't want to. So he was kind of ignoring all these small issues, and he was continuously blaming his symptoms onto the surgery, and he was saying it's all because of the surgery. Now, why do we say that his vision problems are not because of the surgery? Because we've done we've done our evaluation, and it was all within normal limits, and the anxiety has been shown to be associated with flashes of light or floaters, binocular vision dysfunction, and stress-related visual impairment. When a person gets a panic attack, there are multiple symptoms that he exhibits all throughout his body, and with the eyes we see that there is blurring of vision and dilatation of pupil. Now, this patient had an odd job timing from 5 p.m. to 5 a.m. that was deranging his normal sleep cycle and the biological clock, and there have been reports in literature associating visual impairment with circadian rhythm disorders. Now, since his work profile is similar to a shift worker, we went ahead and read the literature and this particular paper, which talks about shift workers and their health, their problems, and preventive action, very nicely highlights the fact that in the night shift workers, there is interference at several levels with human homeostasis and well-being. Also, shift workers are more likely to have irritability, nervousness, anxiety-related issues as compared to normal people, and higher difficulties in their family and social life. They're also more prone to having suicidal tendency. So we realized that this patient had something fairly odd, and all of these clues were pointing towards one particular direction, that he needed help, he needed professional help. So we decided to do a detailed counseling in presence of his close family, and his family was required because we needed to find out if there was anything else that we were missing out, a certain part of the history which the patient would not reveal to us. So during one of these counseling sessions, his wife told us that, doctor, at times he's also very suicidal. He talks about those. That's when we realized that this patient was in a very fragile state of mind, and we needed to take care of that. He was recently married, so we didn't want his marriage to be affected by his state of mind as well. That's when we explained him and his family the impact of deranged sleep cycle and anxiety on his vision. And since we did not want him to have a stigma, we refrained from referring him to a psychiatrist, as in we referred him to the psychiatrist without using the word psychiatrist. We told him that we are referring you to a neurobiologist because your biological sleep cycle has been deranged, which is leading to your panic attacks, and that could be a cause of your visual discomfort. And he visited the psychiatrist post-referral. He was started on anxiolytics, and 3 months later, there was improvement in his visual symptoms as well as his anxiety-related symptoms. And the patient returns back happy, and that was our whole point of going through the whole process and spending time with the patient. Thank you for your patient hearing.
Thank you very much, Dr. Kriti. Much neglected and very important aspect that we should all know. Any quick comment from the panelists? And I would request Dr. Neha to carry on with the next part.
Just a quick one. I think it's one of the most interesting topics you've taken up, and it's got to do with the sleep. Sleep is, I think, the most important thing. Neurobiologist is a great term, because we can actually sit back and counsel patients. And I was just looking at, of course, myopia with melatonin, sunlight exposure, circadian cycle, all this is correlating to a lot of etiology of a lot of diseases. So in this particular case, I was just wanting to understand, since the display is too much, because he being the shift worker, there's something to do with the blue light exposure more on those wavelengths of 490, 450 plus by the screens. And then that is why there's a lot of rave of wearing the blue light blocking glasses also. So just wanted to know if you kind of can highlight something on that blue light receptor concept and blocking it worth it.
So ma'am, this blue light concept has been brought about a lot by the optical companies, but there is no conclusive evidence or a proper study or a randomized trial which has been done to actually quantify or substantiate these results. But yes, preliminary studies do say that they help. So I would want to have a more substantial evidence to conclusively say whether the blue light glasses, blocking glasses would have helped these patients or not. But definitely reducing the contrast sensitivity and the settings of your laptop will help to an extent.
Fine. I think there's a
break from the work profile, as in rather than working continuously as he was doing for the 12 hours, he wouldn't take breaks. So again, the same rule of 20-20-20 can be explained to him. And all of these things, certain lifestyle modification could help him along with the help from the psychiatrist.
Correct. I think the lighting. So good topic. I just wanted it to be correlated with this particular patient. So you can work more on the blue light with this particular patient, and trust NN to come out with such innovative ideas. Great, Maya. Great topics. Yeah, you chose for this session.
Thank you. We are running very short of time. Dr. Neha, can you please invite the next speaker?
Thank you, Dr. Maya. After the wonderful session 2, it's a privilege to invite the panelists for the session 3. We have with us Dr. Namrata ma'am, who is an Honorary General Secretary of AIOS and DAWS, and is a Professor of Ophthalmology, Cornea, Cataract and Refractive Surgery at AIIMS. It's a privilege to invite Dr. Swati Tomar ma'am, who is Director at Swanetra Eye Hospital, Jaipur, and the Medical Director of Eye Bank Society of Rajasthan for last 15 years, and currently heading the WAS Rajasthan chapter. I would like to invite Dr. Smita Dubey ma'am, who is the head of Glaucoma Department and Department of Quality Assurance at Shroff's Charitable Eye Hospital, and has performed several thousand skilled microsurgeries for cataract and glaucoma. We welcome Dr. Reena Sethi ma'am, who is a cataract refractive surgeon and pediatric ophthalmologist at Gurgaon and has contributed as faculty at various prestigious conferences. Glad to invite Dr. Purvasha Narang ma'am, who is an alumni of LVPI and a consultant cornea refractive surgery and ocular services at LJ Eye Institute, Ambala. Dr. Prachi Grover ma'am, who is a senior eye consultant at Visitech and specializes in field of cataract, refractive and glaucoma surgeries. Glad to invite Dr. Upma Vasti ma'am, who is a vitreoretinal consultant at CL Gupta Eye Institute, Moradabad, and an active member of WAS of Women in Research, Winar Arm of WAS. For the first presentation, I would like to invite Dr. Prachi Grover ma'am to present her glaucoma potpourri. Dr. Prachi ma'am, can you please share your screen?
Yeah. Just give me a moment. Good morning, everyone. I'm here to talk to you about glaucoma potpourri. I can't move my slide. There's an issue.
Use the arrow to progress the slides.
No, I can't. It's not working. I'll Is my slides visible to you all?
It is visible. It's moving.
Yeah, thank you. Glaucoma is a multifactorial optic neuropathy characterized by progressive loss of retinal ganglion cells, which leads to reduction in thickness of RNFL and optic nerve head changes, preceding visual field loss. So early detection of glaucoma and treatment is important. So what are our current treatment goals? Current treatment goal is to reduce the IOP to a target IOP at a reasonable and affordable cost while maintaining the quality of life and preserving vision. So what is target IOP? It is the IOP at which no further damage occurs. So it should be individualized among the patients and both eyes in the same patient. It should be dynamic so that we can redefine it. So what do we have in our armamentarium is medical, laser and surgical treatment options. Medical being the mainstay of the treatment. But we need to balance our treatment. We tend to treat more individuals than actually requiring therapy, while we tend to undertreat once therapy is initiated. As a rule, we must start as a monotherapy. If monotherapy is not efficacious, then we should start adjunct therapies. So we need to look for whether the patient is affordable for the cost of reduction of per mm of IOP versus subsequent risk of progression. Ultimately, we have to treat the patient, not the pressure. Glaucoma's medication comes with a myriad of side effects like allergies, hyperemia. So we need to educate our patients. And the glaucoma also has a psychological impact like anxiety, depression, financial effects. So we have to educate our patients. So we can patients' adherence also increases to the medication by telling them about the gravity of the disease requiring lifelong treatment, regular follow-ups about the side effects, dosage, and the proper method of installation of the drops and the consequences of non-compliance with the treatment. As a healthcare provider, we can't neglect about the overestimation or the underestimation of IOP. And the pachymetry also plays an important role before diagnosing and deciding the treatment. Gonioscopy for the proper long-term management of glaucoma requires gonioscopy at appropriate intervals as the angle status is not static, because often the gonioscopy is being missed and angle closure patients were treated as open angle glaucoma. Optic nerve head evaluation is influenced by various factors, so it is an important skill to be expertised. Visual fields has its learning curve, so it must be, we should correlate it with clinically also. And OCT RNFL plays an important role in detection and progression of glaucoma, but we cannot be fooled with the red disease. We must correlate it with clinically. ASOCT plays an important role in identifying mechanism for angle closure glaucomas, and the bleb morphology assessment can be done better with ASOCT. So to summarize, glaucoma is a silent asymptomatic blinding disease with devastating consequences. It has emotional, financial, and psychosocial impact to the patient. Target IOP should be individualized, and other treatment modalities like laser, surgery, or glaucoma devices should be judiciously used. Timely referral to the glaucoma specialist for thorough evaluation and regular follow-up is important. Diagnosis of glaucoma primarily clinical. Investigation just aids in documenting progression. Thank you.
Thank you for the wonderful presentation, Dr. Prachi. Do we have any questions from the panelists? Is Dr. Sunita ma'am there?
Yeah, I am there. Actually, I was about to leave. I have another session. Yeah, but it was a very nice, comprehensive overview of glaucoma. So in glaucoma, it's very, very important to take a detailed history and do a comprehensive workup, and including all the investigations. Tonometry is very important. Along with that, the fields and optic nerve head evaluation, I think, they are extremely important. And setting, as she rightly said, setting up of target intraocular pressure, because some patients progress fast and some patients progress slow. So it is very important to set a particular target pressure for that particular patient. And then periodic evaluation of visual fields and optic nerve is important to predict progression and treat progression. So I think all these things are very important. So nice talk.
Thank you, ma'am.
Thank you, ma'am. Next, I would like to invite Dr. Spriha, who is a fellow at Narayan Nethralaya, Phaco-refractive fellow, to please share her screen.
Hi, good morning, everyone. I'm Dr. Spriha Arun. I'm a fellow in the Department of Cataract and Refractive Services at Narayan Nethralaya, Bangalore. Today, I'll be discussing the impact of mask on the ocular surface. I have no financial interests. So here we see a picture of the epithelial cell. This is done using a holotomogram, which is like an OCT for these cells. These are not real donor epithelial cells, but are corneal epithelial cells that we use in the lab. We can see the mitochondria, the Golgi bodies. It is a picture of a healthy epithelial cell and is not under any stress. So when we have healthy epithelium, the patient's comfort zone is good, which is given by an OSDI mini score. The tear film is perfect, which is given by the tear optics, a good epithelium, good nerve regeneration. The surface inflammation, which is from the tears, is absent. So we get a perfect vision and hence a happy patient. So this is a cycle of happiness, which we get when the epithelial cells are happy. However, when the COVID-19 pandemic hit, amongst the various changes that we had to make in our lives, one of the most major changes that we made was the wearing of a mask. So my study was to determine the impact of these masks on the ocular surface. When we wear the mask, as you can see in this picture, for a long period of time, there's increased level of carbon dioxide on the ocular surface, which results in hypercapnia. The hypercapnia in turn causes increased oxidative stress on the epithelial cells, which increases inflammation and hence dryness. So, like you remember, I had shown a picture of a healthy epithelial cell in my previous slide. In comparison to that picture, you can see these cells do not look healthier anymore. They appear shrunken and under stress. So the cycle of happiness that I discussed earlier no longer holds true for these patients wearing a mask. So how did we do the study and what proof did we have? In the past 10 years, we have collected tear and other ocular fluid samples for other various studies. We happen to have a group of volunteers whose tears we had collected in the pre-COVID era. So we decided to go back and exhume those tear samples and compare the immune profile of what was present before in the pre-COVID time and in the post-COVID times in these volunteers. We found interesting results. There was a significant difference in the OSDI and other tear film matrix values. We also saw that the tear cytokine and soluble factor levels, which were either low or within normal limits in the pre-COVID era, were found to be elevated or reduced in those similar patients in the post-COVID times. This is a schematic diagram which represents that higher amount of inflammation has an impact on the collagen matrix. The collagen matrix undergoes degradation. It has an impact on the epithelium. And thus, if we decide to take up these patients for surgery, it will not only impact the surgical outcome, but also the quality of life for the patient. How does it impact the surgical outcomes? The poor epithelium results in poor wound healing, thus a poor optics. The corneal nerves do not regenerate. These white dots that you see are dendritic cells, a sign of inflammation. So the quality of life for these patients becomes terribly poor. This is an example for a patient with a healthy epithelium undergoing surgery, whereas another patient with a poor epithelium who undergoes surgery. There are meibomian gland dropout that you can see here, which are not seen in the earlier picture. So we thought that this process can become more rampant as the time progresses and as we started to do surgeries. So what treatment approach did we have? It was the drops and the lubrication, and it is very well depicted in these two pictures where you can see how well the cells respond and regain their vitality and functionality once the ocular surface inflammation begins to be treated. Various algorithmic approaches can be used for the treatment of ocular surface discomfort, like one of the studies that was published in IJO. And accordingly, depending upon the grade and the severity of the disease, one can treat it. To summarize my complete talk, basically the mask wear causes hyperosmolar stress on the ocular surface, which causes poor quality of life due to high discomfort. Being surgeons, we have to keep in mind about the various surgical outcomes and be prepared for it. So we should emphasize on using and treating the ocular surface before doing any surgery. Thank you.
Thank you for the wonderful talk, Dr. Spriha. I would like to ask the panelists if they have any comments on the presentation.
Yeah, hello, Dr. Spriha. This is Dr. Ma. I'm sorry for my bad throat. I just want to ask two quick questions. First is the tears which you have compared the pre-COVID era. Are they from the normal patients or for some diseased patients?
No, ma'am. From the normal volunteers, healthy volunteers. We had tear samples.
Healthy volunteers. Okay. And the second question, how long you think you should prefer going for dry eye treatment before surgery as it's from the last slide?
Ma'am, 4 weeks should be the preferred time for treatment.
Okay, 4 weeks. Otherwise, a very, very, very nice presentation and very nice topic. Yeah.
Thank you so much.
So again, Spriha, I thought this is a very burning topic which has been there, for so many years. When microkeratome was there, then again, we used to think dry eye is there not because of severing of nerves. And then femtosecond came in and finally SMILE with, less severing of nerves and dry eye. And I'm sure this has compounded more with the lifestyle things which have been added to it, because so many thousands of refractive surgery, people have done earlier also, but these kind of problems have come now more so because we have the diagnostic tools to diagnose it, to treat it, and also because we are looking for it. Earlier, we never looked for it. So nice presentation. Keep it up.
Thank you.
Thank you, Dr. Spriya and Dr. Namrata ma'am. Next, we have Dr. Neetu, who is an associate director and senior consultant at SK Ortho and Eye Center, sharing her unusual case of hypertensive retinopathy.
Good morning, everyone. Am I audible?
Yeah.
I hope my screen is visible.
Yes, it is.
Okay, just a second. I'll just start the slideshow. I thank WAS and DOS for giving me the opportunity to present here. It's an unusual case report of hypertensive retinopathy. A 24-year-old female presented to OPD for the headache off and on since 2 months. There were no other associated complaint. On examination, the vision best corrected was 624. Color vision was within normal limit. Anterior segment, both eyes was normal. IOP was 16 and 18. Fundus examination, both eyes show marked degree of disc edema with flame-shaped hemorrhages, cottonwool spots, and hard exudates. And there was a macular star more in the left eye. And the fundus picture was suggestive of grade 4 hypertensive retinopathy. These are the fundus picture of the patient. And on systemic evaluation, patient had a blood pressure of 220 by 146, which was confirmed several times. Considering the age of patient, the diagnosis of secondary hypertension was suspected and referred to physician. On further investigation, the KFT was deranged. The urea came out to be 89 and the creatinine was 9. LFT, coagulation profile, serum electrolytes, or ECG, all within the normal limit. Renal ultrasound showed small kidney than the normal with the loss of corticomedically differentiation and increased echogenicity. So diagnosis of chronic renal failure was made and patient was started on dialysis twice a week. And after 4 to 6 months, the visual acuity of the patient improved to 6/9, both eyes after the normalization of the blood pressure, and now she's planned for the kidney transplantation. And discussion: hypertension is a disease which affects 1 million of the individuals in the world, and it is a leading cause of the death. 1% present with hypertensive crisis. In young adults, secondary cause of the hypertension must be suspected, and renovascular disease is one of the leading cause, accounting from 0.2 to 32% of the cases. Pathophysiology of the hypertensive retinopathy is retinal blood vessels have a distinct feature that differentiate them from the other vessels. That is absence of the sympathetic nerve supply, autoregulation of the blood flow, and presence of the blood-retinal barrier. So whenever there is increase in blood pressure, this will cause a vessel to constrict initially, and further rise in blood pressure will cause compensatory tone, causing damage to the muscle layer and endothelium. This is a flowchart depicting the pathophysiology. This is systemic chronic hypertension leading to arteriosclerosis, causing narrowing of the retinal arterioles, causing retinal ischemia, hypoxia, increased capillary permeability, and leading to focal retinal edema, retinal hemorrhages, corneal spots, and hard exudates. The grading which we follow is the Keith-Wagner grading for the hypertensive retinopathy, in which grade 1 is the mild generalized arterial narrowing, grade 2 is a definite focal narrowing with AV crossing changes, grade 3 is the retinal hemorrhages, exudates, corneal is the retinal, choroidal, and optic nerve changes secondary to acutely elevated blood pressure. And the features are retinal arterial spasms, superficial retinal hemorrhages, corneal spots, serious retinal detachment, optic disc edema, and associated feature are RPE changes, optic neuropathy, stroke, kidney failure, and encephalopathy. The other changes which we see are Elching spots. These are the black spots surrounded by the yellow or the red halo. And the secret streak, hyperpigmented flecks arranged linearly along the choroidal vessels. Coming to the management of malignant hypertension, lowering the blood pressure in a controlled manner to a level that minimizes the end organ damage. The blood pressure should be lowered in a slow, deliberate, controlled fashion to prevent the end organ damage. Too rapid decline can lead to ischemia of the optic nerve head, brain, and other vital organs, resulting in permanent damage. From systemic point of view, the diagnosis of malignant hypertension crisis represents medical emergency. If left untreated, mortality rate is 50% in 2 months. And most of the patients resume normal vision. On rare occasion, the vision loss could be due to the RPE changes or optic atrophy due to the prolonged papillary edema. Take-home messages. This case highlights the importance of correlation of ophthalmological manifestation with systemic abnormality. All systemic diseases need multidisciplinary approach. Early diagnosis and timely treatment can save or better lives. Thank you.
Thank you, Dr. Neetu. Any comments on the presentation?
Yeah, again me, Dr. Upma. Dr. Neetu, it was a nice comprehensive view of hypertensive retinopathy. The most important line that I found is you have mentioned in the discussion, it is no rapid decline. Actually, this is very important thing to think for. And one thing that I want to add is the recent classification of hypertensive retinopathy, which has included the clinical aspect also. So this is actually like mild, moderate, severe, and malignant. So Keith-Wagner is an old one, and it is associated with the clinical impact that is actually including the possibility of the heart attack. So with the malignant hypertension, it is around 50% mortality rate. So the cardiologist referral to the of these patients are actually now mandatory, so that to, or in fact the patient's counseling also, because the usually patient doesn't take it very seriously, because in many of the time though these people doesn't know that they are having hypertension. So the cardiologist referral from our point of view is very, very important, because there is a very high mortality rate, around 50% mortality with malignant hypertension and the stroke. Yeah. Thank you.
Okay. Thank you, Dr. Upma ma'am. Next, we have Dr. Jayashree, who is working as a consultant at Tejpur Eye Hospital at Assam, presenting her topic. Dr. Jayashree, please share your screen.
Yeah. Okay. At the very outset, I would like to thank WOS and DOS for giving me this opportunity to be a part of this virtual platform today. So I'll be dealing with a non-academic topic, and maybe I am the only one who is talking on a non-academic front. So this is a topic that deals with something that we might have faced, that we are facing, or we are bound to face somewhere in our lives, that is balancing our professional roles and our personal goals. Now, when we talk about personal life, we are actually talking about soft things like emotion. We are talking about love, feelings, family relations. And when it comes to professional life, the words become a bit heavier. That is work, target, money, and professional relations. Now, it is all about balancing these two responsibilities. We might have our own meaning of work, responsibilities, achievements, and goals, but how we balance these two roles is very important, especially for women. Now, professional life, what does it teach us? It teaches us to be disciplined. It teaches us how to coordinate our future plan and to have a positive attitude in life. Now, today, work or profession does not only mean earning to live, but it involves a lots of other things like the luxuries that surround us, the sophistication, you have the challenges, you have your pride, esteem, knowledge, and many more things. But the base of it, you have to remember for whom do you earn and for whom are you struggling this much. Because always remember, to the world, you may be just someone, but to your family members, to someone, you may be their entire world. So, family and profession, they are like the tracks of a railway line where you have a crack in any of the tracks, the train will be derailed. So, you have to mutually balance each other. Now, how do we balance our personal life? When you're back home, come back home, relax, because a little relaxation, it goes a long way. Spend some quality time with your family members and develop some healthy patterns. Now, work-family balance, it actually involves how you balance your time, how you divide your time between your family and your work, how you balance your involvement in both the roles and be at the same time satisfied playing both the roles. Now, why do we women have trouble with the balance? Because we have to deal with the medical school, you have your postgraduate training, we have a tendency to bring back our work home, which we should avoid it at all costs, and we don't get time to recharge our own batteries. So what we need to do, we need to identify where exactly our life has gone out of balance and take some time to figure out and create your plan of attack. You need to prioritize because there is nothing to be labeled as right and nothing to be labeled as wrong. It is what your heart believes, you go for it. And basically, but at the end of the day, you have to prioritize what are the things to be done first. Be organized, make a schedule, because you try to make a list with your morning cup of tea or coffee. What are your personal commitments and what are your professional commitments, and adhere and stick to it. Learn to keep the things behind. This is the step which we women might find it very difficult, but what you need to understand, leave your work at your workplace and don't bring it back home, or basically otherwise you'll be all messed up and you'll never be able to focus or enjoy either of your roles entirely. Learn to delegate things. Don't be a martyr. Don't say that I can do everything. You need help in every step, be it the profession or be it the home front. And learn to trust other people in both the fronts. This, what will happen, this will increase your downtime, which you can use for yourself, for giving you some time. Most important art that we should learn to master is how to say no. The me time. Now, I have placed this slide at the end. Does not mean that this is the least important thing.
Sorry.
And the me time, it is something that is the most important of all, because if you're not happy, if you're not content within yourself, you'll not do justice either to your profession or to your family. So how do you improve the balance? How do you develop the strategies? Remember, some things are beyond our control. Try to break the problems into smaller bits and practices, and always commit to the notion that managing stress is something of a permanent, it's an ongoing activity that is bound to happen at every step. Thus, the most important thing is how you balance is to learn to say no to unimportant things. Plan everything before so that you can balance both, because the ultimate choice, our ultimate goal is what we want is happiness. So for all of us, life is like riding a bicycle. In order to keep your balance, we all have to keep moving. Thank you so much.
Thank you, Dr. Jayashree, for a wonderful presentation. Do we have any quick comment from the panelists?
I think a quick word, what I would give as an advice is that, it's very important to, whenever you come back home, like as a professional, please always, we must try to bring back something very positive about our work also. It's not necessary that we need to discuss about work and all that, but basically, I think true happiness is what is, if you're happy at your work, you'll be happy with your family. If you're happy with your family, you'll be happy at your work. So that kind of a balance we have to also keep.
Okay, ma'am.
Okay, thank you, ma'am. With this, I would like to invite a last presentation for today, Dr. Rajvinder.
I am audible?
Yeah, you are. Please share your presentation.
Okay, I'm sharing the screen. My screen is visible?
Yeah, it is.
So the topic of my presentation is butterfly coloboma. Incidence of congenital coloboma is 0.5 to 0.7 in 10,000 births. Results from failure of fetal or choroidal fissure to close during 5th to 7th week of fetal life. Period between invagination of the optic vesicle and the closure of the fetal fissure. Almost any ocular structures may be involved, including the cornea, iris, ciliary body, zonule, choroid, retina, optic disc, and optic nerve. The typical coloboma is usually inferonasal, is usually located in if involved in any other quadrant of the globe, it is atypical. Iris coloboma may be complete, giving it a keyhole appearance, or incomplete, which is best seen on the iris transillumination. Segmentally defective or absent development of the zonules result in coloboma of the lens secondary to flattening of the equator in the region of the zonular defect. Posterior segment coloboma more closely related to the poor visual prognosis. So I presented the case of 24-year-old female presented with chief complaints of diminution of vision since childhood, pain and congestion left eye for 3 months, no history of consanguinity and no contributing medical or family history. Best corrected visual acuity was light perception negative in right eye and 20/200 in the left eye. So on the slit lamp, there was nystagmus, microcornea, typical iris coloboma, neovascularization of the iris in pupillary zone and ciliary zone, 360-degree pupillary rough atrophy, congenital cataract, polychromatic clusters in the interior chamber, angles, and in pupillary area, anterior vitreous cavity. Posterior segment details could not be analyzed. IOP was 10 and CCT was 653. Left eye was nystagmus was there, a typical iris coloboma, minimally congenital cataract superiorly, shallow AC, IOP of 26 and CCT was 674. On gonioscopy, because there was lot of nystagmus, so we fixed the eye with the help of Goldman 3 mirror, and we were able to take some few good pics. So we can see the iris processes and the lenticular coloboma. And we could see that is the chorioretinal coloboma involving the macula with intercalary membrane adjoining the optic nerve head, giving it a butterfly appearance. So indirect ophthalmoscopy with scleral indentation was done to note out the extent of coloboma. B-scan revealed the closed funnel RD with the chorioretinal coloboma adjacent to optic nerve head in the right eye, and in the chorioretinal coloboma adjacent to optic nerve head with the superior nasal high reflective band suggestive of RD in the left eye also. Because of lot of nystagmus, only one picture of OCT was visible and was taken, and it is showing the hump effect, which is typical for the that is choroidal coloboma. And prophylactic green laser barrage was done, sparing the macula was done under guarded visual prognosis, and patient was advised retinal detachment surgery in left eye. So this is the whole collage of all the pictures taken, and especially the butterfly coloboma. And our patient was the only child affected in the family, so maybe it's the case of Borode. We could not get the genetic evaluation done due to the corona pandemic. Chorioretinal coloboma has shown to be sporadic, genetically transmitted as an autosomal recessive, autosomal dominant, and X-linked trait. The severity of the visual disability is highly variable, dependent upon many factors such as size of coloboma, extent of macula and optic nerve involvement, and associated anomalies. So our case was type 2 coloboma extending up to the superior border of the disc. So CCT was more in both the cases in our patients. So we have that studies have been few studies have shown that CCT is usually more in cases with the uveal coloboma and the with the eyes with the microcornea. Histologically, RP, choroid, and the retina are poorly developed in the areas of the coloboma. The continuation of the neurosensitive retina into the colobomatous area is termed as intercalary membrane. The detachment or break in ICM leads to retinal detachment in these coloboma areas due to crises like split of neurosensitive retina at the margins of the coloboma. This is seen in case where one eye was lost due to the chronic retinal detachment and start of superior nasal retinal detachment in the other eye. And various studies have reported that retinal detachment occurred in 24.1% in eyes that did not have prophylactic photocoagulation, comparing to the 2.9% of the eyes that received the prophylactic photocoagulation. B-scan of both eyes showed the posterior hump at the transition of the normal to ectatic region. So the main emphasis is on the use of any lens to stabilize the eyes in cases of nystagmus, wherein fundus examination looks impossible. Predisposition to the retinal detachment can result in further worsening of the vision and the complexities of the surgery. It is recommended that prophylactic laser photocoagulation be done along with the margin of coloboma, sparing the macula. Thank you. That's all.
Thank you for the wonderful presentation. With this, I would like to conclude the session 1 and thank all the speakers for the wonderful presentation and the panelists for being here with us. And I would like to invite the next session to please begin.
इधर से खींचनी थी, इधर से। अब टूट गया। कर दूं बंद?
Dr. Pramila.
Good morning, everyone. I request Dr. Pramila to give the introductory remark. Ma'am, you are need to unmute yourself, ma'am. Yeah.
Good morning, all of you, to this chilly winter morning, even though we are all at our homes. So let's start without any further delay, because as it is, our session has been delayed for half an hour or so. I think community ophthalmology is now slowly gaining a lot of importance among ophthalmologists. And this is shown by our 1.5 hour session in the DOS that we have got, and very important topics are being covered. I'm very happy that besides the World Report on Vision and the focus on cataract, now the focus is also on other eye diseases like glaucoma, ROP, diabetic retinopathy, and what we can do as community ophthalmologists. So I hand over the mic to Dr. Vivek to moderate the session, please.
Good morning, ma'am. Thank you. Good morning, all. So first talk we have is by Dr. Sumit Grover on World Report on Vision Challenges or Opportunities. Dr. Sumit Grover is the Associate Professor of Ophthalmology at Ansel University, and he is also the in charge of School of Optometry and Vision Sciences, the Program Director. And he has also completed his Master's from London School of Hygiene and Tropical Medicine in Community Eye. So over to you,
Dr. Vivek, let us introduce the panelists also first. Dr. Praveen.
Yeah. Thank you. Of course, we again welcome you. Dr. Pramila Gupta, as you all know, she's the chairperson, and Madam is actually leading the programs from Ministry. Thank you, ma'am, for being the chairperson of this session. I also invite Dr. Rajiv Garg. Rajiv Garg is a famous ophthalmologist and ex-DGHS. Namaskar, sir. Dr. Rajiv, sir. And Dr. NP Singh. Dr. NP Singh is also co-chairperson of the session, and Vivek is the convener. So I'll invite Sumit. I know Sumit personally very well. Sumit is a fantastic epidemiologist, ophthalmologist, and a community ophthalmology person. And recently he finished his MSc in community eye health. He's the topper of the batch. So Sumit, welcome for your first session, first talk.
Thank you so much, sir, for your kind invite. Good morning, respected Dr. Pramila Gupta, chair of the session, and the co-chairperson, Dr. Praveen Vashish, Dr. Garg, and Dr. NP Singh. It's indeed a great day for me because Dr. NP Singh was my thesis guide, and Dr. Vashish has been a guide throughout my journey of the community ophthalmology so far. And in future, same will be followed, sir. Need your blessings. So myself, Dr. Sumit Grover, the most important credentials I have is the community wala ladka, which I'm fondly called by all seniors in the fraternity. And today I'm going to present you with a very important and very interesting topic on World Report on Vision. And this is a very important and timely document launched by WHO in 2019 to guide the strategies on global eye vision health on the national, global, and regional levels. And the disclaimer is that all the graphics and the pictures used in these slides are courtesy of World Health Organization under the Creative Commons license. So I feel very nostalgic today because around same time last year, I actually attended the unveiling of this World Report on Vision when I was in London. And it was a event organized by Commonwealth Eye Health Consortium in association with the Queen Elizabeth Diamond Jubilee Trust. And there, Dr. Ella Cross Cieza, she is the coordinator for, and one of the draft person for this World Report on Vision, was present, and she presided over the meeting. And I would like to present few excerpts from the meeting. She quoted that eye healthcare is a very mature field. Whether we take the advocacy campaigns like Vision 2020, Right to Sight, or Global Action Plan of 2014 to 19, if we talk about technology like OCT, spectral domain, things like that, innovation, disruptive innovations, like the Arvind Eye Care System or the pyramid model of eye care given by L.V. Prasad, adapted by the NPCB, these are the innovations, kind of things which have been provided to the world by India. There are cost-effective interventions like cataract surgery, yet there is urgent need and challenges for years to come. And we'll see in this presentation that what are these challenges. Then Dr. Peter Holland, the CEO of IAPB, adds to it that it is the first ever World Report on Vision, and it will be the cornerstone for advocacy strategy for the eye care organization around the globe. So the World Report on Vision has highlighted many opportunities as well. First, we'll take on the challenges, and Dr. Tedros Adhanom, the Director General of WHO, said that we have no choice but to take on this challenge. And at that time, it was not Corona challenge. He was talking about the magnitude of the visual impairment around the globe. So what are the challenges? The challenges were that at least 2.2 billion people around the world are with vision impairment, living with visual impairment with these many causes like refractive error, cataract. And the beauty of this World Report on Vision is that it included those who with met needs as well as unmet needs. So the 2.2 billion includes those persons who have contact with the eye health system and had their contact lenses or glasses, but the 1 million had their unmet needs. And other beautiful things which were highlighted by this World Report on Vision, that it did not only focus on the eye disease which causes the visual impairment, but also the common eye condition that do not typically cause visual impairment, but majority of the patient presents with these conditions. And to make it more for the policy advocacy, it highlighted that everyone, if they live long enough, will experience at least one eye condition in their lifetime. So we cannot neglect the eye health care. Other challenge is the projected number of increasing glaucoma and ARMD. We can see the magnitude in the year 2030, and the eye conditions are projected to rise because of the aging population, lifestyle, and non-communicable disease. This is about the adults. If we talk about children, the magnitude of myopia, high myopia, the figures for 2030 are gigantic. Other challenge for a country like ours, like India, the unaddressed distance vision impairment in many low and middle income regions is actually 4 times higher than the high income regions. So that is the additional challenge for us. Then we have to understand that how health system works. According to WHO, there are 6 health components which act as an input, which includes governance, financing, human resource, information, medical technology, and vaccine. And these leads to the outcomes. But the problem lies in between, and the problem is of acceptability, accessibility, and availability. These points were very much highlighted in the World Report on Vision. Acceptability on the user end, that whether the eye healthcare intervention is accepted by the community or not, this is, I think, very much neglected aspect. Then accessibility and availability of the eye healthcare services, because we know that in developing countries, the services are only the urban centric, and there is urban rural disparity, whether there is we talk about ophthalmologists, optometrists, or any other eye allied health personnel. They are concentrated in the urban centers, so the rural population is deprived of getting these services, though, so it affects the outcome in the form of decreased coverage, decreased utilization of the services, decreased effectiveness or ineffectiveness of the cost-effective strategies like cataract surgeries, and overall the health cannot be improved. Other thing, if we analyze the cause of visual impairment, we'll see that previously trachoma, river blindness, or vitamin A deficiency, they were very simple diseases to manage. Mass drug administration of ivermectin, azithromycin, or primary eye health care was sufficient. Then came the cataract and refractive surgery, refractive error. They are also like simple one-time curative treatment. Do cataract surgery with IOL implantation or give glasses, we are done. But as we are going towards the future, diseases like glaucoma with multifactorial etiologies, DR, ARMD, they need screening, they need long-term treatment, and they need the plethora of specialists to manage them. So the diseases are increasing in their complexity, and thus the resources requirement to combat the same. Other thing, lack of integration. The programs are vertical, are not integrated. There is no coordination with the private sector. An unregulated workforce like optometry is still not recognized, and many other things are there, like there's lack of training and certifications, and lack of the councils. Other thing, eye care is not the part of health information system in many of the countries. Now, what are the future challenges to achieve universal health care? First is the magnitude. We are aging population and disruptions in the population growth of the country, distribution of the human resource, availability of financial resources, service delivery, marginalized populations like migrants, women, rural population. These are very deprived for the service delivery, and especially the persons with disability for various reasons. Then delivery of the eye care at the community or the primary level where the person lives, and managing the non-communicable eye diseases like DR, hypertensive retinopathy, etc. But the challenges are not over. The main challenge now we are facing is the COVID disruptions. It's a natural calamity. And now we have to forget about cataract, glaucoma, but to think that how COVID affects the eye and what precautions we have to take when we are seeing the eye patient. The Vision 2020 has become now the COVID 2020, and the focus has already shifted. So this is the disruption. The natural disruption can come anytime. But let's not talk about only the challenges. We have opportunities as well. The most important and very much insightful thing which was presented or highlighted and has a pave way for opportunity for the future is the integrated people-centered eye care. It's the eye care which includes all aspects of the eye healthcare service delivery, from promotion, prevention, treatment, and rehabilitation, and according to the needs. And the most important thing is it is coordinated across the different levels and different sectors. It's not just related to the health sector, but to the education, sanitation, social assistance, social justice, labor, housing, and environment. And it is patient-centric, surrounded by the family, community, as well as the country setting. So it recognizes people as the participant, beneficiary of these services throughout their life course, from their childhood to the younger age and to the old age. It adopts 4 strategies: engaging and empowering people and community through awareness, through IEC, reorienting the model of care based on strong primary care rather than focused just onto the tertiary level, coordinating services across sectors, across the ministries, and creating an enabling environment, specifically the inclusion of eye care in national health strategic plans, and planning of eye health workforce according to the population needs. If the population needs is that it needs a vision technician or optometrist or ophthalmologist at particular time of the particular settings. Other thing, advancing universal health coverage through eye care. Making eye care integral to universal health coverage has contributed to will contribute to reach the sustainable developmental goal, especially the target 3.8, which is ensure healthy life and promote well-being of all the ages. This is, I think, the most important advocacy tool, because if we want the sustainable developmental goals to be a reality at 2030, we have to take care of the eye care and universal eye health care as well. In addition to it, eye care services also contribute to other targets that, such as neglected tropical diseases, mental health, road traffic accident, and workforce health, etc. To conclude, the premise of the World Report on Vision is that integrated people-centric eye care has the potential to accelerate action and meet these challenges. For this to become a reality, the report recommends 5 important actions. These are making eye care an integral part of UHC, monitor trends and evaluate progress, implement integrated people-centered eye care in health systems, raise awareness, engage and empower communities, and promote high-quality research. Let's see what we are doing in India. The current prevalence, which is close to the target of 0.3, and high cataract surgical rates are the indicators that we are on the right direction. And we have the 4-pronged strategy with strengthening of service delivery, development of human resource, developing institutional capacity in the form of RIOs, promoting outreach activities and public awareness through IEC. And NPCB has a very comprehensive eye care approach, not limited to just cataract and refractive error. And the beauty is our integrated eye health approach. It's a part of National Health Mission. We are integrated with the Social Justice and Empowerment Ministry, and NHM is there, Rashtriya Bal Swasthya Karyakram is there with the integration, ROP services and diabetic retinopathy services are also started including through the NCD clinics. But still, there are some weaknesses. We have weak health data management. There is limited coverage of health insurance schemes in India, and majority is private based and urban-rural disparity. But I think the public-private partnership is our USP, and I think India is doing well in the able leadership of our ministry. So we all should work together around the globe for effective integration of eye care services with national strategic plan on all levels unitedly, so that the World Report on Vision should not remain to be a PR activity, but an opportunity to reflect upon eye health care issues on global level. Thank you. Thank you so much for patient listening.
Thank you, Sumit, for highlighting the challenges and the opportunity for World Vision Report. I'm glad that Dr. Pramila, Dr. Sara, and myself were part of the development of this report. Ma'am, would like to comment something on this, ma'am? Pramila?
Yes, very nice presentation, Sumit. And I would like to have these PPT also with me.
Sure,
secondly, I like to say that Government of India is now working under universal health coverage through its health and wellness centers, where among the 12 health packages, eye care is one of those included. And we are developing training modules for all level of healthcare personnel, including the CHOs that will be there, the ANMs, the ASHAs. They are in the final stages. They had been sent to me for final evaluation. I have sent them back. So we hope that through this, we'll address our needs. And presbyopia is another field that is now gaining more momentum, and NPCB has already taken it up. And there's a good response to the presbyopic spectacle distribution also under NPCB. Thank you.
Thank you, ma'am.
Thank you. Now we would like to invite the second speaker, Dr. V. Rajshekhar. He is ophthalmologist from Safdarjung Hospital and is also managing program, National Program for Control of Blindness and Visual Impairment, along with Dr. Pramila Gupta. So I request Dr. Rajshekhar to share his slides and start his presentation. Dr. Rajshekhar.
Good morning, everybody. Thank you for giving me this opportunity. I hope I am audible.
Yes, sir. Yeah.
Okay. Yes. And what about the screen? It's visible?
Screen is not visible.
Okay, just a second. Is it visible now?
No, it's not visible, Dr. Ashekar.
Oh, I don't know exactly.
The video is coming on, but the screen is not being shared.
Okay, just a second.
Yes.
Yeah, is it visible now?
Yes, now.
Okay. Good morning, everybody, and thank you for giving me this opportunity to speak about the blindness control program. Just to start with, I would like to say the program was initially started in 1976 after the name has been changed from Trachoma Control Program, which was started in 1963. It was named as NPCB, and now the latest is NPCB VI. That VI looks like 6, but it's actually visual impairment. This program was initially a 100% centrally sponsored program. And after it came into the 12th five-year plan, it has been made into 60-40 scheme. The 60 is from the center, the financial support, and the budget from the states would be around 40%. So that's how the 60-40 ratio is. And in the hilly areas in the Northeast, it is 90-10. The nomenclature, as I have told, that it has been changed to National Program for Control of Blindness and Visual Impairment in 2017. And this is actually in line with the change of the definition of the overall blindness in the or the definition of blindness, which is in line with the WHO. So the visual acuity of less than 3/60 or corresponding visual field loss to less than 10 degrees in the beta eye with best possible correction is what WHO has the definition, and we have adopted after 2017. So I would come to the goals and the objectives of the program. The goals is basically to reduce the prevalence from 1.4 to 0.3% by the year 2020. Is it visible?
The next slide is not coming.
Sir, your introduction is the slide that we can see, sir.
Yeah, the first slide only we can see.
I don't know, there is some technical issue out here. Yeah, you got it?
Yeah.
Oh, okay. Sorry for the. So basically, as I've told, the prevalence has to be reduced to 0.3%, but due to two factors. One is the number of increased surgical coverage, especially for the cataract and also other causes which we are intervening. We have been able to reach a significant extent, but the major change has been with the adoption of the new definition. We have been able to reach to around 0.36% as per the latest reports, latest survey which has been conducted by AIMS. And so the main objectives of the program are to reduce the backlog of blindness through identification and treatment of the blind, develop a comprehensive eye care facility from the primary health center level till the highest level, that's the Regional Institute of Ophthalmology. So and also we have a multi-pronged approach, like we have included the human resources for we develop the human resources like training of doctors, etc., and also the paramedical ophthalmic assistant for providing eye care services. We also have increased participation of the voluntary organization, private practitioners in the eye care, and enhanced community awareness on eye care. So the prevalence now has really dropped down to 0.36% in this year. as per the latest service report, latest survey report. And I don't know what's the problem with these slides. Oh, okay. So these are the various causes of blindness, and the cataract remains the topmost, which is around 66.2%. The non-trachomatous corneal opacity is 7.4%. The cataract surgical complications is 7.2. The posterior segment diseases is 5.9. Glaucoma is 5.5. And phthisis bulbi is around 2.8%. So this is post-surgical. Probably it could be a phthisis or due to the endophthalmitis which has occurred, which is also accounting in this particular survey report, is phthisis 2.8%. And again, I'm sorry about that. So the organizational structure is basically from the State Health Society. In fact, the national program at the center and the State Health Society under NHM, which is having the State Health Societies at every state, and also the District Health Society. Then subsequent subordinate offices are the PHCs, CHCs, and the subcenters. So the tertiary level is basically under the NHM, under the center, whereas the rest, secondary level, district hospital, NGO, and the primary are under the NHM. So these are the various services under NHM which we have a reimbursement of. We in fact do a reimbursement to the non-governmental organizations and also the private practitioners. That's at the rate of 2,000 rupees for cataract surgery. And for district hospital and sub-district, it is 1,000 per case. It is not a reimbursement process. It's an indicative amount which we actually give in advance as per the PIPs which they project. Refraction and distribution of free spectacles, that's at the rate of 350 per spectacle. And this is also including the reading glasses. And also for school-going children, it is from class 1 to 10. So that's around 350 per spectacle. So the diagnosis and treatment of other eye diseases is also at the rate of 2,000 to almost 10,000 rupees. For 10,000 rupees, we have a VR surgery, and keratoplasty is so as I have said, keratoplasty is at the rate of around 7,500. Collection of donated eyes is around 2,000 per eye. IEC is also done at all levels, starting from district hospitals, PHCs, and CHCs. So these are the various manpowers we have for the states. I think that is basically more of the administrative aspect, which we do cover it under. We in fact cover the salaries from the center. Including ophthalmologist, ophthalmic assistant, eye donation counselors, etc. So this is the various financial assistance which I was talking about. We also have diabetic retinopathy and medical treatment. So we have included the other eye diseases since the last plan. That is DR, childhood blindness, glaucoma, keratoplasty. So these are the various rates at which we are reimbursing, and all this is being captured real time and included into the MIS system, and we do the reimbursement, and depending upon the amount we have actually decided, and that amount is basically collated at the state level, and all those reports are being sent to the center.
Excuse me, can we continue without the slides itself?
I think we can. I have the slides with me though.
You may not project them. You can use your slides.
Okay. So coming to the, in fact, after the financial assistance, we also have the financial assistance to the states. And in that, we give grant aid to the district hospitals, the CHCs, and also the PSCs. So this is as per the IPHS norms based on the state PIP. PIP is the program implementation plan, which we get it around every year at the beginning of at the end of the year. That's around November, December, and we do the sanctions by the end of March. In the same way, for granting aid for the IOTs and district hospitals, it is up to 1 crore per district, per state, each proposal for construction, and also the equipment part for district hospitals. Then we have the mobile ophthalmic unit, which is at the rate of 30 lakh per unit. And eye banks, we give it only to the public sector, that is the government sponsored eye banks, in which it is around 40 lakh per unit, which includes the equipment as approved by the program. And eye donation centers is 1 lakh per unit. And there is also a provision for the tele network or the tele-ophthalmology, in which basically we do the screening for DR, and that is at the rate of 25 lakhs per unit. Then we have the financial assistance from headquarter budget, that is also to the RIOs directly up to 6 crores. So we have a provision for providing not only the equipment, also the construction of a modular OT for the Regional Institute of Ophthalmologists. And also for the government medical colleges, we have up till 1 crore for the state government medical colleges, and also to various other eye setups in each of the college we are sponsoring for the equipment. Then individually, we are training the eye surgeons at the central level in various subspecialties, starting from cornea, retina, and oculoplasty, and also the eye banking and keratoplasty services. So then we have a provision for corneal storage medium, which in fact we fund the RP Center aims to provide medium to various colleges and hospitals where the keratoplasty centers are there. Then also we do the entire funding of the surveys, starting from the visual impairment survey, trachoma survey, which are all identified through various institutions. So then now the physical performance of each of the of each year is in fact on the rise, from starting from 66 lakh in the 2017 to 18. Now it has almost reached 68 lakh surgeries. But this year, due to the COVID, the surgeries performed have drastically dropped. It's now, as on date, it's around 6 lakh 51,000, which is a very low achievement as of now. But hopefully, the things might improve as the pandemic comes to a halt. And the spectacles distribution is almost, the target is around 9 lakh or 10 lakh, and we have been achieving almost 80 to 90% of the distribution of spectacles. In the same way, for cornea transplantation, also the achievement, which was around 71,000, and it has increased to around 70,000. It's a pretty good achievement as far as the targets are concerned, because we are getting around 143% achievement. But this year again, as I've told, due to the COVID, it is lagging behind. And other eye diseases also, we have been achieving the targets in DR, glaucoma, childhood blindness, and keratoplasty as planned. So, there are also training and workshops being organized by the state for the state and district program officers and ophthalmologists for diagnosis of trachoma and also glaucoma. Special programs were organized by NPCB. In fact, 450 ophthalmologists have been trained in 2-day workshops for early diagnosis and treatment of glaucoma. The major issues which we are facing as of now is because of the low utilization of funds by most of the states, delay in the payments of the NGOs by the district program officers, probably mainly due to the uploading of data into the MIS system, thereby after which they get the funds allocated. And other main issues would be like quality at the district level. So basically we need to focus on these issues for the future. The major issues, as I have said, also the funds which are lying at the district and at the institute level, the grants which are being given are not being utilized completely. So the basic future and roadmap and initiatives ahead is to basically give incentives and also to the states and districts so as to clear the backlog of cataract in a phase-wise manner with a good emphasis on surgery. The increased focus and other visual impairment like cataract, like diabetic retinopathy, ROP, and corneal blindness also should be included into our program. And training and sensitization of all the government ophthalmologists to various other eye diseases at the district and at the PSC level. Then strategy for focusing visual impairment, especially in the 0 to 6 years of the children and newborn in synergy with other programs. Then also collaboration with RBSK and Education Department for school eye screening and NCD clinics. And also with another department is the social justice and impairment for low visual aids. So surveillance and detection of trachoma trichiasis, also followed by TT only survey in which trachoma endemic focus to endemic districts to focus on elimination by the year 2020 as per the WHO action plan. So this is all, and in fact the latest
permission, may I request the speakers to restrict to the time limits, because we have lined up 14 people to speak, and
okay,
we are
I have completed, sir. Thank you. Thank you so much.
Please, all these speakers restrict to your time limit.
Thank you so much. I have completed mine.
Can you stop sharing your slide, Dr. Rajshekhar?
Okay, are the slides visible? I thought they were not visible.
No, they are not visible, but you need to stop it. Yeah, thank you. Thank you for highlighting about the National Program for Control of Blindness. In fact, we were also interested if Madam, and you can speak something about what are the future plan and targets after 2020, because we have targets till 2020, but after that we are not even aware at this stage. So ma'am, if you can highlight about
I think let me speak regarding this at the end. Let all the speakers get their talks done with. Then I'll share a few this thing.
Dr. Vashit, I'll just like to, it was a very comprehensive presentation by Dr. Rajshekhar. But the point he made about the pandemic, I think that's a very significant point, because I think till the third quarter of next year, this effect will be there, and there will be a lot of backlog in late 21 and 22, early 22. So I think all the facilities, and we should stress from the national plan side that we should spend this time in, developing the infrastructure, particularly telemedicine. So the funds maybe can be utilized in those ways, and that will help ultimately when we are in the middle of the backlog. That will, the good facilities and the good infrastructure, that should be the prime focus. And as Dr. Pramila has also been telling earlier, so we should concentrate on that. Thank you.
Thank you, sir. So next speaker, Dr. Shalini, is not available. She was supposed to speak on high volume cataract surgery. So now I request Dr. Ajay Kumar Shukla, who is a professor and head of MGIMS Wardha. And I believe for last around 28 years, sir, since 1992, because since my childhood, I am seeing as the head of the department in NGS Wardha. So most welcome about your talk on diabetic retinopathy screening by teleophthalmology.
Good morning, Dr. Pramila, Dr. Garg, and thank you, Dr. Vashist, for your kind words. Am I audible enough? I'll be sharing my screen.
Yes, sir. Yes, sir.
Yes.
Is my screen shared? First page.
Yeah.
Yes.
Yes, we can see your slides.
Right, madam. Again, greetings from Sevagram, Wardha. I shall be sharing our experiences regarding the diabetic retinopathy screening by teleophthalmology. And at the outset, we would like to acknowledge the support of Queen Elizabeth Diamond Jubilee Trust and unwavering support of Professor Claire Gilbert from ICH London in implementing this project. Some of us are familiar with this project, which was implemented in 10 states across the country. I'll be sharing our experiences from Maharashtra. Next. We are all well aware that prevalence of diabetes is increasing in India, and every diabetic is at risk of developing diabetic retinopathy, which in turn may affect his visual status. And if there is an undiagnosed or uncontrolled diabetes, it may result in sight-threatening diabetic retinopathy. Now, in taking a cue from presentation by Dr. Sumit, where a pupil-centric approach is being advocated for the World Vision Guidelines. Problem in India is not as much as in the urban areas where you have adequate manpower, probably the socioeconomic status is much better, but for taking care of diabetic patients suffering from diabetic retinopathy in rural areas, and that too belonging to poor socioeconomic strata, where you have to focus on use of teleophthalmology. And another big challenge is maldistribution of trained manpower. As of now, in 735 districts across the country, you find that in public sector, in government hospitals, at best 1 or 2 ophthalmologists in a district responsible for anything between 15 lakhs to 40 lakhs population. Assuming that a prevalence of 10% across the country, and these numbers are simply not manageable by an ophthalmologist in the public sector. We implemented this project in 5 blocks of the Wardha district, wherein a total population of about 10 lakhs was benefited by the implementation of this project. And the only criteria was that in the blocks where the non-communicable disease clinics and eye clinics were functional at CHC level, because this is a major challenge for the diabetic patients to seek the eye care. What we realized long back was that these patients who are dependent upon the government health facilities for even control of their diabetes because of the dispensation of medicines through the CHCs and CD clinic are the ones which will not be coming to the district hospital for getting their eyes checked. Fortunately, the eye clinics are also there at the CHC level. So what this project aimed was building a bridge between the NPCB and NCD clinics at the CHC level. All these CHCs in the 5 blocks were equipped with the proper equipment, including ETDRS charts, 3-netra non-mydriatic fundus cameras with laptops, tablets with pre-installed software for data entry, and there was a provision of internet connectivity. Apart from the provision of equipment, the existing manpower of the NPCB and NCD clinics, including paramedical ophthalmic assistants and NCD nurses, were trained for taking the fundus photograph using these cameras. These cameras were used for taking fundus photographs of all the patients attending the NCD clinics in the CHC. The fundus photographs were uploaded on a cloud-based online software. The fundus photographs were analyzed, graded by the ophthalmologist at the base hospital, and report and feedback was given online in real time. All the patients suffering from DR were referred to base hospital for further investigation and treatment and were provided transport to avail these facilities. In the second phase, we expanded these activities from CHC level to even PHC and sub-center level with the involvement of ASHA workers and health assistants in the PHC or even at the village level, where the line listing of the diabetic patients have been done, for which orientation training of all these health workers were carried out in different blocks. Apart from the fixed facility screening, which was being conducted in the 5 blocks, we embarked on a mobile screening by mobilizing a mobile team and mobile set of equipment so that the persons who were unable to come for a screening even at the CHC level because of various constraints could be screened at the village, sub-center or PHC level. Over a period of about 21 months, we were able to screen close to 11,000 diabetic patients, and at least 3,000 of them availed of repeat examination. To emphasize again, the DR screening is not a one-time procedure. It's going to require an annual screening of each and every patient to document any progression which may require a treatment or further investigation. What we noticed during the implementation of this project, that the mean age of the study population was around 58 years. The males were around 52%. The mean duration of diagnosis of diabetes was about 4.6 years, though the 7.6% of the diabetic patients had diabetes for more than 10 years. What shocked us was that in the study population, almost half were having uncontrolled blood sugar level. Majority of them were on oral hypoglycemics, probably the irregular supply and compliance to the medication resulted in the study population showing such a high incidence of uncontrolled blood sugar. Almost 10% patients had visual impairment, severe visual impairment, or blindness. Next. Analyzing our data, we found that prevalence of DR was something in the range of about 8% in this rural population, and almost 2% of them were suffering from sight-threatening diabetic retinopathy, including diabetic macular edema. The challenge in here was that all the photographs acquired by these persons who were being monitored for quality by the residents from the ophthalmology department of MGIMS were not gradable. This is the big challenge which we faced. Almost 12% of the photographs could not be graded or could not be satisfactorily acquired. So at the outset, we referred all these patients where the visual acuity was less than 6/60 or where the photographs were not gradable for further investigation to base hospital by provision of transport. Now, this is a missing link. If the patients are told to come to the base hospital, we realized early in this implementation phase that not more than 10% of them actually avail of services. But if the transport is provided, the utilization or accessibility of services reached more than 90%. At the base hospital, all the sophisticated investigation required, including OCT, FFA, USGB scan, were carried out for all the diabetic patients, and wherein apart from DR, we were able to document the diabetic macular edema and treat for the cataract if the patient had, or we could provide for services for VR surgery. all the facilities for the diagnosis and the treatment of these patients were provided, and also the district ophthalmic surgeons were trained for grading the photographs and performing and interpreting these investigations, apart from doing pan-retinal photocoagulation and giving an intravitreal anti-VEGF injections. During the implementation of the project, almost 250 VTDR patients were managed. Half of them required laser PRP of great photocoagulation, another 100 required about anti-VEGF injection, and there was a subset of about 25 patients which required both the treatments to manage their DR status so that their vision could be safeguarded. The whole highlight of this implementation of project was that we have to take these screening services to the people who need it most, who cannot access these services by taking these services to CHC or PHC level. What I wish to conclude is by saying that the diabetic patients attending primary and secondary government healthcare facilities can be screened by trained paramedical manpower by taking photographs with the help of non-mydriatic fundus cameras. Use of teleophthalmology using online software for data capture, remote grading of fundus photographs leading to timely referral of DR patients can be very effective for controlling blindness due to DR in rural areas. What we require in here is capacity building of manpower and provision of teleophthalmology compatible equipment at the CHC level across the country. Thank you all for patient listening, and we expect that this DR support for DR screening, which is being provided under NPCB and VI, is made accessible to more states and within the states to more districts, because this is an epidemic. This is a tsunami which we are going to face. If almost 10% of the population in the country is diabetic, and if everyone is at a risk, then this is something which we need to closely follow up or invest in. Thank you once again.
Sir, for so beautifully highlighting the problem of diabetic patients and the last mile help to the patients by providing them transport and how it helps to give them treatment. And I think this project can be taken up along with the NCD program, and these two can be connected. I think every medical college should come up and help in adopting one district or one or two districts around their hospital so that these patients are helped. Thank you.
Thank you. Now invite our next speaker, Dr. Chandrama Paul. Dr. Chandrama Paul is Director of BBI Foundation, Kolkata, and also Honorable General Secretary of Glaucoma Society of India. She'll be talking about angle closure glaucoma in Eastern India, the Hooghly River Glaucoma Study. Dr. Chandrama.
Thank you very much, but the previous speaker needs to stop sharing the screen.
Stop sharing.
Dr. Shukla, please.
1 second, sir.
Stop sharing your screen, sir. So thank you very much, DOS, and thank you very much, distinguished panelists of this session. I'm going to take you through angle closure glaucoma in Eastern India, the Hooghly River Glaucoma Study. So this was the study which was published in the year 2018 in the IJO. And this was a study, a part of a study which we conducted called the Hooghly River Glaucoma Study, which was published in 2016, the main study. And this is a part of that main study where we looked at angle closure glaucoma. So the aim of the study was to estimate the prevalence, features, and associations of primary angle closure glaucoma, basically primary angle closure disease in rural and urban populations from West Bengal in Eastern India. Material and methods. The study procedure was divided into 2 segments: epidemiological fieldwork and hospital-based clinical examination. So the epidemiological fieldwork consisted of health workers who did a door-to-door survey and gave a questionnaire to each house. They had to fill up that questionnaire, and then from there we had actually made a selection, and the social worker accompanied those people from the villages to our base hospital in Kolkata, in a base hospital in Balagor, and in Kolkata the same thing was carried out in the metropolitan city, and they were brought to the hospital in Kolkata. So the study area consisted of, if you look at this, the Gangetic Delta is the largest delta in the world, and consisting of Bangladesh and West Bengal in India. So this part actually drains into the Hooghly and Kolkata itself. So the study area, the rural arm, consisted of the Hooghly area, which was 28 villages in that area of Balagod district, and the urban area of the study was the metropolitan city of Kolkata. So the hospital-based clinical examination and diagnostic procedures. After consenting, the subjects proceeded through various ophthalmic examinations and diagnostic procedures in the following order at both the hospitals, at the rural hospital in Balagor and also at the Kolkata. All history and fractionalization, technology, myopia, including Van Herrick's grading of the angle, was performed. Application tonometry by gonioscope, the Sussman type for mirror handheld gonioscope, and angle was recorded. Ocular biometry was carried out according to the LOC. Optic evaluation done.
I think Dr. Chandrima has.
Connectivity is lost or something.
Seems like that. Should we just maybe wait a minute to see if ma'am reconnects?
Yeah, I think we can wait for a few minutes.
Dr. Paul, we are not able to hear you. Oh, yes.
Okay, I think ma'am has disconnected.
There's some problem. Can you see me now?
Yeah, we can hear you now. Yes.
See me now?
Yes.
Okay.
Yes.
So but the slide's not moving.
Yeah, the screen share has stopped actually.
The screen is shared actually, but I don't know.
No, the screen share is there, but the slides are not moving. It's static and the slides.
Yeah, that's what.
Now you can stop it and then reshare again. Probably it will improve.
Okay. Can you see now?
Yeah.
Yes, ma'am.
Yes, we can see the slides
Yeah,
now.
okay.
Continue.
So the methodology consisted of definitions based on the ISGO guidelines which were used, and no, it's not moving. Okay, primary angle closure suspect an eye in which appositional contact was present on gonioscopy between the peripheral iris and posterior trabecular meshwork of more than 270 degrees of posterior trabecular meshwork. could not be visualized. Primary angle closure was an eye with an occludable drainage angle on gonioscopy, posterior trabecular meshwork seen for less than 90 degrees, and features indicating that trabecular obstruction by the peripheral iris had occurred, such as peripheral anterior synechia, elevated intraocular pressure, iris rolling, distortion of the radially oriented iris fibers, glaucoma flecken, lens opacities, or excessive pigment deposition on the trabecular surface. The optic disc did not have glaucomatous damage. PSCG was when PSC, along with evidence of glaucoma with characteristic disc and field changes. So secondary glaucomas were among the subjects diagnosed with glaucoma patients with history of use of topical steroids for the last 6 months, history of trauma or ocular surgery, history of chronic uveitis, evidence of pseudoexfoliation or pigment dispersion on slit lamp examination, and those with hypermetropia or intumescent cataracts were grouped under secondary glaucomas. So if we look at the article, in the urban population, if you look at that figure of PSCG is 0.97%, and in the rural population, it was 1.15% as compared to 1.45% of POAG. So the conclusion was that PSCG, they thought those were the rates of POAG and PSCG with secondary glaucoma. So if you look at those rates, 40.6% and 55.4% is almost a 50-50. And these are the rates in the rural area, 42.6% and 53.7%. So it's almost a 50-50 in both the arms. So statistical analysis, data analysis using SPSS software package of version 13, P less than 0.05 was taken to be statistically significant. P less than 0.001 was taken to be statistically highly significant. The primary outcome was the prevalence of PSCG with 95% confidence interval, age and gender specific prevalence estimates, PSCG, and prevalence of PSCD calculated. Multiple logistic regress used, analyzed independent risk factors, analyzed including age, sex, IOP, and hypertension. There seems to be a wide variation in the rate of PSCG in India. The prevalence of PSCG in reported ratio of primary open angle glaucoma to angle closure glaucoma was 1.21 in the urban. However, primary open angle glaucoma to primary angle closure disease was 1:1.31 in the rural and 1:1.36 in the urban. So the study concluded that higher age, higher CCT, and shorter axial length, presence of hyperopia are important independent predictors of angle closure disease. And no significant relationship could, however, be established between angle closure disease and female sex, presence of diabetes or hypertension, and smaller anterior chamber depth. The findings of the study establishes the fact that angle closure disease is more common in Eastern India than previous estimates have shown. Hence, adequate changes in healthcare policies should be introduced to address this issue. And as a first step, the authors recommend that a simple and inexpensive procedure like gonioscopy should be made mandatory in basic eye checkup protocols. So what we actually see depends on what we actually look for. Thank you very much for your attention.
Dr. Paul, for presenting such a significant case study. And I think now it has been proven that angle closure glaucoma, if not more common, at least is almost as common as primary open angle glaucoma in India. I think this is a very good advice that you've given, that gonioscopy should be kept as a primary health checkup in glaucoma. And based on this, we had also devised a 2-day sensitization workshop for all district ophthalmologists also on glaucoma, so that they do gonioscopy and at least once in every glaucoma patient that they diagnose. And I think we need to re-emphasize this. We might do again these sensitization workshops. Thank you.
Thank you. Thank you very much.
Thank you, ma'am. Now I would like to invite Dr. Rohan Chariwala. Dr. Rohan is my friend. He is director of Shubham Netra Seva Trust, also alumni of ICH London, my batchmate from there, and one of the very hardworking, very sincere ophthalmologist. So I request him to speak about magnitude of different cause of blindness in India. Dr. Rohan.
Thank you so much, sir. Am I audible and the screen is shared?
Yes, Rohan.
Yes, please.
Okay. First of all, I would like to thank DOS, Dr. Promila Madam, Dr. Praveen sir, to giving me this opportunity to present magnitude of different cause of blindness in India. So, as we all know, India is home to world's largest number of blind people. The number of blind persons in India it is like 2018.7 million. The projected number of blind persons in 2010 is around 24.1 million, and in 2020 it would be more than that. So, and as per the National Program for Control of Blindness, the prevalence of blindness in India was 1.1% in 2001 and 1% in 2006. 1 second, I need to. Can I get rid of? As per NPCB survey 2001, the cataract was leading as a cause of blindness, and 62.6% was attributed to that. Refractive error responsible for 19.7%, glaucoma 5.8%, and so on. So first we'll take cataract. In spite of significant reduction in burden of cataract blindness, untreated cataract remains the challenge. Extrapolating observation of various population-based surveys to the entire country was estimated that in 2001, there were 7.75 million individuals whose blindness could be attributed to cataract, and this would increase to 8.25 million by 2020. Corneal blindness. Common corneal conditions leading to blindness are corneal ulcers, trachoma, corneal dystrophy degeneration, trauma, pseudophakic and aphakic bullous keratopathy due to complicated cataract surgeries, vitamin A deficiency. In India, it is estimated there are approximately. Can you? I'm audible. Hello.
Yes, Dr. Rohan, you are audible.
Okay. So the total number of corneal blindness would increase to 10.6 million by 2020. According to NPCB estimates, there are currently 120,000 corneal blind persons in the country, and additional 25,000 to 30,000 corneal blindness people are added to the pool. Corneal opacities have emerged as the second leading cause of blindness in 2015-19 survey also. In one survey conducted in a rural tribal area of Surat district also suggested the same finding. The prevalence was 8.2%, which was RAP survey, where I was a principal investigator. It has been reported that nearly 90% of the cases are due to ocular trauma or corneal ulceration. Trachoma was one of the leading cause of blindness in India in the past, but in the last decade, prevalence and rapid assessment surveys conducted all over the country, and especially by Dr. Praveen Vasisht and AIMS and the team has done a great job in finding out the prevalence and all. Government of India declared the elimination of active trachoma among children, but the prevalence of trachomatous trichiasis is still a problem. As far as childhood blindness is concerned, in India, 3,20,000 children less than 16 years are blind, and which constitutes about 1/5 of the world's blind children. And as reported by Dandona and Worker, the prevalence of blindness was 0.17%. This corresponds to about 6,80,000 children after all extrapolation. Childhood blindness causes are corneal scar, maybe because of vitamin A deficiency, measles, trauma, etc. Cataract constitutes about 39% of all childhood blindness. The rest are trachoma and glaucoma. Glaucoma, a leading cause of irreversible blindness. In India, around 12 million people suffer from glaucoma and 1.5 million are blind due to that. More than 75% of glaucoma are undiagnosed. Open angle is more than angle closer glaucoma. The prevalence of glaucoma ranges from 6.9% to 8%. As far as diabetic retinopathy is concerned, in India, among 20 plus population, there were an estimated 65 million people with diabetes in 2016. Assuming 15% to 20% of these individuals have any diabetic retinopathy and 5% to 7% have sight-threatening diabetic retinopathy, 3.25 to 4.55 million people are at risk of visual loss or has already lost vision due to diabetic retinopathy. Uncorrected refractive error, the prevalence of it was 10.2%, but heterogeneity in this estimate was very high along the breadth and length of the country. In absolute number, the estimated prevalence of uncorrected refractive error is 54.5 million. Something about National Survey 2015 to 19 results. The objective of the survey was to provide evidence about the present status of the blindness and visual impairment in India. The RAP survey was conducted. It was house-to-house survey and done in both rural urban area. Additionally, 0 to 49 years age was covered in January, February 2019. The blindness, as far as blindness is concerned, the prevalence was found to be 0.36%, and the total number of people blind were found to be around 48 lakhs, and total visually impaired people were found to be around 3.4 crore. 8% was unavoidable cause, which large chunk, 92% was avoidable. And if we go by visual impairment, the 96% was avoidable. So we can do more by providing eye care services to take care of that avoidable blindness. The causes of blindness and visual impairment in 50 plus population, cataract was the leading cause by having 66.2%, followed by corneal, non-trachomatous corneal opacity, you can see 7.4%, followed by cataract surgery complication, retinopathy. If we consider this in 50 plus population, overall cataract was responsible for 58%, followed by non-trachomatous corneal opacity. So corneal opacity still is a public health problem. We need to tackle it thoroughly because many of the RAP surveys, they are pointing towards the corneal blindness as a second most important cause. Followed by cataract surgical complication, diabetic glaucoma, and then diabetic retinopathy. The prevalence of diabetic retinopathy was 16.9%, maculopathy prevalence was 7%, prevalence of sight-threatening diabetic retinopathy 3.6%, among non-diabetics 8%, and new diabetics 3.8%. So to conclude, there is overall reduction of visual impairment, but we have miles to go to achieve the goals set by the WHO through Universal Eye Health, released in the World Report for Vision 2019. In order to achieve universal eye health coverage, we need to have stronger integration of eye care within healthcare delivery system at all levels, with specific emphasis on primary healthcare level. The eye care services should be people-centric and to be provided closer to the communities to achieve their maximal potential. That's all from my side. Thank you so much for patient listening. Thank you so much.
Thank you, Rohan, for such a wonderful talk, giving a very brief of magnitude as well as cause of blindness in India. In fact, we remember in 200, we're saying there are around 17 million, then 2007 survey was saying around 12 million, but as per the latest survey, we have come down to 4.8 million.
Yes.
With increasing population, but overall number has reduced significantly. That's a big achievement, and visually impaired around 32 million. So and as you mentioned, cataract is still the leading cause, And the number 2 position, instead of any other disease, it is basically the corneal blindness. And then we have basically the complication of cataract surgery in the posterior segment. Thank you for explaining things so nicely.
Thank you so
much. I request our next speaker, Dr. Talveer Sidhu. Talveer is our favorite. She was from AIIMS. Currently, she's assistant professor in Government Medical College, Ludhiana. And she is a famous, would be definitely now very good glaucoma specialist. And I believe she'll be working a lot in epidemiology of glaucoma. So I request her to give her talk on prevention of glaucoma blindness. Talveer Sidhu.
Thank you so much, sir, for such a wonderful introduction. Also, thank you, the panelists, for including me in this session. I'm very grateful for being included in this session. I would like to present on prevention of glaucoma blindness in India. As we know, glaucoma is one of the target diseases in NPCB VI program. The magnitude of glaucoma in India, sir, am I audible?
Yeah, definitely.
Thank you, sir. The magnitude of glaucoma in India, as estimated in 2010, was around 12 million cases in 40+ population, out of which open angle glaucoma were 8.2 million and angle closure were 3.7 million, with additional 22 million angle closure disease patients at risk for angle closure glaucoma. Also, it was estimated in Chennai glaucoma study that more than 90% of glaucoma remain undiagnosed in the country. If we look at 1 million population, in 40+ population, we will have around 2,500 to 10,000 glaucoma cases, out of which around 10% are blind, which can be screened with visual acuity screening and cataract case finding. But the moderate and early glaucoma cases can only be detected with clinical case finding, which has multiple problems. And when we talk about glaucoma blindness in India, if we look at the report of NPCB VI 2015 to 19 survey, around 5.5% of blind with visual acuity less than 3/60 are due to glaucoma. But this is a gross underestimate when we look at what is the definition of glaucoma blindness according to the visual fields, less than 10 degrees, where the visual acuity might be 6/6. There are multiple issues in glaucoma control. First of all, there is lack of awareness about glaucoma. In prevention of glaucoma, there are no specific modifiable risk factors. In early diagnosis of the disease, intraocular pressure measurements are not sensitive, as it has been noted in previous studies, that more than 80% of patients who have glaucoma might have intraocular pressure less than 21 millimeter of mercury. A good skill set is required for early identification of glaucoma with adequate HR training. Because of poor availability of resources and equipment at the secondary and primary levels, it is very difficult to diagnose glaucoma early. Also, in treatment, there is a lot of cost of medication, which is there. Also, the glaucoma compliance, which is needed lifelong, and the facilities which are needed for monitoring of the response to treatment should be available at the primary level. Low vision aid services are only as of now available above the secondary level, not at the primary or secondary level. So what have we already done in glaucoma blindness prevention? First of all, for raising the awareness of glaucoma, we have the World Glaucoma Week, which is celebrated in March in every year. Also, India has constituted Glaucoma Task Force in 2016 to 17, where the training of trainers was done from 22 RIOs. After the training of the trainers trained the district ophthalmologists for diagnosing early glaucoma and forming a referral link. We also distributed education resource material, which was provided to the trainers and the district ophthalmologists. An online app was made with a special contribution by Dr. Vivek Gupta, which also allowed the district ophthalmologists to report the glaucoma cases to directly to the health ministry. There was training of the district ophthalmologist in terms of the comprehensive eye examination and surgical skill training, with including live surgery and wet lab training. There was an increase in the number of patients diagnosed with glaucoma after this intervention. Also, there was a constant reporting of the program, and we have tried and we have actually linked the district ophthalmologists to the RIUs. Also, NPCB government provides support for glaucoma management in terms of 2,000 rupees for investigations plus medical treatment for both eyes or surgical treatment for one eye. In Ayushman Bharat scheme also, we have included the glaucoma package for glaucoma surgery and post-op medications for 12 weeks. And in AIOS expert group meeting, we have already devised preferred practice patterns, not only for primary angle closure glaucoma, but also for open angle glaucoma. This is available on the AIOS website free of cost, the PDF for anybody to read, especially the district and general ophthalmologists. The WHO CRO expert group meetings under the guidance of Dr. Promila Gupta have already been done to identify the plan of action for the primary angle closure disease management in these countries. Now, what is the way forward after this? In glaucoma control strategy in vision centers, it is very important for awareness, early identification, and forming a referral linkage. In district eye hospitals, we should have trained ophthalmologists and optometrists with diagnosis and treatment, especially YAG laser should be available at the district eye hospitals with glaucoma medications. In the medical colleges, there should be equipment for training of eye specialists, research, and cost-effective management. Especially at all the medical colleges, there should be glaucoma clinics that should be established. At national levels, we are already developing the guidelines for management of glaucoma. We should have mass media campaigns and distribution of health education related material, which we have already started. So in summary, there should be evidence generation by surveys. There should be creation of awareness of glaucoma at all levels from primary to the tertiary levels. The monitoring and budget is important in monitoring the glaucoma management. There should be opportunistic screening of all 40 plus populations and the family members of glaucoma patient. Treatment facility at district level is important, and follow-up and availability of medications from the primary level is important. At last, thank you to my alma mater and community ophthalmology department of RP Center for leading to where I am right now. Thank you so much.
Thank you, Talveer, for the excellent talk and giving us details about various strategies for prevention of glaucoma blindness. In fact, I can tell you in Vision 2020 Right to Sight program, global program, glaucoma was not included as an important cause which can be avoidable cause of blindness. But in NPCB, Government of India Vision 2020 program, we included glaucoma as one of the important component which is avoidable cause of blindness. Now, thank you very much, Talveer. Dr. Promila would like to say something, ma'am?
Besides all the measures that Dr. Talveer has brought up in her presentation so beautifully, I'd also like to say that we also advised all the district ophthalmologists also to start a glaucoma clinic in each district hospital also. And during their screening camps, they should also screen patients not only for cataract and refractive error, but for glaucoma and DR also. So these were two important directives that NPCB gave to all the district ophthalmologists.
Thank you. Now I would like to invite our next speaker, Dr. Thomas Cherian, who is a famous retina specialist from Little Flower Eye Hospital. And sir will be speaking about community intervention in retina practice. Dr. Thomas Cherian.
I don't think Dr. Thomas
I think Dr. Thomas is not available. So I'll go to the next speaker, Dr. Sucheta Kulkarni. She is also alumni of ICH London, has a lot of work on ROP. She is director in PBMA HV Desai Hospital. And I request her to talk about ROP, global and Indian scenario. Dr. Sucheta Kulkarni.
Thank you very much, sir. I hope I'm audible and my screen is visible.
Yes, Sucheta, yes.
Yes, okay, thank you. Yeah, so I understand we have overrun our scheduled time, so I'll try to be as brief as possible. And without any formalities, let us start with my presentation. So ROP, as we all know, is a vascular disorder of preterm infants which is potentially blinding. And this particular diagram shows the risk of ROP blindness in various regions of the world. And we in India are sitting here in the red region, where ROP blindness is about to explode very soon because of two factors: improved survival of preterm babies and lack of universal ROP screening coverage. So if you look at the causes of blindness, causes of childhood blindness, as per the level of socioeconomic development of any region, you see that vitamin A deficiency and corneal blindness forms a major chunk in very low income countries. But as any country progresses economically, and we have progressed from low income to middle income in recent past, and we have been able to take care of vitamin A deficiency to certain extent. Now that we've taken care of that blindness to a certain extent, ROP is on the horizon, and we are seeing increasing number of ROP blindness in our country. So this particular diagram shows again proportion of preterm infants who are becoming blind due to ROP, and you can see here this of this pie chart, the dark blue wedge represents the proportion of all preterm infants who are likely to become blind or severely visually impaired due to ROP. And you can see the size of the wedge here for the Asia is quite large compared to the size of the blue wedge here in the high income countries. And if we don't act now, this size is further going to increase in near future. So when it comes to risk factors associated with ROP blindness, we can see that in the first epidemic, supplemental oxygen therapy, rather unrestricted oxygen therapy, was the primary cause for ROP. That was in 1950s and 60s. Once that was realized and taken care of, eventually after 1970s and 80s, extreme prematurity became the cause of ROP blindness in the Western world. And right now what we are experiencing in India is the third epidemic, where our babies have features of both the epidemics. So modifiable risk factors as well as extreme prematurity are responsible for ROP blindness in India. So if we look at the birth characteristics of babies in the Western world, or say for UK compared to Indian babies, we can see that quite a large number of heavy babies are developing blinding ROP in India, which are way above the UK screening criteria of 1500 grams of birth weight and 32 weeks of gestational age. And this is why Government of India has recently, about 2-3 years back, they've launched a guideline where the criteria are babies of less than 2 kg birth weight or born before 34 weeks of gestational age should be screened for ROP. And as per a recent estimate, there are more than 3,000 infants who are likely to be going blind in India every year due to ROP. So what can be done about it? Prevention of preterm birth is not always possible, but by improving the quality of care, occurrence of ROP can be halted to a certain extent. Timely screening and treatment can prevent children from going blind due to ROP. And of the children who have gone blind despite all the efforts, we need to have more early intervention centers so that they are integrated into community as early as possible. If we take these actions very fast, I think hopefully we should be able to take care of this cause of childhood blindness in coming decades. Thank you very much for your kind attention.
Thank you, Dr. Suchita. Thank you very much for a nice talk. And in fact, in continuation, we have another speaker talking about ROP screening. Dr. Chandralekha Dey. Dr. Chandralekha is from Delhi, from Center for Sight, and she is involved in Vitro Retina program. So I will welcome Dr. Dey for her talk. Dr. Chandralekha. Kindly unmute yourself, Dr. Chandralekha.
Good morning, everyone. Am I audible?
Yes, yes, sir.
So I would like to thank the distinguished panelists for giving me this opportunity, and I shall begin my presentation. As we all know, ROP is a vasoproliferative disease affecting preterm infants and is one of the most common causes of avoidable blindness among children worldwide. And this goes through two phases of phase 1, relative hyperoxia, and phase 2, peripheral hypoxia, which causes pathological neovascularization. Just a brief overview where we describe ROP based on its locations in zone 1, zone 2, zone 3. The extent is described by the clock hours, each clock hour having 30 degrees, and the various stages of ROP, wherein stage 1 has a demarcation line between the non-vascularized and the vascularized retina. Stage 2, we see a two-dimensional thing converting to a three-dimensional thing. There is a demarcation bridge. Stage 3, there is extraretinal fibrovascular proliferation, and stage 4, we develop retinal detachment. In 4A, macula is not involved, and while in 4B, macula is involved. Stage 5 ROP is the end stage disease, and this is not something which we are hoping to see in children in the near future if we can intervene at the right time. So plus disease is again venous dilation or arterial tortuosity in two quadrants along with other associated factors. And APROP, which was first described in 2005, is a more posterior disease having rapid progression with poor prognosis. The treatment guidelines again in 2005 divides ROP into type 1 and type 2 based on the requirement of immediate treatment in type 1 and follow-up for type 2 disease. The problem statement from a public health point of view is that in Asia, with its middle income countries, it accounts for about half of the world's preterm birth and ROP-related blindness. Countries with suboptimal quality neonatal care have been identified to lead to infants who are larger and more mature, just like Dr. Sucheta ma'am has already mentioned, and they develop more severe and aggressive posterior ROP. So what are the guidelines which are available, and they need to be country specific because of the prevalence of sight-threatening ROP in older and heavier babies as compared to newborns in the developed world. The Rashtriya Bal Swasthya Karyakram of 2019 includes ROP screening as part of the Universal Eye Screening Program, and I shall be dwelling on the technical component of it. The recent screening guidelines are available in this particular website in the PDF form. So who should be screened? All infants gestation age 34 weeks or less, gestation weeks of 34 weeks more if exposed to risk factors, and if gestation age is not known, then the birth weight of 2,000 grams or less. Other preterm infants at the discretion of the treating neonatologist or pediatrician. The risk factors considered are mechanical ventilation, prolonged oxygen therapy, and hemodynamic instability. When should the screening be done? The first screening ideally should be done in infants who are greater than 28 weeks of gestation, should not be later than 4 weeks of age or 30 days of life. For infants who are less than 28 weeks or less than 1200 grams, the first screening should be done 2 to 3 weeks of age. Who are involved in the program? The ophthalmologist, the SNCU medical officer, the SNCU nurse, and optometrist for review of the screening schedule. Where should the screening be done? Ideally, of course, in the SNCU or NICU. However, if done in the ophthalmologist clinic, arrangement for basic resuscitation equipment is necessary. What are the equipments required for screening? A binocular indirect ophthalmoscope, 20, 28 or 30D lens, Alfonso's speculum, and a wire speculum for scleral indentation. The two methods are indirect ophthalmoscopy with documentation, retinal imaging with wide field camera, example a RETCam. It should be done under topical anesthesia, no sedation should be used. Apnea and bradycardia may rarely develop, hence resuscitation measures should be available. This is a RETCam image. So pharmaceutical agents which are required for us to screen are tropicamide 0.5% with phenylephrine 2.5%, proparacaine 0.5%, and an antibiotic eye drop. Commercially available tropicamide 1% and phenylephrine 5% can be diluted 1:1 with methyl cellulose and used. We should wipe out the excess eye drops from the skin. because they get absorbed very easily. The drop should not be instilled more than 2 to 3 times, 10 to 15 minutes apart, and we never use atropine for ROP screening. One of the most important aspects of ROP treatment and management is communication. So communicating with the parents of the neonate is extremely important, along with informed consent and documentation of the same. The technique of the same is informed consent of parents. The child should be fed 1 hour prior to examination, should be dilated 30 minutes prior to examination. The infant should be swaddled properly, and assistance should be there to restrain movements. Proparacaine should be instilled in both the eyes. We wait for 30 seconds and then insert the eye speculum. Examination should be done by a trained ophthalmologist using a BIO. Oral sucrose solution helps in analgesia. In certain areas, wide field fundus camera is also being used. This is a technique which shows how to correctly swaddle an infant to make the child comfortable and also to restrain the movements. The examination procedure is first to examine the posterior pole for presence or absence of plus or pre-plus disease, and this should be done without scleral depression. Then we examine the rest of the retina for the stage, zone, and extent of ROP according to the ICROP classification. Each quadrant should be examined. We also check for presence or absence of APROP and then decide what treatment is planned or what follow-up is advised. The precautions to be taken while screening an infant, first of all, of course, hand hygiene, preferably in SNCUs. Monitoring of vitals and sick kids should be done. The child mentioned fed 1 hour prior to examination, pre-treatment with proparacaine, sucrose for analgesia, and most important is to keep the examination as brief as possible. What are the review protocols? So 1 week or less for ROP stage 1 or 2 in zone 1, ROP stage 3 in zone 2, 1 to 2 weeks in case of immature vascularization zone 1, ROP stage 2, zone 2, regressing ROP zone 1, 2 weeks for ROP stage 2, zone 2, regressing ROP zone 2, 2 to 3 weeks for immature vascularization zone 2, ROP stage 1 or 2, zone 3, and regressing ROP zone 3. When do we stop screening? So first full retinal vascularization, 40th week of PMA and sometimes 45th, or regression of ROP, complete regression to be noted. Telescreening for ROP, because of the prevalence of a low ROP ophthalmologist to preterm baby ratio, also the sensitive medico-legal aspects involved. Sometimes also because of the inter-examiner variability, especially in relation to plus disease, telescreening with CBIA is a very good option, and that will be discussed by the next speaker. The public-private model, which has been encouraged by our government and ministries, is extremely important because it has been noted that semi-urban, rural, and urban SNCUs seem to have almost an equal burden of ROP. So in this particular model, the private institute designated by the government sends trained technical staff to visit designated NICUs on fixed days of each week. These staff take a fundus photo with a wide field camera, and the photos are then remotely read by the trained ophthalmologist who advises appropriate management and makes arrangement for the same. This particular model is extremely successful in the Indian state of Karnataka. So how did it get so late so soon? This particular quote best describes our approach to ROP and for successful management of ROP. Thank you.
Thank you, Chandrika, for such a wonderful talk. It was really informative, very nice, and you also stick to time also. We have one more talk on ROP, and we can have comment from Dr. Pramila. So I would like to invite Dr. Vasumati Vandatam. She is a retina specialist and pediatric ophthalmologist from Radhatri Netralaya. I know her personally. She is a fantastic, very dedicated person. So I request her to talk about retinopathy of prematurity through telemedicine. And Dr. Vasumati, please. Please unmute yourself, Vasumati. Vasumati, please unmute. Yeah, thank you.
Yeah, I've unmuted myself. Thank you so much, Delhi Ophthalmic Society, for the kind invitation. And thank you, personal thanks to Dr. Praveen Vashisht, and it's nice meeting you over Zoom. And I would like to share my slides.
Yeah.
Is my slide visible?
Not yet. Yes,
Yes.
it is visible now. Thank you.
Okay, so I put it on slideshow, and my talk for 6 minutes will be on ROP screening by telemedicine. And as you're aware, our retinopathy of prematurity happens because the preterm babies are born much before their time. And it's one of the commonest causes of childhood blindness. And we are facing the third epidemic of ROP in the world, thanks mainly to middle income countries such as India. And it's a key feature in the Vision 2020 of the World Health Organization also. And this is how it all starts. And if untreated, it's curtains down. And that's why treatment of ROP and identification of babies with ROP is an emergency. And these babies need to be treated within 48 to 72 hours. Otherwise, and sadly, even now, if we go to, say, a blind school, you can see many babies with such appearances mistaken to be cataracts, whereas it is just the stage 5 ROP. So how severe is this problem in India? In India, roughly we have live births of, totaling up to 2.7 crores annually, with a crude birth rate of 2.4. We account proudly for 20% of live births in the world. And roughly 13% of these, about 35 lakhs, are preterm births. And if we consider my state of Tamil Nadu, its population is 7.2 crores by the 2011 census, with a birth rate of 15.9%, and the total number of preterm births about 12%, which would need ROP screening. Roughly 1,34,000 babies need to be screened every year for ROP in my state alone. And this is just a statistical analysis of a 3-year period. This was long back in 2007 to 2010. We are a tertiary referral center for ROP in Tamil Nadu, and total number of babies screened were 521, of which total number of babies with ROP were 201. Of course, the numbers could be high because we are a referral center. And 143 babies underwent laser. And of these 143 infants who were treated, if you see the savings to the society, it's approximately $55 billion. So this is the importance, this is just to stress the importance why we need to do energetic ROP screening. And the key to successful outcome in ROP is timely screening and treatment by laser photocoagulation. And treatment is by vision preserving laser treatment, which if done appropriately and at the correct time, 100% vision can be preserved. Now, why do we need, so we are doing ROP screening. This is a picture of I am myself doing the ROP screening by indirect ophthalmoscopy in a government hospital in Chennai. But why do we need to do ROP screening by telemedicine? Why do we need to extend this project? This has been actually my long-term dream, to do ROP screening by teleophthalmology. And we had the genesis of this project called Project Vision on Wheels. And why do we need it? Because the number of babies needing ROP screening and as well as emergency laser treatment has nowadays increased, even in the rural areas, because of awareness, as well as we have a lot of preterm births in India. In fact, India is world #1 in preterm births. And more preterm births happen in the lower socioeconomic and rural sections of society. And we have only about less than 100 pediatric retina specialists who are adequately trained to manage and treat this ROP. So because of, and it's not possible for the pediatric retina specialist to keep going everywhere to the villages to screen these babies. And these babies may require 2 to 3 examinations before they are declared to be free of risk. So we need a teleophthalmology project by means of a camera, which is portable, which goes and takes the pictures of the baby's eyes. And by internet, the pediatric retina specialist can decide which baby needs treatment, and the baby can be brought immediately for treatment. This is the launch of Project Vision on Wheels in June 2018 at Radha Netralaya. And this is the camera which we place on the baby's eyes, and the picture is immediately seen on the monitor. And this is the van which is used to transport the camera and the technicians to the periphery. And this is the picture. This is just a small video illustrating. This is in Perambalur GH. Perambalur is about 300 kilometers from Chennai. So there we routinely send the van almost every alternate week on a Wednesday. And in fact, our van goes every day to one particular taluk or a village about at least 200 kilometers from Chennai, from Monday to Saturday. And this is the picture of the baby's eyes, and you can see the optometrist explaining the findings to the baby's parents, so that their understanding is also better, because most of these people are from rural areas. So if explanation is not done and they don't see for themselves what's wrong with their baby's eyes, they don't come for treatment. They say externally the eye looks okay. So this is the small video, and this was how it started. We had first initially 2 babies from the remote Virupuram Taluk, and after that the project has not looked back. Once we had 7 babies from tribal areas from in the Tirupattur belt. Tirupattur is about 285 kilometers from Chennai. So, and this is how we maintain where we go and how many babies we see and how many babies were referred. And these are some of our Vision on Wheels babies whom we have successfully treated, and now the babies are about 2 years old and seeing very well. And it's a very gratifying thing to do and see. And we have not stopped even in the COVID times. We make sure that the patients where we go to screen are seated like this with masks and social distancing maintained. And our optometrist also wears the PPE and gloves and mask and a hood, and everything is done under sterile conditions with autoclave speculums. And alcohol swabs are used to wipe the red cam probes also. So thank you very much. I will just leave you all with a short video just to tell you our journey in ROP screening at teleophthalmology. Retinopathy of prematurity, ROP, the blinding disorder affecting preterm babies. My journey amidst these tiny babies started in 2000. At first, when I saw the tremendous bleeding which could happen inside such tiny eyes, I was horrified. Later, when I realized that with timely laser treatment, this bleeding would vanish and sight be restored, I was mesmerized. And the gold standard of ROP screening is indirect ophthalmoscopy, which necessitates the pediatric retina specialist to be personally present in the NICUs where the tiny babies are housed, or the babies have to be transported to the pediatric retina specialist office. There are only about 150 pediatric retina specialists in India, and ROP is very much a rural problem as well, thanks to maternal malnutrition, illiteracy, and ignorance. So it is not practical for the pediatric retina specialist to travel to these villages to screen these babies for ROP, because each baby might require 3 to 4 examinations before it is declared to be free of risk. Hence the need for teleophthalmology. We were able to procure a retinal camera which could be transported to the villages. A mobile van which could transport our technicians and the camera was also donated to us by several industrialists and well-wishers and patients. Our well-trained technical team puts the retinal camera strobe onto the infant's eyes, and immediately the picture of the retina is seen on the monitor, and the pictures are graded by these technicians who are trained in the diagnosis of this disorder. And it's a very good tool to educate the concerned parents also. This screening of babies in rural areas by teleophthalmology, and to ship these babies immediately for timely laser treatment was my long-term dream. And finally, in June 2018, Project Vision on Wheels took flight and my dream came true. ROP became my passion and inspiration to do good, and a commitment for life. So that was just a short video, and now the numbers are like we have screened about 15,000 babies all over rural Tamil Nadu and treated more than 560 of them free of cost. This is through Project Vision on Wheels alone by Teleophthalmology. So thank you so much for the wonderful opportunity to present our work and our inputs on ROP screening by Teleophthalmology. And thank you, Dr. Vashisht and Teleophthalmic Society for the kind invitation. Thank you.
Thank you, Dr. Vasumati. I request Dr. Pramila to give some comments on ROP3 talk. Yes. Yeah.
I think with the improving neonatal and RCH services, our load of ROP is going to increase in future with more and more babies of low birth weight and prematurity being saved. And it's our duty, and we require dedicated and passionate retina specialists like yourself, ma'am, and the others who are working in this field. And I feel that we should develop at least one such center in each state. And in bigger states, we might need even 2 centers where these things can be done. Only then we'll succeed in treating all the babies who require this ROP treatment. Thank you.
Thank you, ma'am. Now I'd like to invite next speaker, Dr. Suraj Singh Sanjam. Suraj is additional professor in community ophthalmology, working with me and Vivek. And he is also having a passion for working for low vision, visually impaired patients. So I request him to talk about profile of patients attending Vision Rehabilitation Clinic at RP Center for Ophthalmic Sciences, AIMS, New Delhi. Suraj, welcome.
Thank you, sir. First of all, let me share my slides before I. Where is whiteboard, ground. Our share screen supposed to be here. Why it is not here? It's supposed to be here when I click the share screen, and it is in the slide is in my desktop, and when I share screen, it is not showing. What a surprise.
Suraj, you can speak like this only.
Yeah.
You can use your slide
Yeah.
from your desktop and then speak.
Yeah, but supposed to be when I click the share screen and the page it comes, it should be because the slide is in my desktop, and then it is supposed to be here. Why? I'm totally surprised because this morning I had another talk at 9 o'clock in the morning. So anyway,
Doesn't matter. You just speak.
Okay.
See your slide. We may not
Okay,
be
we are
able
running
to
out
see
of.
your slides.
Yeah, we are running out of time.
Like that. We'll hear you.
So anyway, once again, thank you, ma'am, Dr. Pramila, and my colleague from RP Center for inviting me for a talk on the clinical profile of a patient attending LBR clinic in RP Center AIMS. So to begin with, I must thanks to that CBM for supporting our low vision and vision rehabilitation service in RP Center since 2015, and our rehabilitation service is upgraded in 2019, and we have improved so much in terms of infrastructure, in terms of devices, in terms of manpower, in every angle. So when you talk about this vision rehabilitation, so
Just
we
a
have,
second, please. Just a second. Dr. NP Singh, I think by mistake you have clicked your share screen. So kindly stop sharing your screen. Thank you. Dr. Suraj, please continue.
yeah, ma'am. Oh, it's there now. Is it visible?
Yeah, yes. I think
Oh,
yes.
okay. Okay. So So anyway, this is the, I mean, we have upgraded our center, our vision rehabilitation and training center. So as you know that, when you talk about this visual disability in terms of low vision and the blind, so every individual has some unique requirement, right from their, their say age and their, genders, and there are so many different unique requirements for each and every individuals. And apart from that, this provider also, so gives a big challenge because of this unique requirement for each and every individuals. So there are so many impacts, like which affects the person suffering from low vision and the blindness. So starting from the compromise in terms of daily living, up to the economic burden, mental crisis, education. There's so many, quite a range of, problems that is affected by the low vision and blind. So while managing this visual impairment, people with visual disability, so in the on the right side in the Venn diagram, so starting from the enhancement of the visual function up to the promoting health, this is an entire range of service we need. So these are some of the service very quickly before I go to the clinical profile. So we provide starting from the counseling and vocational training and vocational counseling, not vocational training, but what we do, we provide vocational counseling. And training is very, very important, including the adaptive training. So we also provide the initial training, and then we further refer to our networking NGOs. And for children, especially, it's different from what adult persons needs for a child who have visual disability. So for them, we need to have a separate, service, which is, very like needs and required for a child having a visual disability. So maybe in terms of reading, writing, math, science, and counseling, and tactile training, texture. These are some of the very important service that required by a child with visual disability. Now coming to the demographic profile, as I mentioned, so our service was strengthened, upgraded in 2019, but here I'm presenting some data since for 2 years, 2018 and 19. So the majority of the patients that we register are from Delhi and Uttar Pradesh and Bihar. So nearly 36% of the patients are from Delhi, and Uttar Pradesh, of course, it's another major patient who visit our vision rehabilitation clinic. Now coming to the gender distribution, age and gender. So when you look at the age, so it is categorized into less than 18 years and more than 18 years. So less than 18 years, it's around 33%, because this group of children needs mainly education. That's why we categorize less than 18 years and above 18 years. So the first is they need some kind of education, and the second, more than 18 years and above, they need some kind of, say vocational training, okay, their livelihoods, there's some sort of, because they don't require any more education, most of them. So that's why we categorize as into two category in a simple way. So now coming to the visual disability. So we have a range of visual disability starting from 618 up to PL positive or negative. So when you look at distribution, first distance, see this group of group of patient, so they don't require, while providing so vision rehabilitations, those magnifiers. Okay, so this less than 160 to PL positive, PL negative, so they require tactile and sound device to be able to live independently, to be able to perform their daily activities. So we should be encouraging to use those tactile and sound device for this particular group of people. And whereas in the above, less than 618 to 160, so we better recommend those visual based assistive device, maybe magnifier. That's why you categorize these two those vision, best corrected vision into two. Similarly in vision, near vision, so starting from the less than N notation N10 to N6, and this N18 onwards, N18, so this group of patient, they will be needing those visual based devices in terms of large print book, because for large print books, usually the font size is N18. So this is the cutoff is better used because this rest of this someone is able to read N36 because this is nearly blind, so nearly like finger counting close to face. So this group of individual, if you prescribe those visual based devices, it's hardly useful for them. Now coming to the male and female, mostly in terms of visual categorizations. When you look at the distribution, so male is usually nearly 71%. So female is slightly, significantly lower than the male. Those patients visiting our clinics. Similarly, near vision, based on the near vision also. So male is always higher. So now coming to the morbidity profile. So as we know that retina, that's a problem with retina. So most of the patients, nearly 64% of the patients, they have a retinal problems. Patients reporting our clinics. So most of them, they have this. And the second most common cause is a whole glove. So now coming to in deep details. So there's the retinal problems, whole glove, optic nerve, cornea, lens, and others. So coming to retina. So those about 64%, the most common is congenital disorder and RP, and these are some of the common disorders, retinal problems that presented in our vision rehabilitation clinic. So coming to the whole globe as well. So phthisis bovis is another common, and similarly albinism. So these are some of the ocular disease profile that were presented in our vision rehabilitation clinic. Coming to the gender-wise morbidity, so as I told you, males are always in the higher side compared to the female. So this is the message. I think it is the last slide. It's a very quick message. So retinal problems are the most common cause of visual disability. When we talk in terms of this vision rehabilitation training, the presented in our clinic, and the males nearly 70%, above 70%. So present in our clinics than females, and 50% of them they need a tactile and sound-based assistive device. So this group of individuals, they don't. Most of them, they are not willing to use those magnifiers because this is less than 160 blindness. So for the students having this less than 160 blindness, so if you prescribe magnifier, it's not predictably useful for them. So we always prefer to go for those tactile and sound based for those group of individuals. So this is a quick thank you for listening.
Thank you, Dr. Suraj, for a very nice and lucid presentation on a subject on which many of us are not well versed in, and highlighting that retinal problems are the main cause, where in most of the cases, sound and tactile devices will be more important rather than just magnifiers. So thanks a lot, Dr.
Okay.
I think we should move, Dr.
Thank you, Suraj. Now, as Dr. Sara is not available, so we'll request Dr. NP Singh to talk about rising prevalence of myopia, a study of and causative. Dr. NP Singh is head of the department in Baba Saheb Ambedkar Hospital, and I request him to share his slides and give the presentation. Dr. NP Singh.
Good morning, everybody. Today, I would be talking a bit about rising prevalence of myopia, in which we carried out a small study to understand a bit about the positive factors. Can I start my slides?
Yes, please.
Okay, thank you. It's been an observation for each one of us in our OPD that we are getting more and more of myopic children these days. Though this is good for our professional interest, but then we must be more logical about it. So this is rather the commonest refractive error that we come across. And in fact, this is one of the world's leading cause of functional blindness. And if we go by the statistics, there are about 1.9 billion myopics in the world today, which covers up almost 27% of the population. And if this trend continues, then by 2050, probably this number would reach 5 billion, and almost half of the world would be myopic. Among the myopic population, almost 70 million myopes today, they are having high myopia. And they carry 4 times more risk of developing RD, macular pathology, cataract, and glaucoma. Now, we started looking out for the factors which are responsible for this increased prevalence. Of course, genetics is the most important one. The exact inheritance, whether it is autosomal dominant, recessive, or X-linked, is of course not clear. But one thing is established, that if both the parents are non-myopic, then almost 7.3% of the offspring are likely to be myopic. To one parent myopic, almost 25% of the offspring is likely to be myopic. And with both the parents myopic, almost 45% of the offsprings are likely to be myopic.
NP Singh, we are not able to see your slides.
Okay. Is it visible now?
Yes, it is visible. Yes, yes, now we can see.
And other than the genetics, environmental factors are equally important, especially in Asian countries where we have high near increased lack of accommodation, and of course there is a tendency for the children to display screens like laptops, mobile phones, etc. So we started this study on 4 environmental parameters, which included near work, outdoor versus indoor activity, abnormal reading posture, and increased screen time. If we look at the basic pathophysiology, the retinal pigment epithelium and the choroid, they both act as conduits to relay regulatory signals from retina onto the sclera, which leads to increase in size of the eyeball. And increased near work also causes what we call as hyperopic defocus, where the light gets focused behind the retina in the periphery of the retina. This stimulates the growth of posterior part of the eyeball. This is an attempt by the eyeball to shift the retina and the point of clearance onto the retina itself. So this leads to, again, elongation of the eyeball and hence myopia. So we conducted this study at our hospital, Dr. BSA Hospital, and nearby school wherein we studied, and it's a questionnaire based study, and we asked certain questions related to near work, display time, indoor versus outdoor activity, and number of breaks taken up during the near work in 300 school students from age group of 8 to 12 years. We found that children who were mostly devoted for the near work, that is, they were doing more than 4 hours of near work, among them, this instance of myopia was about almost 56%. And those children who were doing less of near work, up to 4 hours, less than 4 hours, they had incidence of myopia up to 44% only. Display time was again a very important thing. And those who were doing their display screens, etc., for less than 2 hours, they had an incidence of 29% almost, and more than 2 hours had an incidence of almost 70%. Again, if we look at the outdoor activity, those children who were doing more of outdoor activity, they had almost 59% of them were myopic, while those who were doing less of outdoor activity, more people had myopia, that is 62%. And another thing that was very well established, that rather than the duration of near work, it was, what is important was the number of breaks during this near work. And it was found that myopics, they either take no break or just one break per hour for their near work, while non-myopic population, they take almost 2 to 3 breaks per hour. So what was concluded was that, of course, genetics plays an important role, and other than genetics, environmental factors also do play a important role, which includes increase in near work, increased indoor activity, and more time spent on mobile phones, and of course, the important thing, the number of breaks during the near work. So what we would like to recommend, that let us target at the children which are up to 6 years of age, and we should see that they should concentrate equally on the outdoor activity for at least 2 to 3 hours per day. And in fact, school should add the activities in their curriculum wherein children could have some outdoor activity during the school hours itself. And of course, during the near work reading, 20-20-20 formula should be maintained, wherein 20 minutes of near work should be followed by 20 seconds rest period by looking at a distance of 20 feet. And reading distance, of course, should be maintained at 40 centimeters. Of course, we do need to have an upright posture while studying, and too much of screen time has to be avoided in children. At least for less than 2 years, we don't recommend any screen time. And from children to 2 to 12 years, at the maximum 1 hour of screen time. And for teens and adults, we can go up to 2 hours. Thank you very much.
Any comments?
Ma'am.
Dr. Praveen?
Ma'am, actually, yeah, recommendations are definitely good, as we know, but probably the study done, the sample size is 300 is too less. And the concept of incidence actually is not, he has taken proportion of incidence, not actually the incidence of proportion. Because the incidence of myopia is around, say, 1 to 2% only in 1 year in new cases, and the prevalence is around 10%. But still the recommendations are very good. In fact, I suggest some of the studies, bigger studies conducted by Dr. Rohit Saxena and our team, Dr. Vivek, myself, in a sample of 10,000 children. And that gives actually the prevalence, incidence, and the risk factor for myopia. They should be, I recommend such kind of studies. It's a huge sample size, which will be very useful. Thank you, Dr. Singh. Thank you.
Great. Thank you, Dr. Singh, for a nice presentation. And it is, Dr. Vivek, you wanted to say something, please? Dr.
Yes,
Vivek.
sorry. So this is a topic which is very close to, our hearts in community ophthalmology. We have been doing a lot of myopia research. Sir already alluded to the NIM study, North India Myopia Study. In fact, recently we had a very interesting observation wherein we nearly found 5 times the difference in prevalence in myopia in rural children in government versus private schools. I mean, the prevalence difference was huge. Even though it was low, but still it was a significant difference of 2% versus 10%. And when we inquired about as to, outdoor activity was definitely one of the reasons we were looking at. And we realized that in government schools, children were outdoors all the time. There were classes were being held under the tree. So when we actually inquired from them how many hours you were outside, PT period and all, they could not give an answer because they were outside throughout the school hours. Possibly, I can't think of any other reason that would explain such a huge difference in prevalence of myopia. And this is something which merits a lot of investigation, ma'am, like as we move forward from cataract. So obviously we are looking at diabetic retinopathy, glaucoma, and other irreversible causes, but we have to focus on the children and look at modifiable risk factors.
And I think this COVID pandemic can further precipitate if all these studies are this thing, then COVID pandemic may further precipitate a pandemic of myopia, or should I say the increased prevalence of myopia with the kids having so much of screen time now. So,
in fact, just this month, there is this article in IGO which has actually quantified screen time, and they have looked at, I think, the computer vision syndrome questionnaire.
Yes.
The significant, increase in eye irritation and dryness on account of screen time because during COVID. So,
yes.
In fact, ma'am, we are doing one study with DST. We are looking for this outdoor exposure risk factor. And luckily, we have also collected information during this COVID time, the exposure to outdoor or something. And when we look the prevalence of myopia after this COVID, probably we can actually document good proof that outdoor activities, reduction in outdoor activities, it is leading to reduction in myopia.
Yes.
That will probably come out with a good evidence.
Yes. So thank you everybody for participating in this webinar and giving their valuable inputs. And I think this has been a very fruitful session, though we have been delayed quite a lot and it was a long session, but still these deliberations were very important. Thanks a lot. And we discussed on everything, I think every aspect of visual impairment and blindness. It's a good, fruitful session. Thank you. Thank you all.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am. Thank you.
Thank you.
See you guys.
Hello, Namrata. You are silent. Unmute yourself, Namrata.
Yes, sir. Hello, sir. Hello, sir.
How are you?
Good, good, sir.
14 halls running?
Yes, sir. And all of them are Facebook Live and YouTube Live also.
Great. Logistics, big logistics. Huh?
Hmm. Hello.
हाँ जी मैडम. Welcome, Rohit.
Thank you. Hello, sir.
How are you?
Hello, sir. Good. I'm good. Rajesh is also here.
Welcome,
Good
Rajesh.
afternoon, sir.
कैसे हो राजेश?
बस बढ़िया sir. Hi Rohit. Hello, ma'am.
Lovely AIMS background.
This is the old art.
RP Center Banga. RP
Yeah,
Center.
yeah.
That's right.
Yeah. Rohit Behind his background.
I think
Behind me is the
AIMS background.
central lawn. Yeah.
Yes.
Yeah.
Most picturesque part.
Yeah, that's true.
पहले
Still
पहले
is.
सारा एम्स इतना ही ग्रीन होता था.
हाँ,
तुमने
अब
बिल्डिंग
यही
बनानी
बचा है.
शुरू की ना. हाँ.
यही island in the concrete. Good.
I think can we start now? Dr. Dadia will join in some time.
Okay, perfect.
I had requested even Dr. Khanna, Sanjay Khanna, Rajendra Khanna, and Sanjeev Mohan, Rajiv Mohan to also join. But so I welcome everybody to this DOS Oration session 2020. And I have with me the president who's going to be joining very soon, Dr. Subhash Dadia, and all the executive members of Delhi Ophthalmological Society. It is our proud privilege to confer the Dr. P.K. Jain Oration DOS 2020 to none other than Dr. A.K. Grover. Dr. A.K. Grover, sir, is the recipient of prestigious Padma Shri Award by the President of India. He is currently the chairman, Department of Ophthalmology, Sir Gangaram Hospital and Vision Eye Centers at Siri Fort Road and West Patel Nagar, New Delhi. He's the president of Oculoplastic Society of South Asia, chairman Subspecialty Education International Council of Ophthalmology, counselor at large of Asia Pacific Academy of Ophthalmology, and board member of the Afro-Asian Council of Ophthalmology. He's also the vice president of Ocular Trauma Society of India, the past president of AIOS, Asia Pacific Society of Ophthalmic, Plastic and Reconstructive Surgery, and OPAI. He serves on the editorial board of the APGO, Indian Journal of Ophthalmology, Nepalese Journal, Journal of International Medical Science Academy, Ocular Surgery News, and is reviewer for several international and national journals. He's an examiner for FRCS Glasgow, and he's received numerous prestigious awards and orations, including Distinguished Service Award from APO. He's got honorary FRCS, honorary Fellowship of International Council of Ophthalmology, FICO, and also is the recipient of Colonel Rangacharya Award for the best paper from AIOS. He's authored, edited 5 books, written over 80 chapters in textbooks, and has over 60 publications and over thousands of presentations at international and national level. Chaired sessions and has been guest speaker as well as performed live surgeries at all over the world, including the World Congress, APO, Afro-Asian Academy, American Academy of Ophthalmology, British Oculoplastic Surgery Society, APSOPRS, and several other international and national meetings. And it is my privilege to welcome Dr. A.K. Grover and also to request him to give his oration, that is Dr. P.K. Jain oration for the year 2020. Thank you, sir, for accepting the same, and we would now request you to please deliver your oration.
Thank you. Thank you, Dr. Namrata. So is it visible now? Is
Yes.
my screen share there?
Yes, sir, very much.
So I'm privileged to be the recipient of Dr. P.K. Jain oration and would like to thank the Delhi Ophthalmological Society, its executive, Dr. Namrata, for this privilege. It had been a great privilege to know Dr. P.K. Jain, a very unassuming, very humble, very nice person, and he was a great source of inspiration to us as youngsters. And we really do miss his presence in Delhi Ophthalmological Society. Thank you again, Delhi Ophthalmic Society, for this privilege. I'm going to speak on the subject of congenital ptosis, my tryst with innovations over the last quarter century. As Nelson Mandela said, things always seem impossible until they are done. And it is this desire to carry out what you want for your patients which brings you to newer and newer innovations. Congenital ptosis, with all its variations, is always a huge challenge, and its management requires a combination of science and art. Ptosis surgery really transforms lives, makes them live a life which is really qualitatively so very different from one they would have been forced to live with a ptosis, like in this patient with jaw winking ptosis corrected after surgery. However, the journey to management of these patients is not an easy job, and we often are faced with many difficulties which force you to think and innovate. Let's look at how we manage ptosis today and its evolution through a journey of what we had to do when we started some 30 years ago with virtually no facilities and most surgeries not being done in the country or in the world. Evaluation has undergone a sea change. We can assess much better and take an appropriate decision for each of the subtypes of the congenital ptosis. The choice of surgical procedure has also undergone a very significant change as we have gained experience in the management of these cases and we've learned to communicate with the relatives and with the family to make them understand the best that we can offer. For the milder cases, we choose to do the Fasenala Servet surgery, and the procedure that we do today is a procedure that Dr. Bitheria, me, and Dr. Kalra described in 1983 and was selected for the yearbook 1984. This modified surgery avoids crushing of tissues, avoids central peaking, and avoids suture keratopathy, which were the hallmarks of the original procedure, which was carried out with Putterman's clamps. And this has been possible with a set of traction sutures, which allow the dissection of the tissue to be done in a very uniform fashion. I'll very briefly go over the video. The first set of traction sutures is closer to the everted upper border and holds the tissue that is to be resected. The second set of sutures is placed closer to the fornix and really holds the tissues together for the suturing after the resection has been carried out. So when a uniform piece of tissue is resected, a suturing is done in a fashion that allows all the knots to be buried and the procedure to be carried out without causing any exposed sutures to cause irritation. This results in a correction which can be very predictable and give results that are most astounding. The reproducibility of the results is what is important, as you can see in this pre-op and post-op patient in the straight gaze, upward gaze, and downward gaze. We modified the protocol for intraoperative decision-making in levator resection based on our own experiences, and we were able to get much more reproducible results by modifying the Burke's nomogram for intraoperative positioning of the muscle. And this was only possible after we did a huge study of over 100 cases, and we could then choose a nomogram that fitted in with our patients. Results can be extremely gratifying in appropriate patients with very little lid lag and lag of thalamus. For severer cases, frontalis sling procedure is the choice, and it is in this area that we've been able to make a very significant difference. The autologous materials obviously have the advantage over the synthetic materials, which tend to cause recurrences, infections, and granulomas. These complications make fascia lata the procedure of choice. And the fascia lata procedure that we carry out is a technique that we have evolved over a period of time. It's a modified Crawford technique. When we started the fascia lata sling surgery, there was no one to train. Nobody else in the country was doing it. There were no YouTube or no videos available either, no VHS videos either at that time, only written texts to look at. And we had no fascia lata strippers. There were no right fascia lata needles, which we had to acquire with a lot of difficulty from abroad. And therefore, this led to a great deal of difficulty in carrying out the procedure. We innovated by using artery forceps, and we used newer techniques in order to be able to pass the fascia lata and to carry out the removal of fascia lata with the help of a small incision. We shall see that technique when we describe the Marcus gun procedure. There was also the problem of undercorrection and asymmetry when the sling procedure was carried out unilaterally, which we sorted out, which we'll discuss later. So this is the technique of removing the 4-inch strip of fascia lata without a stripper with a 1/2 inch to 1 inch incision. And this results in a scar which is very small. The results are again very gratifying for these difficult cases and are a source of a great deal of joy to the patient. Blepharophimosis syndrome is quite common in several parts of our country, and it requires a two-stage procedure with horizontal procedure in stage 1 and the ptosis correction in stage 2. The procedure was being done, but there were very few centers in the world which were doing a correction by transnasal wiring. And we had not seen anybody of course, in the country, there is nobody else who's commonly doing this procedure yet. The transnasal wiring for the severer cases is extremely important to give them the proper depth and the proper maintenance of long-term correction of telecanthus. And we have done this procedure by innovating several steps to make it easier. This is the marking of a Z-plasty, and then the removal of windows is carried out, and transnasal wiring by fixing the wires to the canthal ligaments passed from one side to the other with the help of a fascia lata needle is carried out. We've also modified the technique to carry out a railroading in order to pass the stainless steel wire through the ligaments. So this is where we pass a hypodermic needle, do a railroading with this in order to get a good firm anchorage through the medial canthal tendon. And this is the result that we are able to achieve from a superficial medial canthus to a very well deeply placed medial canthus. And a second stage surgery really provides an excellent result. Note the depth that we've been able to achieve for the medial canthus. And after the stage 2 is done, we are able to provide excellent results. Sometimes this may be done as a single stage procedure. So transnasal wiring and fascia lata are done at the same stage to provide an excellent correction. In ocular motility disorders, there were several cases with severe monoocular elevation defect who were denied surgery. We realized that most cases can be taken up and that no patient with ocular motility restriction with ptosis need be condemned to a life without a ptosis correction. And we were able to tackle many of these cases by first correcting their motility and then doing a fascia lata or a silastic sling procedure. An example is a congenital ptosis with a double elevator palsy here. As you can see here, a restriction both in the up and in and up and out direction, where a NAPS procedure was first done, followed by improvement in the Bell's phenomenon and correction of the ptosis by slings procedure, which was well tolerated. But it is in the area of jaw winking ptosis that we have been able to make the maximum difference. This is a patient with hypotropia and superior rectus under action with jaw winking. And here, after an inferior rectus recession and a bilateral levator excision with fascia lata sling surgery, we're able to provide a good correction. So let's look at the jaw winking ptosis as to how this procedure has evolved. So jaw winking is a difficult problem in cases where the jaw winking excursion is significant. We evolved our current procedure through a number of steps. It required step-by-step improvements in our technique. So the two components that need to be tackled are ptosis and the jaw winking. So jaw winking is eliminated by disabling the levator by a complete excision. So this is done by dissecting right up to the Wittnals, and then after the excision is done, then the frontalis sling is done. Initially, this was being done as a two-stage procedure. We evolved a single-stage procedure, but levator excision required the fixation of the sling onto the tarsal plate because we were opening up this area, which resulted in problems. So we modified the surgical technique where we did not do any dissection between the tarsus and orbicularis in the primary procedure, so that we could do a single stage procedure. We already mentioned the sub 1 inch incision we evolved in order to get a 4-inch piece of fascia lata of the required width. This innovation helped us to work without strippers, giving only a very small incision. However, when we did a levator excision with unilateral sling, we found that the asymmetry was not acceptable. Therefore, we started doing a unilateral levator excision with bilateral sling, which gave better results. However, the frontalis was still not being used adequately because of normal levator action on the opposite side, and there did remain an apparent undercorrection. Therefore, we started doing a bilateral levator excision with bilateral fascia lata sling surgery, and this gave us the ideal results as desired. Let's look at this surgical technique. So this is a patient with jaw winking. We've done the marking as for a double triangle Crawford procedure with modification. And these are the forehead markings. We use adrenaline locally and give a sub 1 inch incision. Do a dissection with the long scissors. Start with the dissection with the long scissors along the entire length of the fascia lata. Remove the strip, divide it into 4 equal parts, close this 1 inch incision, and then make our incisions in the 2 eyelids. This procedure is always done bilaterally with bilateral levator excision. So this is the opening of the orbital septum to expose the levator aponeurosis, which is then excised from the levator border without dissecting in between the tarsus and the orbicularis. Once we have dissected the levator free, we remove all the horns in order to completely eliminate the jaw winking. And the excision is carried out right down to Whitnall's ligament. The opposite eye is also subjected to a levator excision. Dissection is then made between the 2 incisions laterally and the 2 incisions medially on the skin, and the pockets are made after incisions in the forehead. Using the right fascia lata needle, we are able to pass the strips as a double triangle, both nasally and temporally. These are then tied till we achieve the right correction and the contour. Skin muscle must always be excised to get a proper lid crease. Knots are strengthened by 1 or 2 sutures of Vicryl, and the 2 strips are passed to the central forehead incision. This knot is also secured, closure is carried out, and this completes the procedure when a frost suture is also applied. This technique has the merit of providing a single stage procedure with total elimination of jaw winking and excellent symmetry of correction in the 2 eyes. The results are permanent. This being an autologous material, there are no side effects and virtually no recurrences. The scar on the thigh has been minimized to a minimal. The results are extremely gratifying. This is a patient with jaw winking. This is the post-operative appearance with perfect symmetry between the lid creases on the 2 sides with a perfect contour and correction. Upward gaze and the downward gaze are also quite symmetrical and therefore cosmetically excellent. And jaw winking is cosmetically abolished. We have carried out 185 patients of jaw winking, 112 with this technique, and we have observed that we've been able to provide good or fair results in almost 93% of the patients, with elimination of jaw winking in almost all cases. This technique shows that the only way of finding the limit of the possible is by going beyond them into the impossible, as Arthur Clarke states. Thank you all. Thank you, Delhi Ophthalmic Society, for being a part of my journey through these years of evolution. Thank you once again for the award and for the honor. Thank you, Delhi Ophthalmic Society.
Wonderful presentation, sir. It was, as always, extremely enjoyable listening to you.
Thank you, Rohit.
Dr. Namrata seems not to have, maybe busy in some other session.
Yeah, she's there.
Dr. Namrata, request.
You're mute.
Yeah.
You're mute.
Can I do the next session, next talk? Because I have to, I think you have recommended my name for college. I have to go and chair the session there. Is it okay?
Acha, no, just 1 second. We would like to, we are not done yet. And we would thank you, sir, so much for the honors. And we would just like to, of course, we can't do it when we'll get a chance, we'll do it physically. But we would like to confer this Dr. P.K. Jain Oration Award 2020 to Professor A.K. Grover. And I think we can clap.
Thank you. I'm honored, grateful for the honor.
So we are thankful, sir, for your consent and for your great presentation. We would now go to the next oration. The next oration in line was actually Professor Tityal's. If sir agrees to give consent, we can allow Dr. Kirti to present her oration, sir.
Always.
So it is again my privilege and honor to introduce the next orator. Dr. S.N. Minter oration for DOS 2020 is conferred to Professor Kirti Singh, MD, DNB, FRCS, Diploma, DPL, Hospital Management, FAI, MER. She is Director Professor of Department of Ophthalmology, Guru Nanak Eye Center, Maulana Azad Medical College. I know her since I was in Lady Hardinge Medical College as a student of MBBS, and she was in final year MBBS at that time. She graduated from Lady Hardinge Medical College. On a personal note, she was not able to come down off the stage during the final Prof of MBBS ceremony because there were so many awards. The moment she used to come down, another one was announced, so she had to again go back halfway. So there were about 5-6 medals or maybe more to the best of my knowledge as of now, which she received in that convocation ceremony. She's done post-graduation from RP Center of Ophthalmic Sciences, PG Diploma in Hospital Management, National Institute of Health and Family Welfare, trained in glaucoma from Wills Eye Hospital, Moorfield Eye Hospital, recipient of WHO fellowship. I think 3 coveted fellowships again is a great honor. She's member of Clinical Epidemiological Unit of Maulana Azad Medical College, faculty member of Department Occupational and Environmental Health Unit of MAMC, faculty of Medical Education Department, again faculty of Microsurgical Skill Training Center in MAMC since 2013, and has designed surgical innovations for postgraduate training in Delhi. She's been exclusively practicing glaucoma and problematic contact lens fitting cases. She's conducted many CMEs and instruction courses at state, national, and international level level and delivered over 500 educational lectures at various CME at local, state, and international level meets, published and authored 3 textbooks in contact lens and glaucoma, co-authored 12 books and 55 indexed and over 75 peer-reviewed publications, has delivered over 800 educational lectures at various CME at local, state, and international level meets, and authored a volume of English poetry and contributed to Sahitya Kala Academy newsletter. And we are all aware of the fact that she writes really nice poetries. She's been on honorary radio compare for All India Radio for last 15 years and been nominated Provost of MAMSI in 2018. There are several awards like I discussed earlier, and various awards she has also been conferred from Delhi Ophthalmic Society, Women Ophthalmic Society. She's the recipient of B.N. Khanna Oration Award in 2019, gold medal from the IRSI in 2019, and also the WHO and also the Low Vision Rehabilitation Award from Arvind Eye Hospital, Madurai. And it is again a privilege and a pleasure to request Dr. Kirti Singh to give the Dr. S.N. Mitter oration now.
Thank you, Dr. Namrata. It is an honor to be sharing the platform with Dr. Grover and Dr. Tityal, who have been my teachers. And DOS has always been my alma mater, so it's a real privilege. Thank you for that. So I'll be sharing my journey over the last years on trabeculectomy. So I'm talking about the innovations which I have done to enhance longevity and minimize the complications. That has been my holy grail for the last 20 years. I'm indebted to Dr. S.N. Mitter, whom I found out was the first person who started the DOS in 1948 with rupees 36. It seems now so laughable, and it is just a great thing which he did. And more than that, Dr. N.N. Sood was the first recipient of Dr. S.N. Mitter oration. So I stand in hallowed feet because he has been my teacher and my role model. So thank you for this great honor which DOS has given me, especially of a person of the caliber of Dr. S.N. Mitter, who has worked for DOS all his life. Thank you. So primarily in India, we are an aggregated country for whom surgery, the patients for whom surgery is required often belong to the rural background, especially in the setup where I work in. So whenever we use mitomycin, it's a double-edged sword because the risk of endophthalmitis, blebitis, and not to mention avascular bleb is always a problem. Therefore, my first aim was to look for safer alternatives as wound modulators. And I stumbled upon amniotic membrane. Initially, my first thesis was an amniotic membrane, and my resident would go in the morning to the cesarean hall and get a fresh amniotic membrane, get the seronegative test for all of them, prepare it, and then we used it. Now, thankfully, that era is gone. We have the commercially available membrane. It's a physiological bleb modulator. It promotes epithelialization, downregulates the fibrogenic TGF-beta signaling, and it is an anatomical barrier. It causes a vascular stroma, inhibiting incursion of new vessels. So we've used this over so many years in our center, and the blebs were much healthier. The microcystic spaces were there. However, the blebs were less high, less avascular, and more diffuse compared to mitomycin C. And these are some pictures of the AMT blebs. This is a picture of an AMT bleb. You can see the beautiful microcystic spaces which happen in the AMT blebs. And they are much more comfortable because they are physiological. AMT is physiological vis-a-vis mitomycin C. This was one patient in which I did a trab in MMC, and other eye the trab was done with amniotic membrane. And this is a 10-year follow-up of this gentleman, and you can see the IOP is controlled for both, but the mitomycin eye had the avascular bleb, and the early cataract happened in the mitomycin eye, which did not happen in the AMT. Of course, it is N is equal to 1 year. But having said that, amniotic membrane doesn't have the potential to cause cataract. And this article of ours was published, this study of ours was published. The second aim, I tried to, again, a more physiological modulator, especially where mitomycin can't be used The first Ologen I did around 10 years ago was on a pregnant lady in the second trimester, and I didn't want to give mitomycin C, and she was only 29 years old. So I started with Ologen that time. It's no financial interest to declare. It's a biodegradable collagen matrix implant, and it causes programmed healing with the guided fibroblasts and myofibroblasts. In this, I put an Ologen along with amnion. Very often, I put holes in the amniotic membrane, so that Tenon's cyst incidence is less. Again, the Ologen trab. This is the type of conjunctival incision which we are doing now. This, I call it the smile incision, but it's actually a conjunctival frill which we leave behind. And again, the Ologen causes a more layering, obviously. And what we found in our study was that it, unlike the company people who say it lasts for 4 to 6 months, it lasts longer. And these are some Ologen blebs. This is Ologen with AMT, and this is the patient with mitomycin C. So you can see the difference in the blebs. And this study again was published in IGO. The third thing which I looked for is again the type of patients sitting in India whom we see are, we have both cataract and glaucoma, and cataract progression is known to increase post-trabeculectomy. If we do a single surgery, we can handle 2 comorbidities for the patient who will not be able to come back for another surgery. So what happens is normally we want the trabeculectomy first, followed by cataract, but very often the patient, because of inaccessibility to medical care, the cost factor, will not be able to come back. So combined surgery is very germane to our country. And trabeculectomy inherently is an imperfect surgery. Phacoemulsification is relatively perfect surgery. So combine the two, how do we do that? So this is what I had devised, a 6 trab incision, SICS trab or W incision, in which you have a patient with hard cataract to combine SICS along with the trabeculectomy and only with 4 sutures. And again, my residents, whenever they do a SICS, they could do this surgery if they do a combined one. Obviously, phacotrab is easier to do and superior, but SICS trab is a very good option in patients with hard cataract, especially when you don't have a phaco machine available. And this is the surgery being done. It's a W incision, which becomes a Y incision. It's a hard cataract. So this surgery is not dependent on any technically on any phaco machine. And you do 2 releasable sutures and 2 fixed sutures along with the conjunctival suturing as shown, because this is the suturing which I have been doing now, the conjunctival frill incision. This has been recently accepted for IGO for publication. So this is the new in between phonics space flap and limbus space flap is the conjunctival frill incision. This frill incision was devised because trabeculectomy causes suture-induced discomfort and suture-induced astigmatism. So this innovation preserves the limbal sanctity, reduces the SIA, reduces scarring at the frill site, and because this incision is right here at the limbus, it prevents there will be some scarring happening here, so anterior migration of the bleb is prevented. So I started doing this technique almost 5 years ago, and after that all my residents and all the people who are doing trab in my setup have shifted to this incision because it's so much easier to do and the patient is so much more comfortable with this incision. So it resembles a smile, so we have a euphemism for this. It's a smile incision and the patient also smiles up. So these are some pictures. And this is how we release the releasable sutures. I do Richard Wilson technique of releasable suture. and it's very simply released on the slit lamp sequentially. And even the smile incision, the smile suturing can be released on the slit lamp. You don't need to go to the OR for that. So it's a pretty clean incision to do. The next innovation we did was phaco-infiltered ECG. We have a lot of ECG patients coming to us in our hospital, and a lot of them have trabeculectomy done before. And these patients have very often a bulky lens and a very shallow AC. So how do you modify that? We finished our thesis in that. I'm sorry for the sound. Sorry. So what we did in this was that for the bleb, we just did a visco protection. We just put a viscoelastic at the sclerostomy site before the phaco, and the cytokine inflammatory upregulation which happens at the bleb causing the fibrosis is reduced. And we have finished a thesis on that the bleb morphology is much better maintained if you block the ostium with sclerostomy with viscoelastic. These were a few of other modifications which I learned from Dr. Spaeth, that whenever you do a releasable suturing, at that time only you do a titration. So that will tell you how tight your releasables are. And so this is what we do always. We do a bleb titration of the conjunctival flap. So we titrate the bleb 2 stages. One at the end of releasable suturing for the scleral suturing, and second at the end of the conjunctival flap. So our shallow AC incidence and our bleb leaks are much reduced. And this has been again from the AIOS. I published this CME series, and this has all been detailed there. The last modification which I wanted to share with you as what we have again done in the last 1 decade is I started doing needling for my patients. Initially, we did only with fluid, and then with 5-FU. As my confidence grew, I did with mitomycin C because that's much more effective than antifibrotic. Most of these patients were scheduled for a repeat surgery, and we just spoke that paper yesterday. Almost 87% of the patients we could just revive after proper needling. So this is needling with MMC. You can see the hemorrhage happening because I've cut the blood fibrovascular band. There's a gritty feeling next to the bleb, and you keep lysing it. The needle should be visible at all times, otherwise it can cause buttonholing of the conjunctiva. And once you withdraw at the end, just seal up this area with viscoelastic to prevent any 5-FU or MMC toxicity to the cornea. So we could revive many blebs. In addition, the thing we started seeing was that a lot of patients had the inner sclerostomy blocked by the iris. So always for any bleb failure, we do a gonioscopy. And whenever this internal blockage is there, like a Heimlich's maneuver is done, we try to lyse out this and open up the sclerostomy. And this technique was an internal revision technique. For lack of time, I won't show that. So we combine that with needling, and we also do the internal revision. So all these innovations which we have done for trabeculectomy over the last 20 years have been keeping in mind my country, the needs of my country. We don't have sophisticated equipment. We need to think out of the box, and that's what I have done, and that's what I am sharing. Thank you so much again to DOS for giving me this oration, and thank you to my patients for trusting me with their eyes in glaucoma, which is a very unforgiving disease. Thank you so much. And thank you to my teachers. And I have one of them right there, Dr. Tityal, who was my senior resident. Thank you for teaching me. And Namrata, my peer, thank you so much.
Thank you, Dr. Kirti, for your wonderful presentation and oration. Dr. Subhash Dadia, the president of DOS, has also joined us. Dr. Dadia will say a few words before we finally confer the oration on you.
Thank you, Dr. Subhash.
So I think so congratulations, Kirti, and thank you for the SN Mitter Oration 2020.
Thank you.
Thank you. We come with this, we come to the next oration, and the next, it is a pleasure for me to announce the next oration, which is for my teacher and my unit head from RP Center, my guide, and he's been a source of inspiration to all of us. Professor J.S. Tityal, the Dr. Om Prakash Oration DOS 2020 is conferred to Professor J.S. Tityal, Professor and Head Cornea, Cataract and Refractive Surgery Services, Chairman of National Eye Bank, RP Center for Ophthalmic Services, AIIMS, New Delhi. He joined as a faculty member in RP Center, AIIMS, New Delhi, and he's been here for last many years, close to almost 30 years now. He did his senior residency in cornea, cataract, and refractive surgery, and he also did his junior residency from AIIMS as well as MBBS from AIIMS. So he was like as though born and brought up in AIIMS in not only ophthalmology but also in the medical field, that is MBBS. He has, to his credit, numerous awards and achievements which are related to academics and research. He has more than 280 publications which are indexed with more than 3,500 citations, 4 books and 46 chapters. He's delivered more than 50 orations and several of the keynote addresses. And he's done numerous live surgeries and has been regularly conducting instruction courses at all international platforms, which includes the American Academy of Ophthalmology, the American Society for Cataract and Refractive Surgeons, the European Society for Cataract and Refractive Surgeons, the Asia Pacific Academy of Ophthalmology, the Asia Pacific Academy of Cataract and Refractive Surgeons, and All India Ophthalmological Society. To his credit, he has 2 patents and several international awards and honors, which include the Senior Achievement Award 2016, the Achievement Award by AAO in 2009, the APS-CRS Certified Educator Award in 2015, the Achievement Award by APO 2015, the Best of Show Award by AO in 2006, 2008, and very recently in 2018. And he was also the first Indian to perform the live surgery in Ascus, USA. He has been at various positions in various societies, which includes the Secretary DOS 2003-2005, the President DOS 2013-2014, and the President Indian Society of Cornea and Keratorefractive Surgeons since 2016. He's also been awarded the very coveted Padma Shri by the President of India in 2014 for his remarkable contributions in the field of medicine as well as in the field of ophthalmology. So with this, I would request Professor J.S. Tityal to give his oration.
Thank you, Professor Namrata Sharma, for such a nice words for me. Indeed, it's my honor and pleasure to be with you people, especially the President, Dr. Subhash Dadia. And Namrata Sharma, the team has done wonderful work to organize this webinar, web-related conference from DOS. And it is a huge Herculean task being done by you people. I'm also honored to have this international Dr. Om Prakash oration today. And thank you, Rohit Om Prakash, for giving me this opportunity also. Though I didn't have opportunity to meet Dr. Om Prakash personally, but this is what I got it from Rohit. He was a graduate and postgraduate from Kalansi Medical College, Amritsar, head of Department of Medical College, Rohtak, Professor Emeritus, CMC, Ludhiana. He was the founder and he set up the Om Prakash Eye Institute in Amritsar, which is now being looked by his next two generation, his son and his now grandson. He has conducted many free eye camps in Punjab. I think that was a trend at that time. Haryana, Jammu and Kashmir, done more than almost 2 lakh surgeries for poor patients, which is a wonderful achievement in anybody's life. He's one of the earliest one to start posterior chamber IOL in the back. And I can consider looking his records, achievements. He's a pan-ophthalmologist, done refractive surgery, corneal transplant surgeries, name anything, like retinal surgeries, oculoplastic surgeries, everything he's done, and his legacy is now going on. So it is my pleasure to get this honor to deliver a talk on something related to a cataract surgery. Today, my oration will be based on something new which we talk about in cataract surgery, that is intraoperative OCT, improving the surgical outcome in our cases, especially in the femtosecond related cases. No financial disclosure on this particular talk. I've been employed by All India Institute of Medical Sciences, New Delhi, and work in RP Center for the last 30 years. As we all know, cataract surgery has seen a sea change in terms of technology and the improvement in quality of vision and life of patients. And that directly, indirectly translates to the improvement of thinking of people to get into newer technology. That is femtosecond laser cataract surgery, which is the new tool assisting various cataract related steps. It gives the automation, enhances the precision, and it improves the challenging cases outcome. I would say femtosecond is not a separate surgical technique, but it's adjunct to the phaco surgery. So this is what nowadays I talk about. It is a laser-assisted phacoemulsification surgery, that is flash rather than flax, but that's the standard term people have used. There have been challenges to really incorporate this femtosecond laser device for cataract surgery, because initially it was approved for corneal surgeries. Because you have a deeper treatment in the cataract, you require a longer focal length, more larger spots. Optics has to be changed in terms of various numerical apertures to adjust corneal, capsular, and nuclear area to be tackled by these lasers. Does require a larger field of view for a beam delivery in the cornea-related incisions. That is a main incision, side port incision, or LRI incision for a cataract during the cataract assessment, and subsequently planning the laser application in those areas. Most importantly, it needs a high precision 3D imaging to incorporate the lens capsule, and cornea clearly, so that you don't overfire in undesired places. You can establish the safety zone for these cases. The 3D integration of OCT was prerequisite for successful laser system development in these cases. In today's talk, I would like to have OCT related advantages in 2 categories. One is the planning of laser application, laser treatment for our patients, the OCT guidance, and the intraop OCT guidance for these patients who have undergone flex surgeries. So this is a truly automated or image guided surgery which you talk about. So you can have entire OCT picture of a capsule, and you can customize the capsular size, centration. Incision can also be modified as per the requirement. You can put corneal incision to decrease the astigmatism. Then you can plan the OCT picture gives you a real planning for the nucleus depth to be analyzed, and up to what extent you're going to do a nucleotomy or fragmentation. You can clearly visualize the posterior part of posterior capsule, so you can know which type of posterior polar cataract you have, and accordingly you can leave the large epicortical cushion depending on your cases, and you have a really well designed incision in the cornea, which can be 3-planar, and geometry can also be modified as per requirement. We know that one of the most important step and challenge is doing a capsulorhexis or capsulotomy with laser to have perfect capsulotomy, which can be achieved by the laser system. In LensX system, it gives a 360-degree scanning of the entire capsule. That is a circle scan and line scan, which gives you this picture, and you can design 250 micron or 350 micron safety margin, both anteriorly and posteriorly. While from a catalyst system, it also scans the full volume of both anterior and posterior capsule. After it defines the center of the capsule, automatically the capsulotomy centers to the center of the capsule. This is a beautiful publication from Dr. Mahipal Sachdev group, where they could assess the morphology of posterior polar cataract with the OCT attached in the catalyst system, and they could identify their pre-existing defect in the posterior capsule, and you could modify your surgery accordingly. So that's the advantage of OCT picture in the laser systems. This is one of my patients of subluxury cataract. The advantage of OCT, it gives a tilt. That means amount of subluxes can be recognized during your OCT picture and laser application, as well as you would know if something wrong, like you can see a vitreous in the anterior chamber, that can also be picked up. You can recenter the capsulotomy as per the requirement of a subluxury cataract. And one more thing which can be there in these cases, you can precisely do a capsulotomy to have an accurate alignment IOL with a little bit of modification of capsulotomy. This is seen in a LensAR system. You can see a little knob of area of implantation of toric IOL. You require a good image picturization of a limbus to have this capture. You can see intraoperatively it matches with the image guided Callisto system. You can see towards the end the lines are matching. Immediate posterior, you can see this knob or tongue shaped capsulotomy area matches with the 3 dots of toric IOL. So these are advantages there with the OCT guidance of laser application. You can have various types of fragmentations. We know that it decreases the energy delivery during the nucleotomy and safeguards the corneal endothelium. This is our publication where we compared the 2 types of fragmentation, CHOP versus matrix pattern. And we realized that matrix pattern is more suitable for the higher grades of nucleus hardness with a significant decrease in nucleus emulsification energy use. And this is a survey article by us on our use of OCT, IOCT in anterior segment surgery, also includes cataract. If you see OCT after a laser application, you can see nice picturization of a 3-planar incision. And this is the, you can see the laser-induced delineation, cavitation bubbles. Dr. Mahipal yesterday talked about pneumodelineation of a laser application. Therefore, you have an easy access to a nucleus management subsequently. You can see fragmentation of nucleus can also be visualized with the OCT attached in the microscope, and you can safeguard the posterior capsule and epinucleus towards the end, and you can assess the lens in terms of a stability of lens in the back also subsequently. So this is what I was talking about. This is the clear image guided or automation which can be done. You can see this is the nucleus being planned. So you can see this is the posterior polar cataract. You can see here, so we have around 800 micron safeguard being done. So once your capsulotomy done, this is a nucleus fragmentation, a grid pattern of 300 micron blocks in a 2 planes. The color of nucleus laser application can also tell you how hard or how soft your nucleus can be, subsequently the incisions. So once I shift this patient into a microscope, which is IOC integrated, we can see clearly the fragmentation of the nucleus in these cases. You can see also, you can pixelize the capsule in terms of completion of anterior capsule also. This is the delineation, pneumodelineation has happened, and surgery becomes very, very safe. You can see the blocks of nucleus fragmentation can be easily seen. Once I open the CHOP pattern, this emulsification becomes very easy and fast, and that also is safety for both posterior capsule and endothelium. Subsequently, you can aspirate the cortex and implant the IOL. At towards the end, you can see it is so important to see how stable your lens, and the capsulotomy being perfect also improves the outcomes of premium IOLs in our case. The femtosecond laser created incisions we compared with the manual incisions, and we found that femtosecond laser incisions were having lesser chance of wound site detachment, and they have a better configurations. So this you can see, this is the femtosecond incision day 1 and after 1 month. This is a blade incision in these cases. The femtosecond also has importance in the incisions. What about looking into cases of challenging scenarios? Does IOCT and flex help in these cases? So this is our new classification of looking at various cases of white cataract, the type of thing. This is what IOCT picture. We have classified in the 4 categories of white intumescent cataracts. And these cases can be effectively seen and treated with a femtosecond laser also. So once we see the OCT of femtosecond laser, if you're seeing these cases, you'll know what type of a white cataract you have. You can see a homogeneous liquefaction of this, the type 4 type of white cataract. The laser application will definitely have a fluid release in this patient, and you may have a chance of a little bit of a micro adhesion remaining. You can see the gush of fluid coming out with so much of pressurized capsule being there in these cases. So manually, this case would have a more chances of a capsule rhexis extension. You can see OCT again here helps you to picturize what type of cataract we have, white cataract. Once the fluid has come out, there's no chance of radiation of even a micro adhesion, which is there in these cases, because there is no intralenticular raised pressure, which in manual cases is very difficult to predict how your capsulotomy is going to behave. Here, everything is soft. You can do a completion of your micro adhesion also in these cases safely. Nucleotomy may not be possible in all white cataract, but it can happen. This is one more white cataract. You can see this is a type 2 type of white cataract. You have some fibers and some pockets of a fluid. Here, you may not have a fluid release in a gush. You can have a free floating capsule in these cases. So that's the advantage of OCT attached to the femtosecond laser system also. Gives you a guide what type of white cataract you can have in these patients. And if you compare with the manual surgeries, it is much more effective in terms of mean diameter and circulatory index, the femtosecond laser. Posterior polar also, OCT does help you in a pre-op assessment and as well as the laser application also. And this is our new classification of OCT based looking into types of posterior polar cataract, type 1, type 2, type 3, depending on to the visibility of clarity of posterior capsule. If you have a clear delineation of posterior capsule, this is a type 1. If you have a periphery clarity and central is missing, then it's the type 2 type of posterior polar cataract. This is type 3 where you can't delineate the posterior capsule because of a disc being large and dense. So these cases have a higher chances of a posterior capsule adhesion during your surgery. This example of a type 1 type of posterior polar cataract where you can see we could delineate entire thing, and I could do a hydrodelineation. And once you do a hydrodelineation, you can see this is a space been created, and around 1000 micron epicortical cushion has been created with delineation. Subsequently, I'll do a hydrodissection also because this type 1, because posterior capsule was almost clear from the disc. So this is what you see, hydrodissection as well as hydrodelineation, both has been done, and the surgery becomes simple. So once you can delineate the type of posterior polar cataract, your surgery can also improve results in these cases. In laser-related steps also, we have modified the surgical steps in a laser application with the hybrid technique, where we create the 3 safety circle and blocks of a nucleus, and subsequently you can take out each block one by one. The primary, secondary, and tertiary blocks can be taken out, leaving the large epicortical cushion towards the end. So this is a typical posterior polar cataract you can see here, which has not clearly defined the posterior capsular margin. So capsulotomy, we normally do around 4.9 to 5 millimeter capsulotomy. Subsequently, we'll do a hybrid type of planning. In this case, you can see this chop pattern and circle pattern is there. Once you take this patient on the table, free floating anterior capsule, no hydro dissection delineation required because you have a pneumo delineation happening. As soon as I open this job, the bubbles will come out, and this job will also allow fluid to disseminate into the this pneumo dissected delineated area, and these pieces get free. Now I'll take one by one each piece, and this will safeguard the entire epicortical posterior capsular complex without getting disrupted till the end of our entire nucleus being taken out. Subsequently, you can take the epicortex and implant the IOL. The OCT attachment in both in femtosecond as well as in the IOCT does help. In subluxated also, as I showed in one of my initial PPT, you have a lot of modification to be done. You can see here, I'll shift my capsulotomy to the larger area of capsule available because you have a large subluxation of almost 3 to 4 clock hours in a temporal side in this patient. There's a vitreous in this patient also, little tilt. What I'm going to do subsequently, put a little laser application. You can see these bubbles because of a vitreous is there in these cases. Subsequently, do a similar technique as I did for posterior polar cataract. Posterior openings in the limbus so that we can hook the loose capsule and stabilize the bag during emulsification. You would have to do a vitrectomy before you initiate your nucleus removal. Once you remove the vitreous, you can take out the nucleus clearly in these cases. Take out the pieces safely because now your bag is fixed. Do a removal of cortex with bimineral technique under visco cover, that is normally a dispersive viscoelastic. Put CTR and implant the IOL. So both laser and IOCT will help in these cases to have this type of result in a post-op day. It would also have little bit of advantage in the phakic IOL situation also because OCT will give you a anterior capsule as well as the phakic IOL pixelization also, and you can apply your laser in a correct position of anterior capsule in these cases. Both for ICLs and VeriSize or iris clip lenses, laser can be applied nicely. And OCT, both laser as well as microscope OCT does help in these cases. To summarize, OCT in femtosecond laser devices does help in a treatment planning by determining safety zone for a capsular application, nucleus application, and a corneal incisions also. You can classify morphologically various types of cataract. Polar cataracts, white cataracts. The hardness of nucleus can also be classified in these cases. In challenging cases, definitely it is very useful to have a femtosecond laser. And in terms of IOCT, it's definitely going to enhance the safety of femtosecond laser cataract surgery also. It has an expanding indication now. It is being used more oftenly for pediatric cases also, especially a posterior capsulotomy in pediatric patients. It does have an advantage. It outweighs the cost effect or limitation which may be there in a femtosecond laser. It's not barely a bladeless surgery. I say it is the surgery which will define the future of automation. Therefore, integrated artificial intelligence in a femtosecond laser devices in future will totally change the concept of a cataract surgery for the betterment of mankind. Thank you for your kind listening. Again, I would definitely like to thank the entire executive at DOS, especially Dr. Subhas and Dr. Namrata and Dr. Rohit also. And it was very pleasure to give this talk.
Thank you, sir. Like always, it was a pleasure to listen to you and to learn from you. It has always been like that. And thank you so much. And I think we would formally, of course, I'm sure there is going to be a event which is going to happen physically. Dr. Subhash Dadia will announce that also. And we would like to formally confer the Dr. Om Prakash Oration Award to Professor J.S. Chityal virtually today and then physically at a later date. Thank you so much, sir.
Thank you very much. Virtually, aap dono ko salam karta.
Congratulations, sir.
Congratulations.
Wonderful job. Both of you have done wonderful work.
Thank you, sir. The next is the Dr. Hari Mohan Oration Award for DOS 2020, given to Professor Rohit Saxena, who is the professor at RP Center for Ophthalmic Sciences, New Delhi, in Pediatric Ophthalmology and Neuro-Ophthalmology Department. He's edited 2 books on strabismus, authored more than 60 chapters in international and national books. He has 290 publications and is a principal investigator in many funded projects, as well as a co-PI in many of the national and international funded projects. He's supervisor of various theses and also co-supervisor in the Department of AIIMS, as well as with other collaborative departments. He's invited faculty and presented research papers and given several talks in various conferences, and has been regularly conducting instruction courses at AIOS as well as other national and international platforms in squint and neuro-ophthalmology. He's the invited speaker at various national platforms and in CME meetings, and has performed live surgery in national and state level conferences. He's was conferred more than 32 awards, including the Best of Show Video Award at AO 2019, AIIMS Excellence Award 2018, Fan Favorite Video AO 2016, Best Paper in SPOSY 2016, Equine Appreciation Plaque in 2014, AIOS IGO Platinum Award 2013, Best Paper Asia Arvo in 2013, APO Achievement Award in 2013, IRSI Gold Medal in 2012, and AO Achievement Award 2011, to name a few. He has been the AIOS ARC North Zone representative and continues to be so in this term as well. He has served DOS in various capacities. He was a secretary of DOS in 2011-2013, and he's been the editor as well of the DOS Society in 2009 and 2011. He is currently the member for Subject Expert Committee to Advise Drug Controller of India and member Ethics Committee in AIIMS. And he's one of the few clinician scientists who's also done PhD apart from MD ophthalmology. And that is his unique point. We have very few clinician scientists in India, and I would request him to give his Dr. Hari Mohan Oration DOS 2020 today. You have to unmute yourself, Rohit.
Rohit, you are not.
Yeah, just a second. I'm audible now?
Yeah.
Okay. So I just start my screen.
No, your screen is sharing, but you have to put it on slideshow.
Unmute.
But again muted. Rohit, you have to unmute yourself.
रोहित को कौन चुप करा रहा है बार-बार?
Unmute, please.
बहुत ही difficult काम होता है.
Admin, can you unmute Professor Rohit Saxena? He refuses to unmute himself.
Hang हो गया उसका system.
Yeah. Now I'm audible?
Yes. Yeah.
Okay.
But you have to make this into a part.
Yeah.
Full screen.
Screen visible? My screen is
Yes.
visible? Okay.
We do
So,
have
it'll-
Dr. Sanjeev Mohan. I think, Rohit, we would also like to acknowledge the presence of Dr.
Yes.
Sanjeev Mohan, who's the son of Dr. Hari Mohan, with us today. Thank you, Sanjeev, for being with us.
It's an absolute pleasure to first introduce Dr. Hari Mohan. Of course, we would be aware about him, but the honor of talking about him is itself, and of course, receiving the Oration Award is a very high point in my career. So Dr. Hari Mohan who graced the earth from 6th April 1928 to 27th March 2013. And he was born in Muzaffarnagar in UP. He received medical degree with honors from King George Medical College, Lucknow. He went to England for his postgraduate training, where he did his DO from London, his FRCS Edinburgh, and FRCS Oxford. He was a complete patriot at heart. He returned to India in 1956 to join the Irvine Hospital as the honorary surgeon, and then was the honorary professor at the Maulana Azad Medical College till 1968. He had very closely worked and had the blessings and guidance of Dr. S.N. Mittal, who laid the foundation of his very successful career. And he was a pioneer in lens implant surgery and had a lot of work and published numerous papers on this subject. And that is why particularly I chose, although it was not my direct expertise area, but cataract refractive procedures as my topic when I would be delivering this. He has a lot of honors and awards, and some of the most important ones were the Padma Shri in 1971, the BC Roy National Award in 1996, the FRCS Glasgow. He was the international advisor in ophthalmology to the Royal College of Physicians and Surgeons. He was conferred the Lifetime Achievement Award from the IOS in 2004, the Padma Bhushan in 2005. He got the Doctor of Science from SGPGI Lucknow in 2008, and he was the honorary ophthalmic surgeon to the Honorable Presidents of India from 1968 to 2007, 40 years in that position. In 1980, he established the Mohan Eye Institute that has since then raised the standards of medical ophthalmic practice in India. It is located in the heart of Delhi and is recognized by the MCI, the National Board of Exams, the Royal College of Ophthalmology UK, and the Royal College of Physicians and Surgeons of Glasgow for their training programs. And the Royal College of Physicians and Surgeons conduct its fellowship exams in ophthalmology every year at the Mohan Eye Institute. Besides his massive work, he was also involved in a lot of charitable area and created a charitable wing in 1980 dedicated to his mentor, Dr. S.N. Mittal, which does 40% of the surgeries free of cost for the poor, besides doing a lot of eye camps in Delhi and neighboring areas. So it's an honor to deliver the Dr. Hari Mohan Oration Award. And as I said, I have particularly chosen outcomes in post-cataract and refractive procedures. So for my area, I chose binocular outcomes, which is an increasingly important area to discuss. So we know that binocularity and stereopsis is progressively increasing in the current world, and we require a lot of manual dexterity, like needle threading, like picking up fast objects, which were routine. But now with the advent of 3D movies, 3D games, sports, driving, and also a lot of occupations that demand a very fine depth perception, like active sports, aviation, defense, and even medical, like ophthalmology. Now we are doing through requiring 3D for the heads-up 3D surgery, or even through the microscope. So there is a massive increase in the need for stereopsis. And while these are normal values which we had checked up for the Indians for near and distant stereo acuity, and they were mainly discussed among pediatric ophthalmology and strabismologists, but now the role is being particularly appreciated world over among all subsections of ophthalmology. Up till now, outcomes, especially cataract refractive, were discussed in terms of 6/6 and N6, but now as almost all refractive procedures achieve 6/6, and we also know that it does not guarantee satisfaction. We know that we have to look beyond these standard values of outcome to look for more depth in the quality of vision that we can provide to our patients. So this is one of a very recent ARVO meeting abstract, just June 2020, where they studied the binocular vision characteristics in patients before and after cataract surgery. And they found that 60% of their post-cataract surgery patients had binocular vision disorders that affected their overall outcome, satisfaction of the procedure. And most of them almost 60% of them had pre-existing non-strabismic binocular vision anomalies. So there were binocular vision anomalies that were not so apparent because it was not associated with strabismus and only could be picked up by special tests. And cataract surgeons must, according to them, perform a more comprehensive binocular vision evaluation to identify these patients at risk. Another paper is preceded by one study which showed that post-cataract surgery, there is a much lower incidence of hip fractures in elderly. And this study that came after this actually showed that even monocular cataract significantly reduces the postural stability and associated binocularity. So not only binocular cataract, but even monocular cataract significantly affects postural stability, and possibly this is responsible for the higher fractures in patients, in elderly patients who suffer fractures and injuries. So showing us clearly why early cataract surgery and early rehabilitation is now particularly required, so that binocularity is maintained, which affects the posture and movement of everyone. So we know that multifocals are now the new normals. Everybody talks about multifocals, but we know the issues of glare, halos, jumps or step in vision, reduced contrast. The key thing is that a lot of work is going on to overcome these limitations. But stereopsis was a very poorly understood and poorly examined test in these patients. And is it need now for us to look into stereopsis changes post-cataract surgery? So this was one of the studies which we had done, in which we had looked at stereopsis outcomes in bilateral multifocal IOLs versus monofocals. We did 20 patients with the multifocal Acrysoft Restore and 30 patients bilateral multifocal Acrysoft IQ. And of course, the multifocal showed significant improvement in both distance and near visual acuity. The stereopsis also significantly improved. There was a spectacle independence of 80% in the multifocal cases. But though there was an improvement after cataract surgery in stereopsis, which was expected, the values remained much below normal. For near, they tended to improve after giving a +1 near add, whereas monofocals gave near normal distance stereoacuity unaided, and after the near add, near stereopsis was normal. So could this be one of the factors that is responsible for the dissatisfaction in patients doing their routine activities with multifocal IOLs? Another study, which won the Best Award in APO 2019, which was presented by Dr. Tityal, evaluated the distance in near stereoacuity in the ERV lenses, the extended range of vision intraocular lenses. And in this study, we used the AMO Technis Symphony lens. And there again, we found that there was a significant improvement in the distance stereoacuity. While it was very good, it did not reach absolutely normal levels, which you would take to be closer to 70 or less than 100 at least. For near stereopsis, very, very good near stereopsis was achieved, which was almost comparable to normal. So very good near stereopsis and very good distance stereopsis could be achieved with this ERV IOLs. We also found a better stereopsis associated with greater patient satisfaction. And of course, you had much better modulation transfer function on the abrometer, signifying that better stereopsis is associated with higher MTFs. Another recent study we did on the similar Indian ERV lens, the Supraphobe in focus IOL. Again, we evaluated stereoacuity at 3 months, and we found that the distance stereoacuity was very, very good, again achieving near normal values. Although the near stereoacuity was good, was not as good as the one we saw in the previous study. So they were pretty comparable. Near stereopsis was good, but was slightly lower. So we can see that ERV IOLs mark quantum leap in the premium IOLs with excellent visual acuity along with stereoacuity. And it is important for us to routinely assess binocular interaction in all IOLs, especially multifocals. The other thing we looked at for was in refractive surgery. So this was one of our original works we did in 2014, where we evaluated stereoacuity changes after LASIK. And it was also discussed in an article in iWorld, this publication that we had made. And it created a lot of interest. Again, in this, we found that there was a significant improvement in stereoacuity post-LASIK. So with glasses, you had a certain level of stereoacuity and binocularity, which significantly improved post-LASIK. And there was improvement in both distance and near stereoacuity. And this gain was related to pre-operative anisometropia and not the amount of refractive error that was corrected. So it is very important for us to make sure that there is no post-operative anisometropia also. Another study from RP Center had evaluated similar things in the ICL lenses and again showed significant improvement in binocularity and stereopsis after the ICL implantation. So important to remember that the best way to improve stereo acuity in refractive procedures is to ensure good final visual acuity, correct the anisometropia, and minimize aberrations. Stereo acuity is not the primary outcome for LASIK, but now that 2020 is being frequently, routinely achieved, the next level for refractive surgery outcome should be 20 seconds of arc, so 20-20-20. And refractive procedures go beyond a cosmetic surgery. And this should be recognized and acknowledged as a benefit of this procedure because we give a better quality of life to all our patients. Just to show you how we are advancing in this, we are looking at 3D motion perception in patients now in normals and in eye movement disorder. So this is one of the DST device development project, which we are working in collaboration with IIT to actually now test binocularity in motion through depth. So while all these tests, the TNO RANDOT tests stereopsis in a 2D, in a pseudo binocular system by dissociating both the eyes, we are now giving them motion stereopsis tests and trying to generate help to test real stereopsis while we are moving, which is the normal condition that happens to us. And this was part of one of our publications in the TVST, which is about to come out, which was motion perception used for visual field testing also. And just to show you, this is again a contraption device for in the COVID times to actually sterilize all these VR goggles and the testing apparatus so that we do not risk spreading COVID in the patients while we are doing these tests for motion perception. So I just want to say, as we are completing and finishing a very dark year 2020 in our life, we have to go beyond 2020 and look for 2020 and produce great stereopsis here. So I just want to acknowledge the pediatric ophthalmology and cataract refractive specialty, many of the doyens who are present here and who have presented here from RP Center from Ophthalmic Sciences AIMS, IIT Delhi, with whom we are collaborating for many of these advancements, and of course Delhi Ophthalmological Society that has helped me so long and has always been given me opportunities like this one. Thank you very much, Dr. Subhash, Dr. Namrata, and entire DOS fraternity.
Congratulations, Dr. Rohit.
Thank you, Dr. Subhash.
Thank you so much, Dr. Rohit, for your presentation, which as usual was outstanding. And again, we will confer this virtually to you because we cannot do it in person. And thank you, Dr. Sanjeev Mohan, for being with us today. I know that you are there for all the Hari Mohan Oration Awards. Thank you so much for your kind presence. And we do remember Dr. Hari Mohan sir. Almost all of us have been in interaction with him with gratitude and with respect. So
thank you, Namrata. Thank you so much for allowing us to be a part of DOS. And thank you for conducting this. I've been listening to all the orations, and my hats off to you to have done such a beautiful program. Thank you, Namrata. And congratulations, Rohit, for your oration.
Thank you, Dr. Sanjeev. Thank you for being present. It was really, really great to have you here.
Thank you.
The last oration is the Dr. B.N. Khanna oration, DOS 2020. And it is my pleasure to introduce the speaker, Professor Rajesh Sinha, who is also a colleague. I know him since his postgraduate days. He's done MD ophthalmology from AIMS, then subsequently went on to do pool officer or senior research associate at AIMS RP Center. He's very qualified, DNB, FICLE and FRCS, and he's done also a fellowship from the University of Washington, Seattle. He has more than 350 publications to his credit, 4 textbooks and 5 educational manuals. He has been a part of 3 multicentric FDA clinical trials. He has received multiple awards. Notable amongst them are the Achievement Award of American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology, SAARC Academy of Ophthalmology, and he has also been nominated the Professor of Asia Pacific Academy of Professors in Ophthalmology. Again, a very unique award. He's been recipients of many notable orations all over the country, and he's currently the treasurer of All India Ophthalmological Society, SAARC Academy of Ophthalmology, and the Eye Bank Association of India. And he's the dynamic secretary of the Indian Society of Cornea and Keratorefractive Surgeons. I would now request Dr. Rajesh Sinha to give his oration.
Thank you, ma'am, for this nice and kind introduction. And at the outset, I would like to thank the DOS executive, especially the president, Dr. Subhash Dadia, and the secretary, Dr. Namrata Sharma, for having me here, for giving me this honor of presenting the prestigious Dr. B.N. Khanna oration. And it's a wonderful moment for me to remember Dr. B.N. Khanna. I was one of those privileged people who had the opportunity to meet him. He was very hardworking and a dynamic person. Actually, he came to India after partition. And about 70 years back, when he started his crusade for eradicating blindness, he didn't have any resource to do. He just had the willpower and the guts to do the hard work. And then many like-minded people joined him, and then he started several charitable eye facilities all over India with 2 high-tech centers, the Khanna Eye Center, which was started in 1951 by Dr. B.N. Khanna at Fatehpuri, Delhi. And then he initiated many activities. He was known for his tireless efforts for eradicating blindness from our country for over half a century by doing more than 6 lakhs free surgeries all over India in Bihar, Jharkhand, West Bengal, UP, Haryana, Orissa, and Rajasthan. And unfortunately, Dr. B.N. Khanna, who lit the lamp of light in lives of millions, left us indebted in 2015. He was a visionary, excellent clinician and surgeon, and a great social worker. And his legacy is being carried forward by his 2 able sons, Dr. Rajinder Khanna, who is the past president of DOS, and Dr. Sanjay Khanna. And it's my proud moment to be, delivering the prestigious Dr. B.N. Khanna oration. Dr. Khanna was involved in eradicating blindness due to cataract, and that's why I thought that there should be a topic related to it. And that's why malpositioned IOLs, complicated scenarios which he has been handling, I thought to present. And basically, malpositioned IOLs means that IOL which is not in position. Now, what is the IOL in position? The IOL in position means the center of the IOL should coincide with the visual axis, and that's how you can have the best quality and quantity of vision. But if the IOL is not in position, this means that the visual axis and the center of IOL are at 2 points, and that can lead to various problems like prismatic effect, astigmatism, lenticular. Then there can be dual zone, aphakic and pseudophakic, and the patient can have problems. If there's gross decentration, then there can be aphakia and the problems related to it. And if the IOL is decentered in such a way that it is causing some problems due to mechanical effect, like touching the endothelium, causing endothelial decompensation, or can cause glaucoma, then these are quite serious and severe problems. So the issues that can happen because of malpositioned IOLs can be suboptimal visual acuity due to so many reasons, and of course, certain complications like glaucoma, corneal decompensation, etc. So the aim of management is to recenter the IOL by minimal manipulation, because all these cases, they have undergone multiple procedures. And if you do, maximum manipulation in these cases, more manipulation in these cases, that can lead to more complications. So one should try to be minimally manipulative. However, you want to have a stable and well-centered IOL on a long-term basis as well. And apart from that, you have to manage associated complications like glaucoma or corneal decompensation. So I will just be discussing about a few case scenarios, because decentered or malpositioned IOLs can have a spectrum of presentation. Now, I'll just show a few of these spectrum to, and we'll show how these things can be managed. Now, this is a decentered IOL. You can see it's a damaged capsule here, and there is some subluxation here. That's why the lens is, shifting on one side. Now, since the capsule is intact in this area, you can just dial, just make a small entry, stab incision, inject a little bit of viscoelastic, dial the IOL in position, and this IOL can remain in position once. This is a 6.5 millimeter optic, the all PMMA lens. So just by dialing, if it remains in position, it will remain for a long term. So that is a minimally invasive manipulative method of recentering the IOL. But sometimes it doesn't work. Like this is a case of traumatic cataract with repaired corneal perforation, wherein IOL, multi-piece IOL was put in the sulcus. It decentered, it was recentered again, but again it decentered, and it is going on to one side. There is zonal adhesions here. You can see the capsule damaged, and the IOL is going on to one side. Now, fortunately, this patient had a capsular, rim with a ring, actually, with a fibrosed margin. Now, this size was slightly smaller, but a decent, reasonably okay size for capturing the IOL optic. So this is a good option in such cases to capture the IOL optic, so that once it is captured and it is in position, it remains rock solid throughout life. So unless there's a trauma. So this is another method of handling such a situation if there's a decentered IOL, if we have a good rim or good capsule for capturing it. Now, this is another scenario wherein a patient who had undergone an uneventful cataract surgery and then had a trauma, and then the IOL haptic along with the bag is shifted anteriorly. There is zonal dehiscence here in this part, almost 90 degrees, and then the capsule and the IOL optic haptic has come anteriorly. Now, the remaining zonules are absolutely fine. So if you can stretch this part with the help of an endocapsular ring, then the remaining zonules will support. So this endocapsular ring, if you place in the bag, as the ring is advanced, you can see the capsular bag goes posteriorly and it comes in position. So now you can see that the bag has almost gone behind the iris and it is in position. So once you place about 270 degrees of zonules are intact, and this is not a progressive condition, it was because of trauma. So you can expect the IOL to remain in position for the rest of the life. Now, another scenario wherein the bag is there, the IOL is in the bag, but there is a huge decentration, a lot of about 270 degrees of zonal adhesions. So in that case, you cannot expect an endocapsular ring to work. So what we can do here is that we can hook this haptic. We can fix this haptic with the help of a lasso suture. So a groove is created about 1.5 millimeter behind the limbus, and then a stab incision just opposite to it. Now, a 9-0 Prolene suture needle is introduced to this groove, go behind the haptic, pierce the capsule, come over the optic. And that is how you bring this straight 9-0 Prolene suture needle. And then you dock into a 26 gauge needle introduced from the paracentesis in the opposite side, and then you bring it out. Now, in these cases, you have to keep staining the vitreous with the triamcinolone. But in this case, the patient had asteroid hyalosis. And every time the vitreous used to come into the anterior chamber, it was already stained. So that was one work less for me. And you should not do any manipulation if the vitreous is in anterior chamber. So whenever vitreous used to come due to manipulation, the vitreous had to be removed. Now again, little bit of vitreous has come into anterior chamber. So before I pull the suture, the vitreous has to be removed. So the vitrectomy is done. And now with this lasso suture, the loop around the haptic, you pull the haptic, and now the lens with the bag is in position. Now you have to be very careful in tightening the suture. If you pull too tight, then you can damage the zonules on the opposite side. So you have to be a little careful, and that is what it is. And as you can see here, the lens is right in position. Now, another scenario, a case of UGH, recurrent UGH, uveitis glaucoma syndrome, wherein the patient used to come with very high IOP, AC reaction. Why? Because this lens is inverted and has been fixed somewhere. There's no capsule visible. So because of recurrent UGH, the lens had to be repositioned. So this lens was inverted. One haptic was taken out so that to ensure that the lens doesn't fall. And then this one haptic is exteriorized through a sclerotomy made under the scleral flap. And then second haptic is also exteriorized. And now intrascleral haptic fixation is being done. So the haptic is being tucked into this groove created adjacent to the flap, and then the conjunctiva is also placed in position. Now, once the IOL was in correct position, the patient had no symptom following that in the follow-up period. Another scenario, this patient, this eye looks aphakic, but it is not aphakic. There is one IOL in the bag hanging in the vitreous cavity. A patient who was vitrectomized had the IOL in the bag, but it was hanging, no vitreous, fluid-filled eye, but a little bit of zonules left. So in such a case, if you can lift it up with something, as in this case, I have used an endoilluminator to lift the IOL and pass 2 lasso sutures around both the haptics. That will fix the IOL in position. So one lasso suture is being passed through the scleral groove, going underneath the haptic, piercing the capsule, moving up over the optic, docking onto one side and creating this loop. So one knot is being tied. Now you just have to pass one knot, because if you tie multiple knots, you can decenter the IOL, because you have to titrate the tightness of the suture on both sides. Once you have done it, you remove the endoilluminator, you can see that the lens with the capsule is right in place and centered. And so this is also one way of handling such a scenario. The last scenario that I'll be telling is that if a patient has developed a decentered IOL, this IOL, there's an IOL in the anterior chamber which is touching the endothelium. So it is causing endothelial decompensation. So in order to have good vision, we not only want an IOL in physiological position, but also we have to replace the diseased endothelium. So we are doing an ultra thin desec along with intrascleral haptic fixation of IOL. So the sclera is marked at 1.5 and 3 millimeter positions. Intrascleral, the lamellar dissection is being done, and then a groove is also created adjacent to the flap. You remove the epithelium in order to improve visualization. And then you do the Descemet's scoring of this diseased Descemet's. And once you have done that, you would like to remove the IOL which was touching. This was an AC IOL which was touching the endothelium, causing endothelial decompensation. You make stab incisions on both sides on the scleral bed, and this is a multi-piece IOL which is being introduced. The tip of the haptic is held and the haptic is exteriorized on one side. The other side also, the haptic is exteriorized. And once both the haptics are out, you introduce the haptic into the pocket created adjacent to the flap. And once both the haptics are there, you put fibrin glue to stick the flap and the conjunctiva, scleral flap and conjunctiva. And this is a donor endothelial donor lenticule, which is being introduced into the anterior chamber. And once it is there, you inject air so that the lenticule is properly retained in position. Good tamponade created with the help of air. So these are some of the scenarios. You can have a spectrum of such conditions, and depending upon the exact condition, you have to manage it. The basic idea is to center the IOL and manage associated complications in order to obtain good visual outcome. And apart from handling these patients clinically, a good patient counseling is very essential in order to have a good patient satisfaction. So in the end, once again, a big thanks to the DOS executive, Dr. Dadia and Dr. Namta Sharma, for giving me this opportunity to present this prestigious oration. Thank you.
Congratulations, Dr. Rajesh.
Thank you.
Yes, Subhash. Carry on. Subhash.
Congratulations, Dr. Rajesh, and we will be presenting it physically once the situation normalizes. and we are hopeful situation will normalize very soon.
Yeah.
So congratulations,
Thank you.
Rajesh, for the PM Khanna Oration Award.
Thank you.
Thank you, everyone. Thank you all the orators for being with us and for your excellent orations. Now I think we'll move on to the next session. Praful is there. Thank you. Thank you, Dr. Dadia. Thank you, Sanjeev. Thank you, sir. Dr. Grover, sir. Thank you, Rohit and Rajesh.
Thank you.
Khanna was also there.
Dr. Grover, sir.
Dr. Khanna, sir, was there.
I think maybe there's some network issue.
Praful, can you take over for the next session? Praful, are you there? Okay, welcome everybody to this next session, and this session was actually essentially designed by Dr. Praful Marana. I think he's there and he'll be joining us very soon, and it is on basically career opportunities and exams for the postgraduates. Thank you, Dr. Andrew Begenza, for being with us. I saw Sushmita was there. Yes, thank you, Sushmita. Dr. Kalpana Narendran also. Chaitra, thank you for being with us despite your not very good health. So Praful, can you please start and introduce? Thank you, Paramita. You have to unmute yourself, Praful. Unmute.
Entire idea of keeping this session is to help the resident. At least we can give them some tip about preparing for exam, and after that, what are the opportunities that is there in India. So fortunately, we have a lot of experts from all over India. So it will be a very good session for the resident. So I'll start with my presentation. It's basically giving few tips and tricks about how to prepare for your exam. But before proceeding with my slides, first thing I would like to emphasize is especially to the residents, you know what are your strong points, you know what are your weak points. So your study plan should be based on that. What you can take from us is few tips that may be helpful to you in few aspects, but ultimately it is the you who is going to face the exam. So this is the typical pattern at RP Center exam pattern. I think almost all over India this is the same. First you have to appear for theory, then practical, and practical and practical. At RP Center it's a tiring 3 days practical program. At other centers maybe 2 days or 1 day. So as you can see the smiley, first day you are happy that okay theory is over, second day you are a little bit worried, third day you start crying, and fourth day you are completely clueless what's going on. So that is the problem. So this is a scorecard of one of the SASA international series that India faced Australia. As you can see in the left column, almost all batsmen are good in batting, but on particular day one person outperforms others. Why this happens? Because maybe partly luck and also by preparation. So this is what happens in exam also. You have to compete with your colleagues, and nobody is having IQ dramatically less than you. So almost all of us equal IQ, but the clue in getting maybe the gold medal or the best among the best is how you prepare, and the most important, how you execute in the exam. So I'll discuss this theory preparation in two headings. One is preparing for theory and the other is what you have to do in exam. Yes, books are standard for preparation for any exam, but articles, notes, online information, and previous year's papers, they do have some role. So I'll just highlight few questions from AIMS MD exam that will help you know the importance of all of these things. For example, in 2010 MD ophthalmology exam, there was a question on recent trends in dry eye. So if anybody would have read a textbook, it would have been very difficult for that person to attend this question in a perfect manner. So if just to highlight, there was an article on dysfunctional tear syndrome in 2007 in Cornea. And if anybody would have read this article, even if not read the article completely, if you would have gone through the tables, for example, they have classified the dry eye depending on the cause. They have created a severity level. They have mentioned the signs which are to look for in a patient of dry eye. And finally, they have created a severity level based on which the treatment should be planned. So anybody who would have read this article, he will definitely outperform others in appearing for this specific question. So articles are required only for specific few specific questions that you may get idea from your previous papers, but textbooks are standard. Notes, yes, there are people who are habitual of making notes of everything. That is a very good habit if you can make note, because in ophthalmology one of the problem is very difficult to get a standard textbook where you will get everything in one place. So you have to refer multiple sources, at times books, at times articles, at times from DOS times or some AOS times or CME series or conferences. So it's better to prepare your note. Just to give you one example, when I was preparing for MD, Vitreous hemorrhage used to be a essay type question, and the source which we used to refer is Ryan's textbook of retina, where it was a 12-page chapter, and Survey for Ophthalmology review article that had 28 pages. So it's practically impossible to revise from these sources just before your exam. So it's always good to prepare a note of this important topic so that you don't struggle towards the end of your exam. Online information, there are few topics that you have to refer to online. You have to refer to online information. Just to highlight one example, there was a question in Delhi Medical Council about ocular manifestation of dengue, and if you would have searched in any textbook, then you may not get adequate information. But if you would have read this article, which is nothing but a review article, then the person would have scored better than the others. So for preparation for theory, books are a must, but articles, online sources, and notes, they give you an extra edge over your colleagues, and they will help you in scoring extra marks. Previous paper is very important. I'll share one of my personal experience. I never used to refer to previous paper while preparing for ND exam. And just 1 week before my exam, I was just going through the previous paper, and there was a question like current trend in management of wet ARMD. Now, if you search in any standard textbook, you will never get a perfect answer to this question. You will have to compile, and you have to think, and then you have to answer. But if you would have referred to some review article or recent journals or some CME series, this answer could have been easily available to you. So that's why you should refer to your previous papers, because the questions are little bit twisted. So that will give you an idea how to prepare for your exam. Now, this is very important. Even if you have done your hard work for 3 years or 2 years, you have to present it in a nice manner. For example, if you notice, none of the examiners, they read each and every sentence that you have written in your answer sheet. They just go through your paper, and if you highlight the important things, they will go through that, they will see that, and they will feel that, okay, this guy knows this much, so let's give him some good score. So presentation is very important. For example, if a question comes on management of keratoconus, if somebody likes to write like this, then and the other student just put a chart like this. If it's a keratoconus, thickness this is the option, thickness is less than 380, this is the option, then examiner will definitely give good score to the second student. Similarly, natural history of keratoconus, you write a complete text, somebody just gives a chart like this, then definitely that guy has an edge. Nowadays, it's very easy for you people also, because PowerPoint gives a lot of options like smart arts. You can use this smart art graphics to create your own charts during preparation, so that just before exam, simply revise those charts, and you can put those charts in your answer sheet if a question comes on that particular topic. But never create chart like this. If you prepare a chart like this and put it in your answer sheet, the examiner will definitely give you negative marks, because it's very, very confusing and it's very time consuming. So make presentation simple, easy to understand, and try to present your answer in as much as tables, charts, and highlight important things. That those are the clues that will help you in appearing your theory exam. Practical, yes, practical is very difficult in ophthalmology. Why? Because we have so many things to answer there, like long case, short case, instruments, grand viva, images, all these things. So what at the onset, I'll advise you to either prepare note or refer to some standard textbook that gives you in a practical point of view. In the standard textbook, you will never get like history, present history, past history, provisional diagnosis. So coming to long cases and short cases, I'll just elaborate that point here. See, long cases, short cases, the primary focus is on history taking, but none of the standard textbook will teach you that. Okay, so for that, either you prepare note or you can refer to standard textbooks. There are some special books that primarily deal with practical aspect of these things. For example, the corneal ulcer. Okay, if you read this textbook, all the chapters, and you get a long case in corneal ulcer, then it's very difficult for you to approach it perfectly. But let's take example of this chapter here. Cornea conjunctiva, corneal ulcer, it starts from history itself. Chief complaint, history of present illness, then past illness, then what are the things to look in exams, then what are the clinical feature of specific keratitis, then differential diagnosis. So if somebody has prepared from this textbook, then he will definitely do well in exam. If you don't want to follow any such textbook, then you can prepare your own note. Similarly, while answering in your practical exam, don't jump onto rare things. For example, if your examiner asks you what are the causes of PBK or pseudophakic bullous keratopathy, student one would start from Brown-McLeod syndrome, chronic uveitis, IOL endothelial touch, and all rare causes. Although these are the causes, but the examiner will never be happy. Instead of that, you could answer complicated cataract surgery, Fuchs endothelial dystrophy, and viral keratouveitis. So even if your number of answer is less, but you'll score better than the student one. Instruments, see, whatever instruments are there in your exam, these are from your OR only. So it's always a good habit while doing surgeries or while working in OR, you should take picture of those instruments so that you remember them. And again, either prepare note, or there are several books in the market about instruments in ophthalmology. You can follow those things. Appliances means I'm not aware about other exam, but the RP center, we do give appliances like any equipment, and the student has to answer viva about that. Again, refer to some standard textbook for preparing for such appliances or other vivas. Images, this is very common in all form of exam, be it DNP or diploma. They will give you one image, then they will ask you interpret this image. For that also, I would advise you prepare special notes, because in textbook they would never teach you how to read an image. They will just describe that. So either you prepare your note, or you refer to specific books where they have clearly given that, okay, if you get this image, start with this, observe these points and interpret from this. Lastly, grand viva. So every exam ends with a grand viva, and in viva, remember few points. Don't answer rare things, which I've already highlighted. Prepare a list, because ultimately it's your internal who is going to pass you. So prepare a list of favorite questions from your internals, and you prepare accordingly. Take your time. Don't jump to answer the moment you hear a question. Do not argue. If your examiner is you feel that examiner is wrong, even if you think that okay, you are right, but still don't argue with them. You will get better opportunity later on. Keep your references. Whenever you are quoting some figure, the immediately examiner will ask you what are your references, and please don't say that, sir, I have read this from eMedicine or from Wikipedia. It's better to keep standard textbook references or some standard articles. Don't give excuses, because I have seen as an examiner in our center, a common excuse by students is, sir, I have read this, but now I'm not able to answer. Don't give such lame excuses. This is not going to help you. Don't panic. If you're not able to do good in one station, there are other stations. So no need to panic. This is just an exam. Move on to the next station and try to do good in that. Okay, with this, I'll conclude this talk. These are the two books. The primary aim of these two books is to help students appear in an exam. But as I said, there is no standard thing. You prepare according to your study pattern, and you can prepare your own note. You can still, that will still help you in appearing for exam. With this, I'll conclude this talk. Thank you very much for your kind attention. I'm sorry, my voice went a little bit horrible in between. So are there any questions? If there are no questions, then I will request the next speaker to take over. I think Dr. Paramita, the next talk is yours. Yes.
Thank you. Good afternoon, everybody. Thank you, DOS, for giving me this platform to talk about options about what to do after post-graduation in ophthalmology. Now, gone are the days when ophthalmology used to be an end branch. Now, with multiple subspecialties available to specialize in, it becomes essential to decide early on your long-term goals. Consider your finances, whether you have the aptitude for teaching and research, or you have great patient handling skills. Another important factor which impacts your decision is where you plan to locate, where you plan to ultimately settle. Now, if you don't intend to have your own private setup, it is essential to gain additional experience before you get good employment opportunities. Also, it is rare that you would be completely confident about your clinical and surgical skills after post-graduation alone. Maybe it is something to do with the fact that each part of the eye requires detailed study, and also surgical expertise of a particular subspecialty is not gained in post-graduation when you are only allowed to assist and observe. Also, the number of cases a postgraduate student gets during his or her residency is determined by the number of students in that batch in a teaching institution. So coming to the options that one has after post-graduation, these are senior residency, subspecialty training or fellowship in a reputed eye center, joining a corporate setup, charitable eye hospital experience, applying for fellowship or getting a job in another country, starting your own eye hospital, or joining a small private setup with your own private practice. So coming to the first one, that is joining a medical college as a junior doctor or a senior resident. So there are a number of pros with this option. You have the leverage of working in a medical college setup. There is security in working in a teaching institution. Additionally, if you have joined your own medical college, you're already familiar with the setup and the staff. You get adequate clinical and surgical exposure. You gain teaching experience, which is a must for future teaching jobs. Then you have ample research opportunities, and in certain specialized centers like RP Center and Guru Nanak Eye Center, a senior residency is equivalent to getting a fellowship. However, there are cons. There is disparity in pay scales across states. If you are ultimately planning to set up your own private practice, you are actually delaying the inevitable. And during senior residency also, you are not completely independent. You are supervised by your senior consultants. Then coming to subspecialty training or getting a fellowship. So fellowship training programs are available in cornea, refractive surgery, retina, uvea, glaucoma, oculoplasty, pediatric ophthalmology, neuro-ophthalmology, and cataract. So again, number of pros. You gain specialized training in a particular field, learn the latest techniques, have ample research opportunities and chances to publish. After completing your fellowship, you get a number of job opportunities, though these may be concentrated in urban areas, or you may opt to get multiple attachments as a consultant in a number of hospitals. However, there are cons. The more specialized you become, the number of job opportunities may actually go down, especially in peripheral centers where there may not be adequate setup. Also, fellowships are time consuming. They take at least 1 to 3 years and the pay is less. Another easy option is joining a corporate setup. These jobs are largely concentrated in urban areas. The pay is good, whether on a fixed or a sharing basis. Again, the cons, at least in the early period, you may be limited to medical management of cases. You may not get to operate. You may be overshadowed by big names, and there would be no job security. Another good option is joining a charitable eye hospital. Here you get to do high volume surgeries. You have job satisfaction because you're serving the less privileged. You have good growth opportunities. The con being the pay may not be as good. Another good option is getting a job, government job as a specialist, as an ophthalmologist. Again, job would be satisfying because you would be dealing with huge numbers. There would be job security. But the con being the number of such advertised posts are very less, and you need persistence to make improvements in such setups. Another option that a lot of people consider is getting a fellowship or a job abroad. Here, we have to remember that our postgraduate degree is not recognized by most countries outside. You have to appear for special medical licensing tests or country-specific board certification for getting residency and jobs. The cost of application is high, and you have to remember that fellowships like those sponsored by ICO, International Council of Ophthalmology, these are largely observerships. You do not actually get to observe, but you do learn a lot. And also regular positions often demand specialization and expertise. The pros in this avenue are you have a change in lifestyle, there are definite long-term financial gains, and basic science research opportunities may actually be better. Though in India also we have good basic science research opportunities. The good part about ophthalmology is that there is very less mortality and morbidity, and there are no critical patients, and emergencies are by and large very less. So if you are planning to set up your own private hospital, you have to first consider the financial aspect. The pros are this is the avenue that offers the best growth prospects. You are your own master, you can employ or call specialists as per need. However, you are burdened with additional management responsibilities, and you have to invest a lot of time for your setup to be successful, and you have to create a name in the long run. And then another viable option is you can run an independent OPD and operate in an attachment hospital. So this saves you setting up OT costs. However, a large chunk of whatever payment you receive goes to the attachment hospital. And this arrangement may or may not work long term depending on your relationship with the hospital you are working in. So that's the take-home messages. Additional experience is essential both for better job opportunities and before starting your own practice. However, specialization is not essential for success, but specialization generally will give you an added advantage. And ophthalmology is a branch which gives us a dual satisfaction of both medical and surgical management. And whatever we decide, we have to keep ourselves updated with the latest diagnostic tools and treatment procedures to advance our career. Thank you.
Thank you, Dr. Paramita, for the wonderful lecture. It will definitely help at least the students who are appearing this year in the exam to decide what to do next. We have Dr. Susmita Kaushik from PGI. She will be speaking about the opportunity at government setup. So she's from PGI, so she can better discuss all the things that is there in government setup, including RP Center, GNEC, PGI. So I would request her to start her presentation.
Okay, I'm having a bit of a problem since morning in slideshow. I'll try it once. I'm audible, I hope?
Yes, ma'am, you're audible. Your slides are also visible.
Yes, but they're not moving. So screen has stopped, it's closed. So I'll present without a slideshow. Will that be all right?
Yes, ma'am, that will go.
This happened in the morning also. I'll share it again. So the minute I do a slide show, it stops sharing for some reason. I don't know what. Can you see that now?
Yes, ma'am, we can see that. You can continue with this.
So I'll just make, I'll present like this. There should be no problem. Yeah.
Yes, you can continue like this. It's
okay. So thank you at the outset, Dr. Namrata, for this very unique thing which I had to apply brain to. I didn't know what was expected, but essentially I would be talking about the PGI because this is where I've been for the last almost 20 years now. And pretty much it's not government institutions, unfortunately, is not one basket. We must understand that. So I'll give you an example of what is possible. And then we'll go on to see what else we can do. So the first thing to look out for any institution when you're going to wonder what you're going to do is the institution's reputation, the faculty profile, the infrastructure, the practical learning, and the workplace value. And Dr. Namrata also told me to talk about a little bit of what is offered in PGI. So in addition to the post-graduation, I'll also talk about the various courses that we do that you could pursue after PG. So what to expect and the opportunities waiting to be grabbed. And here I'm sharing two of our young, bright students, Anirudh and Anand, who were adjudged the best resident of PGI in their respective years and being felicitated by the president, by the Prime Minister, sorry. So this is the department of ophthalmology. We, like the RP Center, we have our own advanced eye center. But before we go ahead, we must realize that PGI, like RP Center, is a privileged government institution, if I may say that, because it's an autonomous institute of national importance with independent funding, and it has high quality tertiary care services to over 80 million people. And that's why they become the preferred institute for graduate and postgraduate education. So I just like to play out this one clip, if it does.
They were doing very well, better than most in the country. Ran a structured postgraduate program and regularly published papers, many of them seminal, but then we did not excel. People did not know that we existed. When the baton was passed on to me some 30 years ago, the world was changing. And I realized, and my friends Jagat and Manka, joined later by Arun, Pandav, Usha, Vishali, Sushmita, among others, agreed that if we were to make a mark in the world, we had to evolve into an institute that provided state-of-the-art facilities in all subspecialties and care. Advanced Eye Center to
Right, so I played this because this was recorded a couple of years ago for one of Professor Jagat Ram's talks. So I borrowed it from them because this, at least our center, I'm sure RP Center as well, is a culmination of a dream where people ask, why not? So, yeah, there you are, you got stuck again. Okay. Right, so we the people right now are 24 clinical faculty, 1 community ophthalmology, 1 basic science, 36 junior residents, 20 senior residents, and we also have something called a fellow in glaucoma, 3 MCHs in cornea cataract, and 6 MCH in vitreoretinal diseases positions. So we grow up in an environment of teaching, research, and excellence because of all the pioneers who made the department. And the services are dedicated, there are dedicated faculty in each. So our strength is that we've diversified very early. So if you come here, you usually are assigned not to so much to a unit as much as to a specialty very early in. So that's something unique. We have pediatric ophthalmology, cornea, vitreoretina, neuroophthalmology, uveal diseases, glaucoma, oculoplasty, and cataract and refractive surgery. So these are the broad areas. Of course, if you're part of an administrative unit, you might be called on to do this, that, and the other, but typically you sort of stick to your niche. And what is on offer? These are the courses, the MS, of course. We also have a B-Optom and the super specialty courses of an MCH, like I said, in BR, in cornea, and a fellowship in glaucoma. So I'll just take a second about the fellowship. That's unique in the sense that the MS ophthalmology is of course the same. The duration is 3 years, entry is all India, twice a year. So we have 2 batches a year. Eligibility we know is MBBS, categories are as for the government. And requirements for completion are all this: 1 dissertation, continuous assessment. We do have periodic internal assessments and we have exit exams. So the VR and cornea MCH is a duration of 3 years, again 2 batches in Jan and July. It's a national competitive exam online. There are multiple centers now. And the exam is in 2 parts. Half of it is general ophthalmology and half is in the specialty. And the eligibility is MD, MS or DNB. Categories are as the government required. And the requirements are again 1 thesis, continuous assessment, and again the exit exam has 4 theory papers. So this I said I would, this is a bit of a unique thing because it's a duration of 1 year, again 2 batches. But what we've tried to do, we've realized that when people used to go out from AIMS, PGI, GNEC, especially in the southern part of the country and especially abroad, what sells is something called a fellowship. And senior residency was not really recognized or understood. And we had to explain that senior residency means doing a fellowship. So this is really the 3rd year of senior residency. So the eligibility is 2 years of SRship in ophthalmology. And then the entrance exam is an all India exam, and anybody with 2 years of senior residency can do that. And the third year is also teaching experience. So when you come out 3 years later, you have a 3 years teaching experience under your belt for a government job as required, but you also have 1 year of fellowship in that same program. So I thought this fellowship in PGI are in multiple specialties, and all super specialties now have these fellowships. So they start off like that, and it's come out to be very useful. B-Optom, of course, is a BSc course, so it's an all India exam, again, twice a year, eligibility of class 12 with science. Categories are as usual, and they also have a year of internship in which they get a stipend. So this is what an MS student can expect: tremendous clinical work. That's the first thing. It's a referral institute for the entire northern region, and it's a huge clinical experience with a footfall which is really mind-boggling. Rigorous, dedicated, daily structured teaching in the morning, state-of-the-art technology in specialty labs across all specialties, basic research labs, and surgical training is initiated in the wet lab on animal eyes and then on a simulator before going on to the human eyes. So I'm sorry, it seems to have got stuck again. Oh dear. All right. So this is just exposure to world-class technology in every field. And what the super specialty can expect is a well laid out syllabus and a semester-wise syllabus coverage, 2 dedicated MCH fellowship classes a week. Now this is an addition, and they also have to teach the MS students. So we have more teachers with us. The surgical training, as for all super specialty centers, whatever is required, you have latest techniques in cornea, VR, and glaucoma procedures. But uniquely, they all have to maintain a detailed surgical logbook. I can't forget mentioning that a special place in our hearts at PGI are our babies, somehow. And we do offer world-class care for these precious ones. So our niche and our hearts really are with ROP and pediatric retina. Incidentally, Dr. Lingam Gopal, Dr. Subhadra, Anand, Vinekar are all prodigies of PGI and students of Dr. Dogra. So maybe that's where the legacy continues. Pediatric glaucoma, of course, you all know the special place in our hearts for that. Pediatric cataract and strabismus, Professor Jagatram is known all over the world for the work he's doing. And retinoblastoma is is with intraarterial, and all the gizmos that they use is very state of the art as well. But more than that, it's a multicultural life experience, enriching experience, because when they join, they are from literally every part of the country. And initially, it is so funny the way they try to figure out not just Hindi, but then the Punjabi and then the Thet Punjabi. So it's great fun to see how they go through the OPD with the language barriers and all. So these are snapshots of life at AEC. So we have birthdays, we have parties. Unfortunately, these are pre-corona times, and we hope they'll come out again. And this is after a day in the OR where you just slump down on the 3 sofas that you have, absolutely drained, but still happy for having done a day's work. So this is distinguished alumni across the globe. I thought it's important that I put this up as well. So coming to whether or not you should take up a career opportunity in a government institution. Now, I am biased because I'm talking from a very privileged position, but by and large, I can say that whether it's yes, well, you need senior residency for faculty positions, you have an assured salary, and usually it is incremental, though very, very nominal. The academic perks are the opportunity to work and the opportunity to showcase your work, as all of us here owe whatever little we are known by the opportunity we got as to where we were. Vacations, of course, one huge thing that all my friends who are not in teaching are very, very envious of. Teaching, if you like that and you like the sound of your voice and you like giving gyan, learning when you teach, and of course conferences and the excitement of that. There's no investment. The Bijli, Pani, workforce, infrastructure, the Sarkar pays for it. So that way it's easier. The downsides are the patient load and work, which is overwhelming. At times, it really, really bogs you down because you want to do so much more and you can't. The equipment, you need to chase everything. It's cumbersome, you have to go around babudam, but it's completely your initiative, your grit and your conviction, and you can do anything that you want, really. Thank you so much. Come, see, and help others see. Thank you for the opportunity again.
Thank you, ma'am, for the wonderful lecture and outlining what all options are there at PGI. We have Dr. Andrews Braginda. He has also a vast experience of work in one of the premier government institute of India. I think he can, if he can give his input about, because PGI RPC may be the privileged institute, but there are also other institute, government institute where you can explore your opportunity. I think he can give us an idea about that.
I'm going to cheat and say Dr. Andrew is from PGI as well. So
well, I'm currently in CMC and have been for the last couple of decades. And CMC Vellore is actually not a government institution, but it's a unique kind of place because it's a not-for-profit charitable institution with very high academic standards and rated one of the best medical colleges in the country. So it's a different kind of place. We have our pros and cons, and they're very similar to what Shushmita outlined, which is that you do get the opportunity to sort of create your own drive and initiative. But we also have a huge amount of inertia to overcome, administrative, blockades, restriction of resources, mainly finance, because we are a self-financed institution. So you can initiate and pursue your interests. You do have a tremendous amount of independence in how you want to function. But ultimately, you are there for patient service, and that patient service has to take the first priority. So all of us in my department are fairly academically oriented, but we have to kind of put that secondary to serving our patients. So we are teachers, we are a medical college, so we have postgraduate trainees. We all of us are thesis guides from a fairly mid-level of once we join as faculty. And we are involved in active clinical research and even some laboratory-based and basic science research. We have a very active stem cell center, and a couple of my colleagues are involved in stem cell research related to ophthalmology also. So you have the opportunity in an institution like CMC, which is which is an independent but institution of extremely high standards as far as basic science as well as clinical science is concerned. We also have the huge advantage, just like PGI and AIIMS, of having multiple super specialty departments. So there's a lot of inter-referrals and a lot of discussion over cases which involve multiple specializations outside ophthalmology. And of course, within the department, we have the opportunity to, even though we occupy our own niches in super specialization, we do have a unitary system where we do rounds with all the other consultants so that I can stay more or less up to date in what's happening in retina and in cornea and things like that, just from listening to what my colleagues are discussing. And that's a huge advantage, because I think it's a little bit of a mistake to isolate yourself and become too much of a super specialist, because that's not how our country functions. And if you really become highly specialized and only capable of looking at patients which are in your field, then you become limited as an ophthalmologist, and you are limited to the place where you have learned this. So you become unemployable elsewhere. So I would strongly advise junior colleagues to always try and stay in touch with what is happening in general ophthalmology, even while pursuing your deeper interests. So that's about all I have to offer as advice.
Thank you, sir. In fact, that is really true. When you our fellows or our SRs, they realize when they go into private practice, because when you are doing a general OPD, and if you have done only retina for 3 years, then you get confused when you see some cornea cases. So that is a very valid advice to the residents. And if we don't have any comment, then we'll move on to next presenter. Now, everybody doesn't like free Bijli Pani setup, right? So there are people who leave government setup and they go into private practice and they flourish there. So we'll have Dr. Kalpana Narendran. Ma'am will be speaking about experience at Arvind Eye Hospital and what are the career opportunities there. Yes, ma'am. Kindly start your presentation. Thank you.
Thank you, Dr. Namrata, for giving me this opportunity and being part of this, unique session. So, the career options which are offered in Arvind Eye Care System. Just to briefly introduce about me, I've been in Arvind for almost 30 years now. I did my post-graduation here, specialized in pediatric ophthalmology, and now I'm in Coimbatore for the past almost 25 years, heading the pediatric ophthalmology clinic and the cataract eyewear services clinic. So after the exams, once you finish your post-graduation, the thing which goes in our mind is, what is that I'm going to do next? So just to briefly give you an idea about the statistics of how many ophthalmologists train every year in the country. This is a rough estimation about 2 years ago. Now the population of India is about 1.38 billion. And then according to UGC, almost 1.3 lakhs of students enroll for medicine annually, out of which 1,026 students choose ophthalmology annually. And with this population, sometimes once they finish, you have this feeling of your saturation, but it is not really true. There is still a lot of scope for survival and to excel. And what is ophthalmology? It's a very unique subspecialty, because we all know that, eyes are the windows of the soul, and giving someone sight is next to life. So I think we should also be really, having this feeling in our hearts that we are a very privileged or blessed group of people where we are able to, give vision to people. As we all know that it is, blindness is a severe form of impairment. People say it's losing sight is next to death. So restoring sight is a very unique thing, and ophthalmology is also a specialty which is a good balance between surgical and medical practice. And when you're doing your in your school, they normally do not teach you the practice of medicine. They do not really prepare you once you come out after medical school or residency. You're not prepared. At least in the residency, you're kind of aware. You're getting exposed to the business of medicine. I'm sorry, I'm using the term business, but that is what healthcare business model. That is what is talked about now. So we're not exposed to that. And again, if you really see in the current scenario, the healthcare is more like a business of symptom relief and not on symptom of prevention. So it is more like a disease management system, and we're not focusing on healthcare system. Ideally, it should be a healthcare system management and not a disease management system, which we are currently on. Not all of us take, efforts to more into, this is what I mean, like, trying to create awareness in the community. We do at some level, but not really focusing on that. But we should be moving on from a disease management to a healthcare system. And once you finish your post-graduation, you should prepare yourself. The preparation means is, first you should know yourself. Dr. Pramita already a little bit touched on this, but it's very important before you move on to doing a specialty or choosing the, what kind of a career you're going to step into. It should be better to know yourself, your attitude, your intelligence, what type of work you're willing to do, and your personality. Because some specialties need a lot of communication. I'm a very subdued person. I'm very quiet. I don't want to communicate to people. Then you're in trouble. So, you have to decide on that and then know your options. What are the courses available? What you want to do? And always keep a backup plan. Don't get disappointed. And then, do a thorough homework and look at options available. And then another important thing, how much time you're able to spend, what specialty, because certain specialties like IOL entry segment, 2 years, you'll be done, you'll be ready to go out to practice. Whereas certain specialties like cornea or retina, the surgical training might need a little more time of investment. So your financial backup should be strong. And then always look for scopes everywhere and your potential, and then apply where is suitable for you. And the other opportunities, like, once you finish your residency, I'm not going to the details because already Dr. Promita talked about it. So you have to decide where you want to go. Once you decide on this, so there are 4 questions which should come in your mind ideally. One would be, what is the right specialty I want to choose? And then why do you want to choose a hospital or a system like Aravind Eye Care system? And then look at options of what Aravind is going to offer you, and then how to apply and move on. And then how to choose a specialty. Again, what are the factors which will help you to influence your choice? What is your plan? Where are you going to set up your practice after you finish your fellowship? So is it rural or urban? So you need to do a market survey and see what is needed in that particular area. So should I do a retina fellowship, or should I do an IOL entry segment? Or there is no glaucoma person here, there is no pediatric ophthalmologist here. My wife is a pediatrician, so if I do a pediatric ophthalmology, it's a good combination. My wife is a diabetologist, if I do retina, it's a good combination. So you need to really work on that and see what is best for you. And then whether you're going to go to a private practice or institute-based practice. Again, you should keep that in mind. And then cataract versus specialty, then monetary benefits. So if you really are keen on improving your monetary benefits, then you should concentrate more like an entry segment fellowship, because other subspecialties like retina need a lot of investment if you plan for a private practice with the equipment and the other things. And the spouse factor, again, like I already talked about it, is very important. And then this is again depending on choosing the location. There are certain locations like, certain big metros where there's a choice for your spouses, whether she's an ophthalmologist or other specialty medicine, or even, professionals who are not even doctors. So why choose Aravind at all? As we all know that, everybody wants to learn from the best. So Aravind is a balance. It's got both, the charitable eye care and the corporate. I wouldn't say really corporate, but then we have the paying setup as well. So it's a sustainable eye care model, which is what it's spoken for. We do 60% free and 40% paying. And it is the world's largest eye care provider. It is a postgraduate training center, and the specialties, we do high volume and high quality care to the patients. And another advantage is all specialties under one roof. So most of the tertiary care centers we have all the specialties. And then it has a research eye institute. So candidates who are interested in research can also have a 1-year fellowship program in research. And we have structured and hands-on training programs, and diversity options are available. This is just to share with you locations. So Aravind Eye Care System started in the year 1976 in Madurai, and then it's moved on. We have 7 tertiary eye care hospitals: Madurai, Pondicherry, Chennai, Coimbatore, Tirunelveli, and Salem. So these are the tertiary, and these are the tertiary eye care centers. And then we have the secondary centers or community eye centers, which only do cataract surgeries, or more like a comprehensive ophthalmology, cataract, glaucoma, and medical retina. So these are the locations where Aravind functions from. And what type of courses we offer? We have the long-term fellowship courses, and then the short-term clinical courses. Long-term fellowship, they get a stipend, and the short-term clinical courses usually for 2 months or 6 months, which are paid by the students. This is more like the diabetic retinopathy course and the short-term observation programs. And these are all the long-term fellowships which are offered across Aravind Eye Care System. We have retina and vitreous, and I've mentioned the numbers here. I'm also going to show a QR code which you can scan, and later on you can go and see the different options available. And this is the duration. Some courses are 2 years and some courses are 1 year. So this is and another specialty is the pediatric ophthalmology and strabismus course together was first started in Aravind Madurai. And we have different options. I'm not going to the details of it. And this is again the short-term fellowships which are offered: small incision cataract surgery, phacoemulsification, clinical observation in glaucoma. So these are all the courses different. How to apply? Normally, this is the website. You could go and click and apply online. And once your application is chosen, it's a center. You have to decide on which center you want. Like you want to go to Madurai or you want to go to Coimbatore, you can choose the place of applying. So once it's a central office will, kind of go through, and then they will allocate the area, and then you will be called for observership. Usually it is for about 2 or 3 days. You have a written entry level exam. After that, you have a one-to-one interview, and then you will be decided whether you will be selected or not. And then how to apply? Again, for the short-term courses, again, you can go to the website and choose to apply in the website. Now this is the course catalog. So if you can scan this QR code, you can go, or in the website also this course catalog is available. This will be helpful for you to go through and decide what kind of fellowship you would want to do. Another very important thing is, once you decide and once you choose your career, you always have to look upon people and the healthcare. Why are they successful? People who are successful are, people who are very real and what they are doing and who are very passionate about what they're doing. And then choose your role model. The role model is who you will emulate, and then who you will not follow, what you want to do and what you do not want to do. That is also very important in your career. And most importantly, to conclude, you should always have this feeling that you can do it. Follow your heart, do what you like. There will be setbacks, but then what is very important, people who have been successful, is perseverance is the key to success. So I wish you all the best. A lot more to talk about, Aravind, but then this short time, I did not want to exceed time. So you can always scan the QR code and go to the website, and then and always get in touch with one of us if you need any more details. Thank you. Thank you for the opportunity.
Thank you, ma'am, for the wonderful lecture. In fact, if I may share one of my experience when I joined LB Prasad as a faculty for a transient 6-month period. That time I was made the SICS trainee, and at RPC we don't do SICS. So I was very much confused, and I have a fellow from Arvind. His name was Chandrasekhar, and he was so competent in SICS, and I was really amazed at the training that you give to your resident. Thank you, ma'am. So I would like to invite Dr. Chaitra Jadab. She is from Narayan Netrala, and nowadays it's Narayan Netrala is the second hot destination of our resident once they complete their PG. So ma'am, kindly start your presentation.
Yeah. Hi everybody. This is Chaitra here, and I must say that this is something very interesting for us to talk about when all the institutes are coming together and showcasing what options are available for the residents who are either passing out from their post-graduation, who are looking for fellowship opportunities. So Narayan Netrala, I would say, is a world of opportunities for everybody here, because you have different range of options from your post-graduation, your fellowship, research, PhD. So we are a very young institute, but still we've been able to put together a couple of niche areas, and a lot of it is in basic science research, and also we're doing a little bit of work in genetics. So that's definitely a go-to place now for that. I'll briefly elaborate on some of the so first, coming to the centers that we have, as of now, we're spread across Bangalore. There are 4 centers, and all of the centers are involved in training, whether it is postgraduate training or fellowship programs. And as I mentioned, we have even some clinical research attachments that one may want to take as a short-term option. PhD programs in a couple of universities, and then we have our basic science research happening at our Grow Lab. So for the postgraduate training, that is the DNB, we have both the primary and the secondary, and so accordingly 3 or 2 years of training. The intake we have is about 4 DNB primary seats and 4 secondary, and this has been approved as of now by NDE. And all these postgraduates are posted across our 4 centers, and how that really helps is one of our centers, which is based in the health city, does get to see a lot more range of systemic issues, which we may not see in an exclusive ophthalmic setup. So that's the reason why we rotate all of them. As Dr. Andrew was saying, I think it's very important when they have exposure to other systems as well. we become too niche, specialties by doing just ophthalmology. And then eventually, once you do your fellowship, you don't think of anything else. So one of the centers does help in that holistic approach to managing a patient. So we do have regular training programs, didactic lectures, case presentations. Of course, bedside is difficult because most of it is outpatient. But and now with COVID, most of our lectures are on the Zoom platform, which is still working fairly okay. We're also having some training for suturing, for example, on Zoom, so that all 4 centers are availing the training experience. And then both clinical and surgical procedures training under the consultants is ongoing. We have wet lab training on simulators as well to refine surgical skill. Postgraduates are also very much encouraged from the time they join to conduct and to present their research at various state, national and international forums. And they're actively involved in iBank activities. We have 2 iBanks. So from the first year itself, residents are, trained to harvest corneas for transplant procedures. Now, going on to the fellowship programs, based on the specialty one chooses, the duration changes. More or less, it's for about 2 years. Reason being that a lot of time is also spent in research activity. For example, if you're a cornea refractive, a lot of research work is happening at our center on keratoconus. They do collect your samples from a lot of patients. They take the samples to the lab themselves, and then they study a lot of these biomarkers. As far as retina goes, because I'm a retina consultant, I can give you a few more details about retina. So it's a 2-year program, and we have training both in medical and surgical retina, uvea, and also specifically for ROP as well. And most of them are well versed in lasers post their fellowship, even for patients with ROP. We have plasty, oncology, and orbit as well, and glaucoma and pediatric and strabismus. So based on whichever specialty you choose, the program would help you further your career. And as regards on how to apply, fellowship opportunities is there for those who have completed DO, MS, or DNB. And how does one apply is they submit their CV. I will give you the email ID. And another important thing here is that we are affiliated to the Rajiv Gandhi University of Health Sciences as well, which is a fellowship awarded by the university and recognized by the university. There's an entrance and an exit exam for this, and you'll get a university certified fellowship. Of course, the training does not differ much from an NN fellowship. So some of you may be even eligible for a university degree or a fellowship. And the duration, as I mentioned, depends on the specialty. And this is the email ID you can send in your queries to. A lot of the details are also there on the website. And international applicants are also taken in. But of course, now because of COVID, we've not been taking too many international fellows. There are both short-term observational or, long-term. But then they have to, go through the proper documentation and qualification for a long-term fellowship. Now, other than that, short-term clinical observations, PhD program, and the basic research. As far as the PhD program go, it is for those who are now part of NN. A lot of our fellows have joined in for a dual program, both for clinical and PhD. And we're attached to VIT, and we're also attached to Maastricht University. So this PhD program, it depends on which area you want to do research in, and it is a good thing that people should explore once they opt to do a PhD program. It's quite possible. This is the Grow Lab where we're doing a lot of research on genetic vectors as well. So you can are most welcome to come and visit anytime that you would like to see our lab. And these are some courses that we hold at NN. This is basically a hands-on for diagnostic and therapeutic equipment both. Not everybody who passes out of a postgraduate institute may have been exposed to some of the technology that's available. So that is why we have these short courses like for a day or two where we allow people to come and get some hands-on experience with various investigative modalities. So like I said, we have a simulator, we have wet lab, so to give them some confidence before they actually start operating. Our OTs are all state of art, and we also have 3D visualization systems, which is an excellent teaching tool for both postgraduates and for our fellows. So we've also been collaborating with other institutes such as ISC, wherein we've done a lot of animal experiments as well. So this was during COVID. We wanted to see whether there is any, aerosol risk for various surgeries. So we went into the labs and we used high-speed photography. And of course, our fellows do exceptionally well on a domestic and international platform. These are all the awards that they've been giving. And to end, a little bit about the community work that they are, encouraged to start off right from the very beginning. This is our KidDrop program. One of our fellows is screening a baby. So they go out into the community so that they know how difficult it is to handle, primary care at a community level and not only at, clinics where everything is available. We also give them a lot of training with visual rehabilitation in the CVI clinic as well. And of course, non-COVID time screening camps and outreach camps were part of their training program as well. So this is a thinking room that we have. It's very nice where everybody comes in together and puts their gray cells to think about which paper to submit, which paper to write up, which conference one would be good to showcase your work on. And as they all leave, they do write on this wall of fame what their thoughts were about their fellowship program and their training program at NN. This serves as an inspiration for the batches to come. Thank you so much. And we're always open to anybody who wants to ask us any sort of questions or has any other doubts that they would like to clear. Thank you.
Thank you, ma'am, for the excellent lecture. I really appreciate Narayan Nethralaya, especially for pushing the resident to present their free papers all over the country. Whenever we organize any conference here in Delhi, in the free paper section, at least we get 50% of residents are from Narayan Nethralaya. That is the best part of Narayan Nethralaya, I guess. And we do have some residents in the panels. If any of the resident or senior resident want to ask any questions, is the right time. Dr. Aishwarya, Dr. Abhijit, are you there?
Yes, sir.
So if you want to ask anything about Narayan Nethralaya, then you can ask Dr. Chaitra C here. Or in fact, about the previous, you can ask anything about previous speakers also. Okay, if you don't have any doubt or if you're afraid of asking anything, then nothing specific. Okay, so we have Dr. Bhagwat also with us. He is an assistant professor in AIIMS Bhubaneswar. He may share his experience maybe later on about what about the second AIIMS or the multiple AIIMS that the government is coming up with. But next speaker with us is Dr. Anuswa Kapoor.
Yes, Dr. Praful. Dr. Praful.
Yes.
Yeah, actually, I want to share now. I have to leave due to some problem. So I can give my comment now.
Yeah, Bhagwat, you can.
Yeah, thank you very much. So I once asked Dr. Chaitra ma'am. So what is the post-graduation course you are conducting is the DNB? Am I right? It is 2 years or 3 years, ma'am? It is on mute, yeah.
It depends on whether it is primary DNB or secondary, right? So
Okay,
if it is primary, it will be for 3 years, and for secondary, it will be 2 years.
Okay, ma'am. Thank you. And Dr. Praful, I want to share thing. Dr. Susmita Kaushik, ma'am, what told about the premium things about the PGI or what you are sharing with RP Center. But all the government institutes has not that privilege, as you know. You have worked here also. So there are some problems in peripheral AIIMS like getting all the equipments, etc. You have to run after all to get all the equipments. Although it's better than
believe you me, Bhagwat, we have to run more than anybody else.
Yes,
so what you're seeing is not, and that was one of the caveats that it's very, very, very tough. But I just like to, Praful, do I have just half a minute to share something?
Yes, definitely.
Yeah, so I just want to share a small experience from the other side of the table, because this is what we all thought. The sarkar deti nahi, peripheral institutions don't have anything, PGI AIIMS, etc. But, glaucoma was put on the National Program of Blindness in only 2017 after untiring efforts by Dr. Ramanjit and Dr. GC and everybody. But anyway, So we had a task force, and RPC and PGI were chosen to train district ophthalmologists from 4 states, Northern for PGI and Uttarakhand and UP or whatever for RP Center. And we all had feedback forms, and everybody said that, oh, it's all right, but I don't have an application, I don't have a slit lamp, I don't have a gonioscope, I don't have a visual field. Okay, fine. So I duly, when we had the task force meeting in the Mantralaya in Nirman Bhavan, we come and we give this, ki bhai, you're telling us to train them, but those poor fellows in the district hospitals don't even have this. What? So Dr. Pramila Gupta handed me a file, and she showed me requisitions from district hospitals for the last 2 years, and it is 0. So Bhagwat, this was the other side. The government has enough money, but you have to push it, and you have to push it harder than Narayana Netralaya does. I can tell you that. If Dr. Chaitra shows a PhD and she shows results, she will get a 1 crore machine tomorrow. But I might show it for 10 years, but to get 1 more slit lamp, I will have to prove why I don't need a slit lamp from A and why I need a Zeiss. It's tough.
Yes,
but
ma'am.
the other side is you will get it. It's just that it'll be longer, and your hair will be gray by the time you get it, but you'll get it.
Yes, ma'am.
We can discuss this with
Yeah. I just wanted to
I
put that
agree
in.
with you, ma'am. I
I
agree
think
with
Dr.
you.
Paramita can include this clip. This is one of the disadvantages of government setup.
Yes.
Bhagwat, what about the opportunity to the resident in all these new aims that has
Actually,
that
if
was
you
my
see
question.
our Bhubaneswar aims, as I am an anti-segment surgeon, especially I am a cataract, refractive surgery and glaucoma trained in RP Center Unit 4 under Dr. Khokar and Dr. Ramanjit Shweta Madam. So I do here, I am not doing any refractive surgery like LASIK or femtolasic here, but I do my routine cataract and all the glaucoma things here. So for anti-segment, AIIMS Bhubaneswar is ready with all the surgery, all the things we are doing. And up to posterior segment also, we have some laser, FA, angiography, ultrasound, all the OCT, etc. But posterior segment, vitreoretinal surgeon, one faculty has come now from SGPJ, recently joined, and a few will join later now with this recruitment also.
And at present, you people are offering only senior residency. No
Senior
fellowship.
no, I am saying our PG are getting their cataract surgery and all the small surgery. Senior
After
residency,
postgraduate, yes.
Senior residency, we are not having any specialization like RP Center or the PGI Chandigarh. As we are just opened up now with some few years.
It's like a comprehensive ophthalmology.
Yeah, comprehensive ophthalmology. They are doing what they can do. They are free to do here. But unfortunately, the senior residents who are coming from not from the reputed institute, like not from the heavy centers, they cannot do cataract surgery also. So we have to assist like a JR to them also. That is difficult with us.
But as Dr. Bhagwat, as you have heard, Dr. Andrew Bragenda, he said, so you may be doing a good job compared to Premier Institute, right? But training.
That's okay.
Yeah, so that's the best part. Okay, so now we will move on to our next speaker, Dr. Anusha Kapoor.
Thank you.
He is from LB Prasad Eye Institute, and she will be speaking about the opportunity there. Anusha, can you start your presentation?
Hello, everyone. Dr. Praful, is my screen visible and am I audible?
Yes. This LBPI logo is clearly visible. Don't worry about that.
Okay. So, good evening, everyone. So I am Anusha. I have been a resident at RP Center. Now I am a consultant at the Operation Eyesight Universal Institute for Eye Cancer, LB Prasad Eye Institute. I will be presenting on behalf of our director, Dr. Avinash Patange, Standard Chartered Academy for Eye Care Education. So keeping in mind the vision of the Institute to promote excellent and equitable eye healthcare education so that all may see, the flagship ophthalmology training program flourishes at our Center of Excellence at Hyderabad and at the other 3 tertiary care centers at Bhubaneswar, Visakhapatnam, and Vijayawada. So we offer fellowship in all the 7 subspecialties of ophthalmology and also residency, both primary and secondary DNB. So the lockdown was tough for all, and education provided the only hope to transcend boundaries and ensure growth and development. So having understood that what are the options available for learning in most of the institute, now I will like to stress on how we turn this adversity of the COVID pandemic into an opportunity to ensure excellence in learning for all our ophthalmology trainees. So apart from the ongoing educational activities, I would like to give you a glimpse into the 10 new initiatives we started in the last few months of the lockdown. So starting with the fellowship model, we have completely revamped the fellowship program. It is now a 3-year program, like multiple previous speakers just spoke about the need for an specialized ophthalmology having a good basic skills in all the other specialties. We have started this. Earlier it was 2 years, now it is 3 years. The first year is a blended program including all the specialties. The second year is secondary center training, and the third year is in the respective specialty. So this aims to train budding ophthalmologists to become a self-sufficient and excellent super specialty practitioner, keeping in mind the 3H, which is commonly propagated by our founder chairman: the sound, skillful surgical hand, a thinking head, and a compassionate heart ready to serve the underprivileged. Next is the fellowship selection process. This year, we completely changed from the earlier traditional one-day panel interview process to the new multi-mini interview selection process, which was stretched over a period of 1 month. So the first step was a 2-day webinar. Here I will like you all to understand that all the fellows come from different organizations are at very different levels of residency training. So to bring equity to the system, we organized this first step of 2-day webinar, which was followed by the second step of MCQ exam. This gave us an opportunity to assess the retention skills of the fellows as well. The third step was an executive panel interview where non-ophthalmologists interviewed our fellows. And the final step was the consultant ophthalmologist interview. So this multi-mini interview model ensured a 360-degree evaluation, ensuring equity, thus helping us choose potentially good candidates for our fellowship process. Next, moving on to the fellowship evaluation process. So we have a very structured, clear, objective evaluation process in place for 6 monthly assessment, where not only education, but research, attitude of the trainee is given importance. So this fellowship evaluation is based on the different components of learning which we use in our institute, like the Just a Minute Clinical Pulse, the attention to retention videos. I will be coming to them in the later part of my presentation. Problem-based learning, MCQ generation, types of thinking, photo essay. We also devised a very objective rubric-based fellow evaluation system. So during this lockdown, we have also tried to shift towards a flipped classroom model of training. So this flipped classroom model of training has 2 parts to it. So the first part is this out of the class teaching, where the student reads at his own leisure time, he understands the theory part. What happens in the classroom is active learning, applying the key concepts. So basically in the class, the aim is to reconcile the theoretical knowledge with the practical application. Next, at our institute, we believe that learning shouldn't be restricted to the next 3 years, may it be the fellowship or the residency. The motto of the institute is to provide lifelong learning. So keeping that in mind, we started the series of basic skills workshop. We started with the observation and learning skills. So here we wanted to ensure the behavioral shift from seeing what the eye knows to what the eye does not know. So we trained them in active learning from just seeing. The next was the presentation skills workshop. And based on this workshop came up this videos, which we call the attention to retention videos. So basically the new learners or the new trainees these days have a very short attention span. So we thought of developing educational resources which are less than 7 minutes in duration and based on a particular topic with 3 to 4 crisp take-home message at the end. So thus came up this attention to retention videos. We also organized competition within the fellows and the residents. And we also prepared a video repository with over 500 videos of this A2R videos made by faculty and fellows covering all the subspecialties. Next came the leadership workshop. Stressing on the different leadership qualities, our fellows also prepared videos from their day-to-day life within the institute, picking up instances which portray the different qualities of a leader. Next came the curiosity workshop. Here, in accordance with this philosophy of Albert Einstein, I have no special talents, I'm only passionately curious. So we trained our fellows to ask questions about everything they see around and not to take anything on face value. Next was the critical thinking workshop, where like this particular document we created where the different types of thinking skills were imparted to the fellows, and they created these examples based on the different learning in the clinics, based on different cases they see in the clinic, and they also illustrated the different thought processes they had. We also created a roadmap for critical thinking so that whenever there is a case in the clinic, they run through this roadmap based on evidence and come to a conclusion. So togetherness is one of the key values of the institute. Keeping this in mind, we also organized a team building workshop, which helped our trainees in building their team spirit. Now, the need of the hour was that we were not having the bedside clinics like the pre-COVID era. So we started the AHA Creative Learning Series, where we ensured active learning. It was started in Retina for a duration of 4 months, and residents across the country participated from 35 medical colleges. There were 20 mentors hand-holding them throughout. We also made our first footsteps into the digital media platform. Our LVPI digital education channel has at present 4.83 thousand subscribers, and it is increasing every day. There were also a storm of webinars, 95 webinars, over 9,000 participants. To ensure that all the eye healthcare professionals are brought under one umbrella so that there is equity in eye care education, we planned this iHEP program, and today is the last day for the program, including not only ophthalmology postgraduate students, but also optometrists, rehabilitation specialists, vision technicians, nurses, eye bank technicians, community eye health care personnel, to achieve the vision of so that all may see. Finally, all these wouldn't have been possible without our group of ophthalmic educators. So a group of ophthalmic educators worked over 600 hours cumulative over each workshop to ensure that learning continues. Thank you everyone for a patient listening. I will be happy to answer any question.
Thank you, Anuswa, for highlighting all your innovative ways of teaching residents and fellows. And any question, any suggestion from the panelists?
What is the bond in LVPI?
Okay, now
There's no bond. There's no bond in LVPI starting from this year.
residents are very smart than us. He directly asks you about the bond without
no
asking anything else.
This year onwards. Any other question?
Okay, we still have one speaker missing, Dr. Meenakshi Swaminathan. I don't know if anybody from her, anybody is representing her on this panelist team or. Okay, I don't think anyone is there. So I think with this, we have come to conclusion of this session. This was an innovative session that I planned with Dr. Namrata so that this will help the residents watching this session or maybe the video that we'll put later on. And I thank you all the panelists for participating actively in this session, and we are planning to make it further bigger on AIS platform. I hope and I wish, I request all of you to again join me on that particular platform. And thank you again. If we don't have any comment or any question, then I think we can wind up the session, because I think Dr. Namrata, she has left because there is inauguration ceremony. So I think let's conclude this session. Thank you, everyone.
Praful.
Yes, ma'am.
No,
Okay,
Praful, Dr. Meenakshi is just joining in. Actually, there was some confusion. She thought that it is at 4:30 and it is not at 4:30. It is 3 to 4:30. So.
Okay, we can have, but unless it affects your inauguration ceremony, I think it's
One just seeing what is the next. No, the Yozis already, already the young ophthalmologists are already there. I think then we will have her talk at some other time, or we can have it now in case she has joined in. I will just.
I haven't joined yet.
Huh?
That will be a good lecture for Yosi people also.
Yeah, Yosi. Meanwhile, you can just ask Yosi, about how have they chosen their careers. I will just, I'll just coordinate with her.
Yeah, Digvijay, I think Digvijay eats.
Dr. Meenakshi has joined.
Yeah, Dr. Praful. I think Dr. Meenakshi is also.
From your session?
No, you want to complete your Dr. Meenakshi's talk, then you just give it. That's all right. We'll wait.
Okay. So in the meantime, I would request you.
I think Dr. Meenakshi is already joined in Praful, so you can invite her, please.
Yeah, I would like to request Dr. Meenakshi to start his lecture. And I think we have covered Arvind Narayan LV Prasad. The last, the major center that is left is Shankara. So ma'am will be highlighting what is there in Shankar Nethralaya to offer all the MD, MS, DNB students.
Right. I'm speaking from my phone. Good evening to everybody. And there was some mix-up about the time. So I'm going to try and see whether I can share the document. If not, I'll just speak, extempore. So is it okay if I just speak a few minutes extempore?
Yes, ma'am, that's fine.
Is that okay? Yeah, okay, all right. So very quickly, at Shankar Nethralaya, basically when you look for fellowship opportunities at Shankar Nethralaya, lot of questions are asked. So what is special about us? What is special about us is that we are one of the largest tertiary care eye hospitals in the country. And we have patients that come from whole of South Asia. We have so a really good mix of diagnosis that you get to see. You also have a very structured surgical training program. Everybody's worried about cutting and numbers. Yes, our numbers are lesser than many other government hospitals or Apex institutes, but our training programs are all our surgical programs are very structured. And so step by step, you're introduced to the surgery. Constantly logbooks are looked at, gaps are identified and they are filled. And we also have excellent student to faculty ratio, which is usually 1:1, or at the most 1:2 with a consultant. We have opportunities for basic science research, research with optometrists, research with other departments, collaborative research, people geology or plastic surgery, or ENT as and when required by the. good city to live in, a safe place for women to work. It's a lot like a family. We like to call ourselves a family. There is an excellent supportive alumni network that handholds you and fellowship. I know the session fellowships for everything from G to vitreoretinal surgery, along with VR surgery and research. Just the entire gamut of fellowships, all subspecialties are there in Shankar Vitralaya. So I would like to think that we are a very holistic approach, sort of a family feel, very protective of our fellows.
My own clinic in
and a very happy place to do your fellowship. Thank Amrita for this lovely opportunity.
Thank you, ma'am. Even if it was small, but you really highlighted the main issues that is there in ophthalmology. And yes, the important point for the resident is the numbers of surgery. That doesn't matter. What matters is the right mentorship and the right training. So with this, I think we have come to conclusion of this session. Now I would request Dr. Digvijay to take over from here. Thank you everyone for participating in this session. Thank you.
Thank you, Praful. Indeed, a good session. So I welcome everybody now to the EOC session. So for all the young ophthalmologists, and thanks to Dr. Namrata and DOS for giving us the opportunity, to be part of the conference and for all of us to be here. So I have with me an esteemed panel that is there. Dr. Karan Bhatia, he will be joining shortly in a short while. We have Dr. Kunjan, we have Dr. Amar, we have Dr. Mohammad Asif. So all of us are here. And is Amar there? Amar, if you could
yes,
take up and moderate from here on.
Yes, sir. So good evening, everyone. We have our first speaker, Dr. Prachi Grover. She is a senior consultant at Vigitech, and she has special interest in glaucoma, and she is going to present the topic on post-operative glaucoma, handling the pressures. Dr. Prachi, please.
Good evening, everyone. I'm here to talk to you about the post-operative glaucomas and how to handle the intraocular pressure fluctuations. So a patient came to us for a cataract surgery. Thorough examination was done with a proper counseling and a consent. So he underwent a phacoemulsification with foldable IOL implantation. After cataract surgery, he could see clearly. The patient was happy. But what happened next was the increased intraocular pressure. So doctor was anxious. So what could be the reason? It could be in retained viscoelastic or IOL in the sulcus or anterior subluxation of the IOL or the pupillary capture or cortical matter in the anterior chamber or a vitreous chamber or a preoperative glaucoma, air bubble in the AC or hyphema or a capsular distension syndrome or a malignant glaucoma. So as we all know that the cataract surgery can help in lowering IOP, but there can be fluctuation in the IOP after surgery. So these should be managed appropriately to provide best visual outcome to the patient. When we operate in a glaucomatous eye, or we had a complication in a phaco, or we operate a child with a cataract surgery, we expect post-phaco IOP spikes. But however, IOP spike in an uneventful surgery, it is a real surprise. Incidence being 18% to 45 with experience IOP of more than 28 and up to 9.8% records IOP of more than 30 for first 24 hours. Spikes might reach to 68 mm of edgy, and the peak occurs in 8 to 12 hours after surgery, but most of these pressures returns to 24 hours. Mostly the pressure spikes are transient and benign. Individual without glaucoma, they don't show any visual field defects, but in glaucomatous patients are more likely to experience IOP spike after cataract surgery. with the visual field deterioration. Retained OVD being the most common cause for increased pressures in the immediate postoperative period. Retained OVD in the lens capsule or the anterior chamber, it causes temporary obstruction of the trabecular meshwork. Cohesives are more likely to elevate the pressure than depressive OVDs. Like you can see in the video, this is to show that we must wash the viscoelastics from the anterior chamber and all the quadrants of the angle, and even behind the IOL. So another cause could be a posterior capsular rent, and it is the most frequent complication after PCR is IOP rise. And despite prophylactic acetazolamide, pressure could rise up to 30 mm of Hg. IOL placed in the sulcus can be managed by redialing of the IOL, or malpositioning can be managed by repositioning of the IOL. Retained cortical matter can cause IOP elevation. Patient may present with a red or painful eye, can be managed with topical corticosteroids or anti-glaucoma medication, or even with a surgical removal of the residual lens matter. Air bubble in the AC can be managed by positioning of the patient or topical mydriatrics or oral IOP lowering drugs, and may require AC decompensation in some cases. Large hyphemas can cause higher IOP. If the IOP rise is less than 40 mm of Hg, we can manage it conservatively. But if it is more than 40 with the corneal staining, we need to intervene surgically. IOP spike, if the patient has a pre-operative glaucoma, there are more chances of IOP spikes. Chances are more in primary open-angle glaucoma, pseudo-exfoliation, or patients with ischemic optic neuropathy, anemia, or systemic hypertension. Surgeons' experience quite matter in this case because due to the more handling of the tissue by the inexperienced surgeon, that causes release of iris pigments into the anterior chamber that could damage the trabecular meshwork directly. So high myopes are also have a tendency to for the IOP increase IOP after the uneventful surgery. We tend to give corticosteroids after surgery. So, but IOP rise is seen mostly after the 3 to 6 weeks after steroids usage. And the 5% populations are steroid responders. And the dextromethasone shows more of higher cases of IOP rise after, as compared to prednisolone. In cases of steroid responders, the best treatment is to taper or stop the topical steroids, and we can use NSAIDs to control any residual inflammation. And with the addition of topical IOP lowering drugs, we can manage them. We need to manage. We need to balance the inflammation versus IOP. We have to wash the fluid thoroughly from the anterior chamber. Otherwise, that fluid may accumulate between the IOL and the posterior capsule, and that can cause the expansion of the posterior capsule, which can displace the IOL anteriorly and can manifest as capsular distension syndrome. Malignant glaucoma, it is a dreaded complication, and we need to intervene surgically. So the proposed guideline is to identify the patient at risk beforehand, and we can start prophylactic treatment before and after surgery to blunt the spikes. Ensure complete removal of OVD, and intracameral myotics can be used in some cases. Aggressive therapy for PCR should be given. Consider combined surgery for glaucoma cases with advanced damage. So to conclude, IOP spike after cataract surgery in a non-glaucomatous patient can be managed easily. So don't panic. Consider steroid responders. IOP spike in glaucoma patient may cause visual field deterioration. Therefore, can consider combined surgery. Thank you.
Thank you, Dr. Prachi, on covering an important topic. Anybody has any questions? Okay, then we'll move on to second topic. Our second speaker is Dr. Samreen. She is from Guru Nanak Eye Center and she has special interest in anti-segment oculoplasty and ocular oncology. So today she is going to talk about approach towards orbital foreign bodies. So Dr. Samreen, please.
Hello, good evening, everyone. I'm Dr. Samreen, and I'll just share my screen right now. So I'll be discussing the approach towards management of an intraorbital foreign body. Now, orbital trauma is something that we frequently encounter in our clinical practice, and it has been seen that approximately 16% of the cases of orbital trauma are associated with a foreign body. Cases of foreign body inside the orbit might have very unusual presentations and may occasionally accompany trivial trauma, such as in children. So the diagnosis and management of an intraorbital foreign body is often a conundrum for the treating ophthalmologist. Now, I'll just be discussing some cases that I think are relevant, especially for difficult cases of orbital trauma. Like, this is the first case that I'm discussing, is that of a 4-year-old male child who was brought by his parents with right periocular edema, orbital inflammation, impaired motility, RAPD, and there was optic dyspala, suggestive optic atrophy. Clinically, the child had a presentation of orbital cellulitis. There was purulent discharge, pus, and which was culture sensitive, was suggestive of Staph aureus. Intravenous antibiotics were given. There was resolution of edema, improvement of motility. However, there was a persistent discharging sinus on the superomedial part of the right orbit. The scans, they showed a relatively radiolucent opacity on the along the medial wall of the right orbit, which can be seen in the axial as well as the coronal scan. Upon further inquiring, the patients gave a history of injury to the right eye while playing about 5 months back. So we took the patient for surgical exploration, and this is what was isolated: about 3 centimeters long plastic rear end of a pen. After this, the patient was again given the antibiotics, and there was resolution of the discharging sinus after retrieval of the foreign body. Of course, the vision was low because of the optic atrophy that was there present with this patient. Now, the second case is that of a 10-year-old male child who had a history of trauma with a ball pen while playing, and was followed by a sudden diminution of vision and drooping of the eyelid. There was no perception of light in the right eye, and an entry wound could be seen below the lower eyelid. There was limitation in ocular motility in all cases, afferent pupil, relative afferent pupillary defect, disc pallor, and hypoesthesia along the cheek. Now, the initial CT scan in this patient was inconclusive. We could not identify any foreign body despite a definite history, but repeat CT and MRI and reevaluation led us to identifying non-metallic linear foreign body extending up to the apex of the orbit. Now, this is the scan. As you can see on the CT, it can be seen as a relatively not very radio opaque object abutting at the orbital apex, and on an MRI, one can further see that it is going all the way up to the apex and likely damaging the neurovascular structure and the optic nerve over there. So a diagnosis of right traumatic orbital apex syndrome was done. Now, this patient was started on steroids because even though we had strongly recommended surgical intervention, the patient refused surgery because of the poor prognosis that we had explained to him. Now, the third case is that of a 36-year-old female who had a history of recurrent swelling of the left lower eyelid. There was purulent discharge near the medial canthus. There was no involvement in the lacrimal apparatus. The syringing was patent, and we could not find anything on imaging. On surgical exploration, what we isolated was a small fragment of wood. And this patient then gave history of some trauma while cutting wood about 8 months prior to presentation. Now, this is the fourth case. This is a case of multiple BB injury, BB pellet gun injury, and the patient was practically asymptomatic, a 30-year-old male, and was referred to us for just for the evaluation of the possible ocular or near the site of BB pellet entrapment inside the body. So we found an entry wound at the glabellar region, and there was a metallic foreign body in the anterior orbit, just adjacent to the medial rectus. Now, this patient was taken for surgical retrieval of the BB pellet, but intraoperatively it could not be retrieved for some reason. And we did a repeat CT, I don't have the scan here, and repeat CT confirmed that there was posterior migration, probably perioperatively, of this foreign body. So further intervention was not done, and the patient essentially remains asymptomatic even at present. So there are some things that I want to highlight pertaining to a presentation of a case of an orbital foreign body. First of all, a number of patients might not give you a definite history of trauma, or there may be a history of relatively trivial trauma, especially in cases of children. Now, the spectrum of clinical presentation might be such that if you are not keeping a high index of suspicion, you might actually miss the possibility of a foreign body. So the patient may present with a clear picture of an orbital cellulitis or orbital abscess, hematoma, a discharging sinus, which might be even taken for a tuberculous sinus or something similar to it, an orbital apex syndrome, supraorbital fissure syndrome, or many times just as a case of an optic atrophy and poor vision. As far as the imaging is concerned, plain X-ray, of course, no, we don't rely on it, but in the initial setting, sometimes it can be done. And metallic foreign bodies can be identified, except aluminium, which is relatively radiolucent. Ultrasonography helps us to identify mostly foreign bodies in the anterior orbit, but detection is frequently difficult. It depends on the sonologist's experience, and also because many foreign bodies are masked by the inflammatory and the fibroadipose tissue that surrounds the foreign body. On computed tomography, this is the preferred investigation for most cases of suspected foreign body, because it enables an accurate localization, especially of high density foreign bodies like metal and glass. Minimum size of 3 mm for case of metal, and 0.3 mm and 0.5 mm for a glass foreign body can be visualized. The challenge is identification of wood, because it's a low density object, and frequently it evades a diagnosis, especially dry wood, which is hypodense on CT and mimics air, while fresh wood, which is isodense, can mimic orbital fat. Now, two of the cases that I presented earlier in my presentation were of plastic foreign body. Plastic has variable radiolucency, and in both our cases, we did encounter some problem in identification of the foreign body. So plastic is one object that can evade detection on scans. MRI should be done only after one has ruled out a metallic foreign body. It enables to get a better soft tissue damage assessment, and sometimes wood can be identified more easily on an MRI, as it is hypointense relative to fat and is more discernible, especially on T1 scans. As far as the management is concerned, anti-tetanus prophylaxis and antibiotics should be given in all patients. Now, the decisions to remove should be weighed against the risk of iatrogenic damage. So mostly organic foreign bodies are associated with infection and inflammation and should be removed in almost all cases. Retention of copper inside the orbit can lead to an intense inflammatory reaction, and every attempt should be made to remove a copper foreign body. Iron should, if retained for some reason, if iron is retained in the foreign body, orbit, we should perform a routine ERG, and in cases of any initial signs of siderosis, one should try and remove the foreign body at the earliest. Now, BB pellet, they are generally well tolerated, and if the site is such that the risk of removal is more than is less than the risk of iatrogenic damage to the patient, so one can actually leave it over there. And also, if there is a metallic foreign body, removal removes the contraindication for a MRI scan. If there's a foreign body at the apex, a transcranial or a transnasal transethmoidal endoscopic approach is to be preferred. We do have image guided systems nowadays, which are especially useful for a small foreign body in the posterior orbit. And a tailored approach should be undertaken for most patients. This is what we recommend in case of a suspected intraorbital foreign body. One should take a thorough history, assess the injury. Initial investigation should be a CT scan, and MRI should be done when CT is inconclusive or the metallic nature of the foreign body has been ruled out, or if there's a clear evidence of damage or retained organic foreign body. Broad spectrum antibiotics, anti-tetanus prophylaxis in all cases. Organic foreign body should be surgically removed, and inorganic should preferably be removed, especially in cases of persistent inflammation, optic nerve compression, anti-allocation, and copper foreign body. The only cases in which one might consider a conservative management are those in which the foreign body is inert in nature, very posterior location, and the risk of iatrogenic damage is more than the risk of retention. Also, in cases of wood, one should do a post-op check MRI, because frequently during the process of removal itself, it might, the fragments might be retained inside the body despite the removal of the larger chunk of wood. And for cases of iron foreign body, it is, as we had discussed earlier, follow-up is necessary till we do a definite surgery. Thank you.
Thank you, Dr. Samreen. That was an important topic because in oculoplastic specialty of Indian setups, so often patients are going to present with simple discharging sinuses. So in those conditions, we need to take detailed history. So often these are going to be challenging cases. So if you are able to take history, if you are able to elicit what is the nature of foreign body, then probably you can customize the imaging modality, like probably you should do CT scan or MRI. So as he has highlighted everything, history is important, but unfortunately in our setup, patients are often going to ignore the history. So that is unfortunate situation. But she has covered everything about like clinical significance of clinical history, imaging, as well as how to manage. So thank you, Dr. Samreen. And we have our next speaker, Dr. Shailaja. You might be aware, some of you might have heard our topics on pediatric cataracts as well as eye genetics. She's very interested in genetics. So she's going to give some pearls in pediatric cataract surgery. So Dr. Shailaja, please.
Thank you, Omar, and thank you, Yossi, for giving me this opportunity. Am I audible clearly? Hello?
Yes, ma'am. Yes, ma'am. You are audible, ma'am.
And I'll just start sharing my screen. Yeah, so I'll just try to cover up some pearls in pediatric cataract management, not just the surgery. Actually, the surgery begins first with the decision to make surgery. The first pearl is that not all pediatric cataracts would require any surgery. So just looking at these images, I want all of you to think and in your mind and say which one of them do require surgery and which may not require surgery. In fact, somebody can speak on and just let me know. You're labeled. Anyone wants to attempt? Which one of them would, in your mind, would you think would require surgery and which one would not?
F1 is first. The image.
Yeah, just tell me which one do not require surgery. I have there's A, B, C, D, E, F labeled.
B, C.
B, C are definitely. D, we need to see whether it's involving visual access or not.
Correct. So I think all of you are right. So all these do require surgery, and probably B and C do not require surgery. But yes, we also have to measure visual acuity. But in children where you cannot measure visual acuity, you have to see the location of the opacity. If they are central, they are more than 3 millimeters, and they are dense enough to cause visual access opacification, then probably they require surgery. You can use a direct ophthalmoscope and look for the glow and determine which do not require surgery. Some of the times you may just need to monitor them, and some cataracts, especially the early galactosemic cataracts, may be reversible. Now this child was at 6 months when I saw there was a cataract, but the visual access is fairly okay. I gave him T-plane to keep him dilated so that he keeps seeing through the clear part of the lens. And you can see with the galactosemic diet, his cataract density is reducing, and he's now 1 year old, and it's even more clearer. So sometimes it may be just required to monitor and not operate on them, because there's so many consequences of operations that also we'll be discussing. The second pearl is that you should look beyond the cataract. So the cataract is within the eye. So just look beyond the cataract. And it's because most of the unilateral cataracts, I would say 1 in 2 chance of a unilateral cataract to have an associated ocular disorder. And this has been seen in various studies as well. So most common children would be a pediatric traumatic cataract, then would be a PHPV cataract. You see those elongated ciliary processes, which is kind of pathognomic for them. Then other very obvious conditions like aniridia or antisegment dysgenesis can also be observed. But the most important would be to see those cases where the cataract is not corresponding to vision loss. And here in this patient, it was a binocular ocular digital sign was there, nystagmus was there, and cataract was not amounting to the amount of vision loss here. And so you should expect a retinal optic nerve pathology. And this child definitely had an LCA, which was not diagnosed, in fact, before, because he was a mentally challenged child as well. Also, along with pediatric cataract, pediatric glaucoma go hand in hand, whether it's after the cataract surgery or in pediatric glaucoma patients also cataract may develop. So always have to monitor the pediatric, the intraocular pressure in them and look for any glaucoma, coexisting glaucoma. The third pearl is, once you have looked beyond the cataract, now try to look beyond the eye. So there's several syndromes. These are just the metabolic diseases which are I've taken from this paper, but I just want to, I will not go into details of them. There's several syndromes and systemic conditions which are associated with pediatric cataract. And we need to have an idea about them and need to look for them in the patient. And why do we need to look for them? Sometimes, why? Because, okay, one more thing I want to say, that do we then investigate for all of them? No, not necessarily. For all those pediatric cataracts, especially the bilateral one, we would recommend that fasting blood sugar, calcium and phosphorus, and this for infantile cataracts, urine for reducing substances, and red blood cell transferase and galactokinase levels, and torch titers in our setup especially. And rest of it could be directed based on the etiology that you're suspecting. As I mentioned, all the syndromes may not be necessary to memorize them, but looking at the type of cataract, one can sometimes predict the associated medical problems and then direct the workup accordingly. Why is it important to know the systemic associations? Because it leads to a complete and holistic care of the patient. Sometimes cataract may be the first symptom, like in cerebrotendinous xanthomatosis, and timely referral may prevent catastrophic events. Careful anesthesia planning may be required for such patients in the cataract surgery because they may have multiple other problems, and visual rehabilitation may be difficult in children with developmental issues as well. So you need to know them. And if you can't memorize, just remember the red flags. If there's an intellectual disability, any congenital abnormality, dysmorphic features, anything odd in a child with a cataract should raise these a complete evaluation. The fourth point is look beyond the patient now. Now, you've seen the patient, now try to look beyond the patient, because sometimes just examining the parents and taking a family history of cataracts can clinch a diagnosis, like in patients with female carriers or mothers of Nance-Horan syndrome. So there'll be a male child with cataract, and mother may have this posterior vile suture cataract, which is very specific of Nance-Horan syndrome, and anterior vile suture cataracts of carriers of cerebrotendinous xanthomatosis. Now coming to the surgery, main surgery part. Now before you are planning, you have to decide whether you want to implant an IOL or not. So mostly IOL implantation is indicated. So I would just say when not to implant an IOL. So in infants, it is still controversy. So until unless you are able to manage the post-operative complications, especially the glaucoma and the visual axis of opacification, not able to follow them up, defer infant IOL in infant, and they could do very well with aphakia as well, which various studies have shown. In general, if the corneal diameter is less than 10 millimeter or axial length is less than 18 millimeter, we would defer an IOL. Any abnormal anatomy of the anterior segment, any uveitic or rubella cataract or cataract with Loeys syndromes, you should avoid it. Any progressive zonulopathies like the Marfan's, homocysteine, and microspherophobia avoided. And whenever there is inadequate capsular support, especially in traumatic cataracts, do not put an IOL in the children. Of course, SFIL may be tried in some of these cases. The tip number 6 would be know your IOL formula and prediction errors. Now, children are prone to have prediction errors. IOL formula, none of them is fairly accurate. You need to have a handheld keratometer, and the axial length reading under A-scan, under GA should be interpreted carefully. The standard deviation should be less than 0.06. You have to select values where the maximum AC depth is there, so that you know that you are going through the center of the eye. and the spike should be good. In general, SRK-T is preferred less than 2 years of age, SRK-2 more than 2 years of age, and even Holiday 2 has been shown to be a good formula in various studies. Under correction, target a moderate postoperative hyperopia. The average prediction error can be 1 to 2, and it's more in infants. So they also show a faster and a greater myopic shift, so you have to account for them. Now coming to the main surgical tips, first one, incision and capsulorhexis. The incision, I favor a clear corneal superior incision because it spares the conjunctiva for any future glaucoma procedure. Studies have shown that it's astigmatism and the refraction does not change much with the scleral or a corneal incision. So when we are putting a foldable IOL, it doesn't make sense to disturb the sclera. The conjunctiva. And the anterior capsulorhexis, it is slightly different than the posterior capsule than the adults because the capsule is very elastic. Trypan blue staining, it says that people say that makes it like slightly stiffer, so you can use it. And the force is always centripetal. The AC should be well formed, and you could use Hilon for that. I use this microrhexis forceps, which really gives good chamber stability, and we can use it with the left hand also and achieve good results. The anterior capsulorhexis, there are some situations where you avoid hydrodissection. In general, in fact, I would say that in pediatric cataract, you do not require a hydrodissection. Lens is quite soft and comes out easily. But in two conditions, I would say you should largely avoid it. One is where you see this kind of cataract, this posterior lenticonus cataract. In this case, quite obvious of this oval shape, a deep posterior looking cataract. Should avoid it because there is a pre-existing defect. Even the aspiration sometimes has to be done with Simcoe to avoid fluid currents here and disturb the vitreous. And for the same reason, avoiding total cataracts because you don't know whether there is an underlying posterior lenticonus here. You can see in this case here that there was a big defect corresponding to the size of the pediatric for the cataract itself. The tip number 8 would be what should be the adequate size of the PPC and how much AV to do. The adequate size of the PPC would be approximately 4 to 4.5 millimeters. If you are planning a 5 to 5.5 millimeter anterior capsulorhexis, the idea should be that the IOL should be covered around 0.5 millimeters from the anterior capsulorhexis, and the posterior capsulorhexis should be big enough to avoid any visual axis opacification. While doing the PPC, do not inflate the eye a lot, the anterior chamber a lot, because the tag can go behind and then it will be difficult to retrieve, but it should be just enough to maintain the anterior chamber. Sometimes you can have these plaques, both in congenital cataract, long-standing, or in traumatic cataracts. It's always advisable to try to pull it out, and they come out quite easily. And this microaxis forceps is handy in that also. Now, in this case, it was firmly adherent in periphery, but I could clear out the central area so that the posterior capsulorhexis is easily carried out without any difficulties. And anterior vitrectomy, when do you stop it or when do you think that it is completed? It is basically the PC should stop fluttering. You can do it before IOL implantation or after IOL implantation. You could see the PC fluttering when you have doing the posterior capsule, the anterior vitrectomy, and it should stop fluttering. The edges are free and not rolled or peaked, and that would determine the end of the PPC of the AV. Last but not least, one when putting the IOL when the PPC is there is little tricky. So the only tip I want to give here is that direct the IOL. You can enlarge your incision a little bit so that the cartridge goes quite beyond the PC opening, and direct the IOL into the bag and open it up so that the optic also opens beyond the PPC edge. So that way it's safer and the optic doesn't go behind the PPC and makes your life much more easier. Also, the SPIOL should always be in the bag, not in the sulcus. For sulcus implantation, the MPIOL should be used, or whenever you want to do IOL capture also, MPIOL is better. And use a larger size cartridge for IOL's powers which are greater than 28 diopters, because the C cartridge will be difficult to push them through it. And last but not the least, meticulous closure and postoperative care is must. I advise a PI whenever you are planning aphakia or the IOL power is greater than 28, again because the lens is too big in the bag. The complicated cataracts and traumatic cataracts also. And meticulous closure, close all the wounds. Even the side port should be closed in children because they have poor scleral rigidity. Postoperative care with adequate steroids, cycloplegics, and antibiotics is a must. And I should not undermine the regular follow-ups where you have to watch out for myopic shifts, visual axis opacification, and pseudophakic and aphakic glaucoma. Thank you all. I thank all my patients and my mentors for teaching me my pediatric cataract surgery. Thank you.
Thank you, Dr. Shailaja, for giving 10 genuine tips for cataract surgery for all beginners. So if anybody has any doubts, you can ask Dr. Shailaja.
Ma'am, what is your opinion on doing scleral fixated lenses for the pediatric eyes? Like what would be your age group considering their changing scleral rigidity and growing eye?
Yeah, again, these are all, this is again not a well-determined, a little bit controversial topic. Around 6 to 7 years of age is what is preferred at our institute, but people do implant in lesser age as well. And most of these studies do not have a very long follow-up, and there is a concern whether, with the scleral growth. And the argument against is that, most of the scleral growth happens within 2 years of life, so maybe it can be done after that. But most of studies have even shown that, growth happens even up to 17 years of age. So up to 7 years, I would say that maximum growth happens. So after that, it's safer. But yes, it should be avoided in those where there is a known, collagen disorder. There should be avoided even at any age. The rest of the ages, like a traumatic, where the eye growth is quite stable, it can be after 6 to 7 years, it's safe.
Thank you.
Very well presented, Dr. Shailaja. Very nice.
Thank you, Dr. Deepika.
Okay, if there are no more doubts, thank you, Dr. Shailaja. Fourth speaker is myself. Okay, I will share my screen. Is my slide visible?
Yes, sir, you can.
Okay, so myself, Dr. Amar Pujare, I'm assistant professor at RP Center. So my topic is on anti-segment OCT in post-polar cataracts. So we have done some of the, we have discussed some of the ideas in post-polar cataracts. So I want to present those things. So why post-polar cataracts are important? Because these are going to have often a deficient or weaker capsule beneath the discoid opacity. So definitely there are clinical signs to indicate when to suspect the deficient posterior capsule. But nowadays the research is going towards the non-invasive, non-contact cross-sectional imaging tool, that is anti-segment OCT. If you search the literature, you can find these 5 important articles in post-polar cataract, where you can see from Hong Kong, from South India, and like from China also, you'll find some of the articles which have tried to define the deficient posterior capsule behind the discoid opacity. However, all these efforts were made using a spectral domain OCT, which has limited penetration up to the posterior capsule. So we need to think of something else which is going to give the capsular details with more clarity. So in this aspect, if you see all these images on the left side, so the first image on the left side is like from South India, which shows that the first yellow circle indicates that how they are going to define whether the capsule is intact or not. Subsequently, in all these yellow circles, you can see they are going to define the deficient capsule when the discoid opacity is obscuring the capsular details underneath. But that is not true. Even in this Hong Kong report, you can see how they are going to define. If they are able to see the capsule or the opacity, then they are going to define it as intact. If it is not, then probably they are going to tell it as a non-intact. Similarly, the same trend has been followed till now. And this is another report from MAMC, which has been published in Eye Journal as a teardrop sign. Okay, so keeping these things in mind, we were working on posterior segment OCT to increase the depth of penetration of depth of the posterior segment OCT. So by accidentally, I placed a 20 diopter lens, which is a retinal. We do often use this 20 diopter lens for fundus visualization. So after that, suddenly we noted that it was able to visualize the anti-segment OCT. So we tried to explore this one, and I tried to image so many cases of complicated cataract, like post-polar traumatic cases, where like we need to have genuine idea about posterior capsular integrity. So in that case, when I observed 26 cases of post-polar cataract, so I tried to find out some of the common patterns. So we tried to define the 2 important C's. One is capsule, and second one is the contour. On the left side, when like you can see here, in the first scan in the left collage, you can see that is a normal picture. We need to alter the signal intensity. We can increase the signal intensity or we can decrease, because the discoid opacity may not allow you to see the capsule beneath. So in those conditions, you either increase the intensity or decrease the intensity. So in those conditions, if you are able to see the capsule throughout, then probably the capsule is intact. Okay. So on the right side image, you can see the arrow is indicating that the capsule is definitely not intact. It looks like the matter is getting herniated into anterior vitreous. So this is the first thing. If you are able to define the posterior capsule entirely along the posterior capsule, especially beneath the discoid opacity, then the capsule is going to be intact. If it is not, then definitely capsular opening is there. Second thing is contour. As we know, the posterior capsule is going to have convex contour. So the left sided semicircular yellow arc indicates the contour. That should be a normal convex contour. But on the right side, you can see the contour has been lost. So when you are defining the capsular integrity beneath the posterior polar discoid opacity, you need to have visualization of the clear capsule as well as the contour should be following a regular this thing. So in these 4 images, we made a collage. Out of 26 eyes, these 4 patients had a definite dearth or the deficiency in the capsule at the apical part. That is one thing. And definitely the contour is not getting followed. You can see the red dot indicates that at the tip of the posterior capsule or beneath the discoid opacity, the contour is becoming like a nipple-shaped configuration. So this forces us to name this as a conical sign, apart from when we are going to get normal cases. So this we published in JCRS. So, but the thing is that we were not satisfied because the 26 number patient is too small and we wanted to use a more advanced technology. If you see the literature, maximum case included is case is around 70 or 75 eyes, not more than that. So we try to include advanced modality. That is, you can see this image is from CASIA 2, which has a soft source imaging facility, which is from Noga, Japan. We do not have any financial interest. And we have this OCT at our center. So we try to image the posterior capsular integrity using this OCT. If you see, it's going to give a clear, broader image like a UBM, and it can magnify the images up to 200 times. So that means even you can visualize the 4 or 7 micron things on the OCT. So we include 101 eyes. So this is the largest series till now in the literature. So the mean age was 52 years and the posterior capsular integrity was defined as 91, as intact in 91 eyes and abnormal in the remaining eyes. So these morphologies, what we saw, what we said previously conical, that was deciphered here. That was re-emphasized here. You can see on the left side, it's a 200 times magnified image. Again, you can see the dots are somehow they are going to follow a conical contour. That means that capsule is not intact, the matter is herniating. So the contour has been not followed. And if you see that the tip, the definitely capsule is not intact. So we saw this one in two eyes out of 101. So intraoperatively we noted that there was a deficient capsule opening and PCR was noted. Second one was, compared to the first one, here the contour is not following to the first. So that means it looks like as if somebody has taken bite from the posterior part of the lens. So the contour is extending interlenticularly. So it looks like as if the moth had eaten edge of the leaf. So we named it a moth-eaten appearance in 5 eyes. And third one was, you can see beneath the opacity, the capsular integrity or capsular direction is indicated by red and white dots. If you see, the red and white dots are not exactly meeting, as you see on the right-sided diagram, where the bridge was wrongly constructed. So it's like that. Beneath the capsule is not in a continuous mode. So it has some ectasia. So that we term as the ectatic pattern. So in addition to this one, all these patients are having rent, but again, patients were having rent. So we introspected and we noted that these are simple images just to convince you. Even more complicated images are also there. In the left-sided image, you can see between the opacity and the capsule, there are no hypoechoic areas. In contrast to this one, on right-sided image, you can see between the opacity and the capsule, there are definite hypoechoic areas. And to note that these hypoechoic areas shows that there is a lacunar areas, or like the areas which have definite space. But please note that the capsule is not deficient. Capsule is visible, contour is well maintained. So we term this as without hypoechoic areas and with hypoechoic areas. So based on this one, we correlated all the patients' intraoperative results. So total patients were 101 eyes. So we categorize them as specific morphologies in 9.9% and generalized morphologies in 90%. So in specific morphologies, if you see conical pattern, then there is a 100% chance that patient might end up with PCR. Again, if there is a moth-eaten appearance, again, he will end up with a 100% PCR because definitely capsule will be deficient and the contour is not going to be followed. In ectasia, out of 3 patients, we only operated on 2 patients, and that's why we noted 66% of PCR. So in generalized morphologies, we are going to categorize them as with or without hypoechoic areas. If you're not able to see any hypoechoic areas, probably you need more suction force to take out the opacity. So that's why it's going to induce some kind of partial tear on the capsule. So that's why the PCR rate is slightly higher compared to the with hypoxic areas. It's around 15%. When there are definite hypoxic areas, so probably the fluid is going to percolate beneath the opacity and it's going to lift the opacity. So that's why the PCR rate is less in this case. So this is our second study. We have third study in our IGO, which has been accepted, probably which is going to get published in January, February. And the fourth study, which characterizes the morphological aspect of the discoid opacity. So that is under consideration in JCRS. So in conclusion, in post-polar cataract, the deficient or abnormal capsular morphology could be categorized on ASOCT into generalized specific morphologies, so that by imaging in such a manner, we can mitigate the complication rate. Thank you.
Very
Any
nice,
questions?
doctor.
That was an extremely lucidly explained presentation, sir. I have read the paper backwards and forwards multiple times, but the way you've explained everything and correlated it, it was exceptionally clear.
Thank you, doctor. Thank you, doctor. And if you don't have any doubts, we'll move on to next speaker. We have our dynamic next young speaker who is very popular, Dr. Ashwini Kumar Behera. He has special interest in glaucoma, strabismus, neuroophthalmology, and pediatric ophthalmology. So now he's going to talk about something on glaucoma. So his topic is defining different severities of glaucomatous optic neuropathy. Dr. Ashwini, please.
While he's uploading, can I ask a question?
Yeah, please.
Yeah, would this OCT be useful if there is a total cataract and a pre-existing PPC?
It's going to have a limited penetration. We have similarly studied MSC cases and hypermature cases. If it is like a very liquefied, if the lens has liquefied matter, so it's going to penetrate till posterior capsule. In those conditions, if you are not able to see the posterior capsule, we tried taking these images onto images software. So in those conditions, we were able to see the capsule using Huang's or also there are different algorithms on ImageJ. But per se, if the cataract is very dense, like in hypermature cataract, definitely you won't see the capsule.
I was thinking whether we could use it for again the same posterior lenticonus cases in pediatric cataract to see if the full complete
in
total
posterior
cataract.
lenticonus you can use.
Yeah, because
in
the cataract there is not so dense, so maybe. But then handled OCT or handled posterior segment with a 20D lens, what would you recommend for it?
Yes, the 20D lens, some of the people from Gujarat and Hyderabad, they asked me, they had Zeiss posterior segment OCT, but I tried an Nidec retinal OCT. So this is possible only on this one. They tried on different OCTs, but that optics is different in all the instruments.
Okay, so that didn't work. So this is Nidec posterior segment OCT, handheld one year, 20D.
No, it's a fixed, non-portable OCT.
But the handheld, for pediatrics, you would need a handheld one. Have you tried with any handheld device?
No, we don't have handheld OCT at our center.
Okay.
We have intraoperative OCT, but if you see the literature, in future, handheld and the IOCTs are going to be short source. Nowadays, we have spectral domain OCTs.
Yeah.
In those conditions, we can use. Probably in 2022, we can get SSOCT.
Okay. Thank you. Great presentation.
Dr. Ashwini, please.
My slides are visible?
Yeah, please go.
Myself, Dr. Ashwini. I am here to present a talk on defining different severities of glaucomatous optic neuropathy. There is no financial interest, and whatever little I know in ophthalmology, all credit goes to this beautiful center, RPC. So why we need define visual field? Because to need to distinguish between healthy and diseased individual, to adjust the therapy on the basis of disease severity, and to monitor the progress and provide a common language for both clinical and research purposes. As you know, different hard science and soft science of glaucoma. Next, straight coming to the topic. There are different classifications to define the severity. One of these is disc damage likelihood score, which is the narrowest width trim to disc ratio. For example, it consists of 3 discs. If you calculate, there is a bending of vessels, which we can calculate. So it comes under 0.13, which is DDLS stage 5, as it is stage 6, and it is stage 7. So how can you come to that conclusion from this values, predicted values? But it is not very popular. Now coming to the methods based on number and depth of defective points. Oda Paris-Anderson classification, which we almost know, and Mills et al. Staging classification. Now coming to this classification, we all remember this mean deviation part, less than 6 decibel, 6 to 12 and more than 12. But we always forget there are other three parameters, the number of points less than 5% on pattern deviation, number of points less than 1% on PD, and center of field of 5 degrees. Now coming to an example. Now you come to this an example with a mean deviation minus 3.75. The points as described above 25%, so 18 points are depressed. So it will be the early defect. Now this is another field with mean deviation of minus 9.52. So according to they are at a stage 0 where ocular hypertension, and they divided more than 12 severe form of Hodder-Parrish-Anderson classification into advanced, severe glaucoma and end-stage glaucoma. Now coming to similar examples, we can see this ocular hypertension depending on the clinical examination and IOP. This is early glaucoma with mean deviation of minus 4.23. And there is a moderate glaucoma with mean deviation minus 6 to minus 12 and other points. Now coming to this is advanced glaucoma, which is around minus 15.37, but according to Hodder-Parrish-Anderson, it is a severe glaucoma. But in this Mills et al., the severe glaucoma comes when mean deviation more than minus 20. So it is a minus 28 field, it tends to field. And end stage glaucoma, there will be no visual field and in the worst eye. Now coming to another new classification known as GSS2, glaucoma severity scale, which considers all these MD, CPSD, CLV, and PSD, and classifies it visual field differs in all 6 stages and 3 types. I will give an overview. This is a glaucoma staging system 2, where CPSD, mean deviation, CLV, LV, all are there, and it is classified into S1, S2, S3, S4, S5. Now coming to the example, because examples are the best way to learn and classify visual fields. You consider this field. There is mean deviation minus 1.43. If you can see, PSD of 6.08. So if you plot this point, mean deviation minus 1.43 with PSD of 6.08 and CPSD of 5.09. So this point will fall on this zone, which is S2. S2 means moderate defect, such as nasal step or scotoma of limited size or etc. Now coming to this stage, another field is the mean deviation of minus 9.52, PSD of 11.09. So the point will be here. You can see. So this will be an S3. S3 means occurring defect as fascicular absolute scotoma and a localized defect. Now coming to this defect, the point will be here. It is S4, very advanced and absolute defect affecting at least 2 quadrants. As you can see, this is a classification and it is being coordinate with the field. You can see this. This is a last field. This is a field with mean deviation of minus 28 points. So this is a terminal defect with a small island of visual residual sensitivity. What is the advantage? It's a quick, reliable and standardized, faster and easier. What is the disadvantage? It is not specific for glaucoma, does not portray any sort of spatial information. The most important advantage, it is correctly classified all localized defects. Similarly, there is the classification based on the Baby's curve. Baby's curve should be fall within 5% to 9% of the field. It is classified diffuse loss, localized defect, mixed defect. There is RPC study classifying different types of scotomas. These are the frequency distribution points here. But this is one of the classification that I want to stress upon, the Psi visual field grading system. The systemic classification Humphrey visual field on an easy interpretation, which named different of defects. For example, this is the normal defect. This is a central scotoma. You can see the central scotoma here. Defect within central 5 degree. This is a paracentral scotoma. Defects within paracentral region that do not cross midline. You can see this is a paracentral crescent. As you can see in this visual field example, this crosses the midline. So this is a paracentral crescent. And this is a pattern deviation temporal quadrant. If you see any defect within temporal zone, it is a temporal defect. This is peripheral arcuate. If you see, this is a peripheral arcuate, a combination of defects that must cross the midline and does not include the central 2 points. This is an expansive arcuate, combination of defects that must cross the midline, and this is an altitudinal defect. So these are the different type of defects and severity. Procedure used to progression is much more important, less important in glaucoma, which is clinical or trend analysis or event analysis. Trend analysis uses a linear regression. The disadvantages are 2 to 3 baseline and 5 evaluation visual fields are required for adequate sensitivity. The event analysis is uses PAID t-test, Delta program on Octopus, and GCP and StatPack in the HFA. This will be my last slide. This is a progression analysis. We can see there are different fields on patient follow. By seeing this, we can see visual field over 5 years, visual field index over 5 years, where the patient is going to be his visual field after 5 years. The rate of progression also noted here -1.5. So we can see whether it is fast progression, slow progression, or an event-based changes. These are dark triangles, half dark triangles. It shows whether the point is previously present or not. That previous field have the same defect or not. So these are different types of visual field severities and visual progression that we need. Thank you. Thank you for your kind attention. These are in short a difficult topic regarding visual field progression. Thank you. Thank you so much.
Thank you, Dr. Ashwini, for giving a comprehensive view on like how to detect these field defects. So definitely that will help all the youngsters. So anybody has any queries, they can ask Dr. Ashwini. Okay, we have our next speaker, Dr. Asha Samdani. She is our senior most squint and oculoplasty SR. She is a favorite SR of Dr. Pradeep Sharma. So today she is going to tell something about adjustable sutures in strabismus surgery. Dr. Asha, please.
Yeah, thank you so much, sir, for the introduction. Just let me share the screen. I hope it's visible.
Yes, it is visible.
Just a second. So very good evening, everyone. I'm Dr. Asha. I'll be presenting a topic on adjustable sutures in strabismus surgery. So I have chosen this topic because it is something which has always intrigued me in my residency days. So I will share whatever I understood regarding the same. So first of all, going to the principle, it is to secure the extraocular muscles to the sclera with a sliding knot and then adjusting the length between the attachment and the muscle. And the limb, it can be done by either limbal approach or conitial approach. Again, it can be done either as a single stage or bi-stage procedure. Generally, in two stages, we do the surgery in the initial stage as first stage, and the second stage is the post-operative adjustment, which is done preferably within 24 hours after the surgery. But according to different literature and different surgeons, it can be extended from 3 to 7 days. So there are two main basic techniques of adjustable sutures. Rest are the modifications. So first, the bow tie technique. In this, we can see that the sutures are tied together in a single loop bow, similar to the shoelace. So whenever we want to adjust, we loosen the loop, then we tighten it or loosen it according to whatever we desire, and then convert the loop knot into a square knot. And the next one is sliding noose technique. In the sliding noose technique, noose is created by tying a separate suture, as we can see here, the suture around the scleral sutures. So when to adjust? This is again a question. Like there are few surgeons who do adjustable sutures in almost every adult patient, whoever is cooperative, and some don't do it at all. But few of the indications which are universally accepted are restrictive diseases like thyroid ophthalmopathy, paralytic strabismus in which diplopia is seen, or in any case of strabismus in which diplopia is seen, previous trauma surgery, or any large angle strabismus. So what are the contraindications? The absolute contraindication is uncooperative patient, because cooperation is extremely important in the adjustment phase. And the relative contraindications are very high myopes, friable muscles, inferior rectus muscle, because the prediction of inferior rectus muscle recession amount is slightly dicey, and children less than 12 years of age, again because of the cooperation issue. So there are few special cases in which we consider adjustable surgery. So pediatric cases. In pediatric cases, we can do it either under the adjustment phase. The second stage is done either as a topical under topical Parocaine, or sedation under intravenous propofol. And the success rates are also almost similar to that of the adults. And there are many studies in which the youngest child operated for adjustable was 10-month-old. And because of the time constraint, I'm not discussing everything in detail. There are also adjustable inferior oblique surgery. In this, we can see that there is a non-absorbable suture which is present between proximal and distal cut of the inferior oblique muscle. And then this is the adjustable Faden suture combined with the recession. And semi-adjustable suture, this is mainly used in inferior rectus muscle, in which the pole sutures are secured and the adjustment is carried out with the central suture. And adjustable superior oblique, in which again there is a non-absorbable adjustable spacer. So complications, intra-adjustment complications, they are the most common are nausea, oculocardiac reflex, bradycardia, syncope, and the post-operative complications are, there'll be a slightly increased amount of redness in these cases. Sometimes conjunctival dehiscence can be seen, sometimes it can be even as severe as it may need an amniotic membrane transplantation, and adhesions and suture granulomas. So what are the future directions? We can use barriers like silicone, viscoelastic, and bioabsorbable films. These are basically to prevent formation of adhesions, so that we can delay the stage 2 or adjustment phase almost from 1 week till 2 weeks. And resections and transpositions are also being explored. So here I would like to share a case which we have seen recently, and also the surgical video of the same. So he is a left eye, recovered 6 cranial nerve palsy with esotropia and with bilateral traumatic optic neuropathy with bitemporal hemianopia. So on examination, he had a right face turn of 10 degrees and 30 prism diopters of esotropia. So let's see the surgery. So here we have planned a left eye LR plication, left eye lateral rectus plication of 8 mm and MR adjustable handbag of 6 mm. I'm not talking about the LR plication part. We basically will concentrate on the, let's concentrate on this MR adjustment part. Yeah, so it's done. The peritomy is closed after LR is done. Here we do it with a limbal approach. After hooking the medial rectus muscle, we dissect it and make the muscle free. We secure the insertion of the MR with the help of zygzovicryl sutures on the either side, as we can see here. Sorry for the frame, it's not centered. Then we disinsert the muscle and the base is cauterized. Now we see that we are making a scleral tunnel just 3 mm before the 6 mm mark we have taken. And now we pass to the insertion side. So there was the pole sutures, scleral tunnel, and the insertion side passage. Before tying a 1.5 knot, we put a silk suture or stay suture in between. And then it is tied. And now a separate bucket handle suture or traction suture is passed. So this is the short end of the MR adjustable suture. This is the long end of the same. The identification of both ends is very important. So because you know which end to pull it if you want to loosen the knot. And this is the silk or stay suture. And this is the separate traction suture, what suture we have used. Now peritomy is closed and the sutures are put away from the cornea to prevent any trauma. So after the surgery, after returning from the OR room, we do the routine rounds of the post-operative patients, and we have seen that there is post-operative diplopia seen in the patient. So now we have decided to adjust the MR recession to 3.5 mm. Initially we have planned 6 mm, so we have to tighten the adjustable sutures. So just have a look at this video.
Let's see how to adjust the sutures after medial rectus recession. The identification of the following sutures is important, which will be dealt in detail in the following video. The eye is adequately anesthetized with the help of topical anesthesia. Our first step will be identify the traction suture, that is the suture with the loop with knot. With the help of two forceps, identify both the ends of the adjustable suture. Pull the short tent completely and pull the silk suture to release the same. Now pull the both ends to tighten and put a 1.5 knot to secure the same. After putting the knot, the patient is checked for the resolution of diplopia, and after confirmation of the same, we can cut the silk suture and secure the 1.5 knot with 1 more knot. Then trim the sutures. The traction suture is also cut and the conjunctiva is reposited. Thank you for your patient listening.
So this is the post-op of the patient, in which we have seen that there is orthotropia in the primary gaze and the diplopia is also resolved. Yeah, so I would like to end my talk by this famous quote: if you can't change the direction of wind, then you can adjust your sails to always reach the destination. So yeah, if you use adjustable sutures as a it's a basically bone in the cases, especially where you are not sure of the post-operative adjustment. I would like to thank Dr. Amar Pujari for giving me this opportunity especially.
Thank you, Dr. Harsha, as you have prepared a very nice presentation. So thank you for preparing such a nice presentation. And if you have any questions, anybody has any questions?
Yeah, no, that was a very nice presentation, Asha. I think, adjustable squint surgery is typically a challenge, even for some of us who are doing quite a bit of squint surgeries on an everyday basis, because adjustments, themselves need to be, there's little unpredictability even despite adjustable sutures. But I think it's really been a good thing for squint surgeons to have this opportunity, of adjustment the next day or even the day after that. But generally, what is the, the earliest that you adjusted, or what is the longest time that you feel that an adjustment can be done?
So at our center, we generally do this, at least we follow till the anesthesia, effect of anesthesia is gone. So for local anesthesia, we take it almost of 4 to 6 hours. So if we are planning to do an adjustable, we do it in the morning, like 11 o'clock or before 12 o'clock. So by the time our OT ends, like 4 or 5 o'clock, we generally go and do the adjustment. So we maintain a gap of 4 to 6 hours. So, and preferably, according to most of the literature, it is 24 hours, but there are quite a good amount of literature coming up these days, especially in which they have done even till 3 days, and some have extended that even till 7 days.
Right. But yes, I mean, ideally, you want to do it within the first 12 hours, if you can. I think that
yes.
The earlier the better, as you said, is the norm. And of course, we've, there are different kinds of adjustable sutures have been described. For recently, we've had some adjustable sutures for the inferior obliques muscles and other muscles as well. But typically, it's the recti and the horizontal recti that this works best in.
Yes.
Good presentation. Yes.
Thank you.
Asha, can I make a point?
Yes, ma'am. Sure.
Yeah. So I agree with Dr. Digvijay. Whenever I have done this surgery and the next day I have to adjust, at that time I say that I won't do it the next time because it is so difficult. Especially adult patients, they're not too cooperative. Like in life also, adjustments are very difficult. So I think even adjustable surgery is little difficult. But I do end up doing it again on a patient where you think that is unpredictable. But after a month or so, sometimes, you don't get very good results even after adjustable. Then you feel ki maybe, a simple surgery would be. That's why most of the, experienced surgeons with time, they have shifted to 6 scleral and not doing adjustable because they tend to get their measurements so correct and accurate even with 6 scleral. But as Dr. Digvijay is saying that yes, it should always be in the armamentarium of a squint surgeon.
Yes.
Very good for incomitant strabismus. But for comitant large angle, I've tried it, but after the end of 1 month, I've got surprises. There was a patient where it was a very large XT. I did 4 muscles and put one on adjustable.
post-op went into 20 ET. I adjusted, made him ortho, but at 1 month he was again 20 XT. So at the end, I was thinking whether it was worth it. So very well presented, but
thank you so much, ma'am. Ma'am, so I just wanted to ask you one question. So do you think that adjustable is not as useful as in concomitant surgeries? So it's not very useful in large deviations. That's what you're saying.
Yeah, what I'm saying is it may be very good for concomitant strabismus, those who are diplopia, and you know that they will fuse after surgery. So you can titrate based on the diplopia and make them more comfortable in the immediate post-operative period.
Yes,
but for large angle strabismus where the fusion is not there, they may give you surprise even after a month or so and go back into a consecutive or a residual because fusion is not at your hand.
Yes,
so in those cases, yeah, but those who are fusing patients and those who have diplopia, they do quite well because they are happy immediate post-op also, and they keep fusing after that and do maintain. That was my experience. Although I've not done very too many adjustables, maybe in your center you must be seeing so many follow-ups of adjustables. But in my experience, this was the thing.
No, I think, there's an interesting case that I had recently where I used adjustable sutures. Now, this is typically not recommended if, they've been repeated resurgeries, because then there are fibrosis and other things around. But, recently I had a patient who had undergone 13 squint surgeries, 13 times. So he's been all over. And, the ones you can't really satisfy. And I did an adjustable suture in that. And, the next day I made him, and he used to have diplopia, and I made him kind of see, is it single? When he finally agreed it is single, I said, you're agreeing now, no? So I'm closing it here. And said the patient after that he was quite okay. He's been following up with me now, and he's, whatever it is, he says it was finally my call this time. So just an interesting anecdote there, that it did come in handy for one such case to, get them to be convinced that, it was your decision at the end, saying that, now things look okay for me.
So adjustable was successful in that case, no? So like it helped.
It was his 14th surgery. I did the 14th surgery. I mean, I had done about 3 in the past, and he'd been to various centers. Every center had managed some surgery or the other, and he would never be satisfied.
So if you don't mind, can I ask what was the initial diagnosis in that case?
No, that case was basically like a case of a congenital cranial dysnervation disorder only, and he didn't have fusion, and but there was diplopia. They could never fuse because either some vertical or some horizontal would come up. But by the time the patient came to me, I mean, I was not too confirmed on the initial diagnosis either, because there's so many surgeries that happened. It was completely an incomitant situation. All muscles were out of place. I think there was hardly a muscle which wasn't really touched, except 2 recti in each eye, because somebody at least fortunately thought that, there could be anterior segment ischemia, and let's not do that. But the obliques had been placed in every different place that they could possibly be. So we did an adjustable oblique in that, along with an adjustable horizontal in 2 separate surgeries. That's how I'd done it.
Thank you, sir. Thank you, Dr. Asha. We have next speaker, Dr. Rahul Bafna. So he is busy with another session. So next I am going to call Dr. Prakyat Roop. He has done such a good innovation. So that is negative dysphotopsia. He has consistently worked since almost 4 to 5 years in this particular idea. So he's very single-minded in pursuing this ultimate goal. So he has patented, even this innovation is in the market. So let's hear from him. Dr. Prakyat, please.
Thank you, sir. Can you hear me? Can you see my screen?
Yes, please go ahead.
Okay. So thank you to DOS executive and to Dr. Digvijay and Dr. Karan Bhatia for this opportunity, and especially Dr. Amar for including me in this session. I'll be speaking on a definitive treatment strategy for negative dysphotopsia. This is my disclosure. I have a patent pending under review on this device. So I'll start with why I picked a bone with negative dysphotopsia and how I collaborated with other fields of work to finally find a solution to negative dysphotopsia and the clinical aspects for diagnosing and managing it, and how I have seen it impact a patient's life. So the story begins with this patient. She was my very second phacoemulsification surgery. And this was an illiterate 61-year-old lady who complained on the first post-operative day that the lateral part of her lids were sticking to each other and she could not open her eyes completely. Now, this complaint persisted continuously on every follow-up, and she kept on getting disheartened every follow-up subsequently. So what I did was I looked up the literature to find any reference of any post-operative post-vacoemulsification syndrome that that the patient suffered without having an evident ptosis, and I could not find any such symptomatology. So I remembered this quote from our short practice of surgery of Bailey and Love, that to study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to the sea at all. So to the sea I went, and I discussed with a lot of clinicians, high volume cataract surgeons, and I found that a lot of patients do present with such problems. And this patient, he had a very characteristic hand gesture that was the same as my patient, but he was a more perceptive patient. And this patient was gracious enough to draw a sketch for me to explain his problem. He also very categorically said that using a thick framed spectacle helped him avoid this shadow. So I drew another sketch for him, and I asked him if this could be used to explain his symptoms, and he clearly agreed. So I realized that my less perceptive patient had interpreted negative dysphotopsia as something sticking her lateral eyelids together, preventing her from a temporal field of view. So unfortunately, at the same time, I was working with IIT Delhi on designing a lens that could compensate for angle alpha and center the optic on the visual axis so that we could make the maximum use of the premium optic IOLs. We used the same model to fashion a peripheral pencil of rays that were made to fall in the posterior chamber in the nasal periphery. And we found that the cause of negative dysphotopsia was a shadow in the nasal periphery coming from the square edge of a IOL placed in the posterior chamber in the back. Luckily for me, at the same time, there were others working on the same concept. And right about the same time as I had confirmed the cause of negative dysphotopsia, Holliday published a similar study on a Zmax I model, which proved that the ray tracing hypothesis were indeed true. So we went on to file a patent for it. And then we conducted our pilot study and subsequently a complete clinical study on the same. So the idea that came to me was to have a sulcus implant that did not alter the central rays going to the optic of the IOL, but change the behavior of the peripheral rays. This is the mechanism of working of negative dysphotopsia ring, that the rays from the temporal periphery will undergo a refraction at the edge and they will distribute evenly in the nasal periphery, thus covering that shadow portion. While at the same time, the ring will sit on the anterior capsule and prevent any rays from high angles of incidence to fall on the capsule directly. The clinical aspects for negative dysphotopsia, its diagnosis and counseling in our clinical practice is important. Patients can present from describing a very well localized concentric black shadow in the temporal periphery to non-specific symptoms such as heaviness. Especially the illiterate patient in the Indian scenario presents with this symptom of the lateral part of their lids sticking to each other. And I have collected over time evidence of so many patients having these hand gestures to typically define that obstacle. Next is important to confirm this diagnosis because there are other overlapping symptomatologies and there is no objective proof to prove the existence of negative dysphotopsia in a patient. It is a symptom. So ruling out neuroophthalmological cause of an abnormal field is most important. To confirm the diagnosis, I generally ask the patient to use a thick rim frame of spectacles or a trial frame. And when the patient tries it on, they feel that the symptoms have lessened. Using a hand or a veil or a scarf as a blinder on the temporal side to block the shadow, or pupillary dilation to decrease or eliminate the size or intensity of that shadow, these confirm the diagnosis to us. Now, in the past, the problem starts here. We counsel the patient, and for management, we only have these anecdotal reports of small case series of questionable efficacy interventions to manage negative dysphotopsia. So here's what an interaction of a patient with his surgeon goes like. When they come with a cloudy vision and difficulty to read, we give them the state-of-the-art cataract surgery with no morbidity at all. When they ask if they are going to be able to read without spectacles, we have trifocals at their service. Now, when with their trifocals, they come with a black shadow and can't see the whole view, which is extremely nagging to them, we tell them to wait and watch because most of the negative dysphotopsia resolves or patient adjusts to it within, say, 6 months. But when it doesn't get any better, then we cut a sorry figure because we do not have a definitive solution for the patient. So I started working on this idea and we designed this ergonomically fashioned haptic to place this device in the sulcus, this ring-shaped implant, which did not require any white-to-white measurements and was sleek enough to go into any sulcus size, even in a hypermetropic eye with a smaller AC. There was 100% success with no adverse events at all, and it did not need any added instrumentation. Let's have a look at the surgery. So we can open the old existing 2.2 mm incision, or we can make a new incision and inject OVD under the iris to gain access to the sulcus. The loading is done in a routine fashion. The ring is just folded into the butterfly cartridge and injected into the AC and manipulated into the sulcus. The AC is washed of all the OVD and the wound is sealed. Post-operatively, the eye looks pristine as before, and the ring is seen resting on the anterior capsular rim. If you shine a temporal peripheral slit, it directly is incident on the nasal rim of the ring, and that is how it actually works. This light, which was going to bypass the optic of the IOL and be incident on the nasal retina, is actually now getting refracted through the ring. And in the ASOCT, we can see that the ring comfortably rests on the anterior capsule and it generally does not rub the iris. Even if it does, it is made of a biocompatible material that is designed and tested for more than 2 decades to be compatible in the sulcus. We completed a clinical study of 20 eyes containing both therapeutic groups in which a second procedure was done to implant the ring, and a prophylactic group in which patients suffering from negative dysphotopsia in one eye underwent a prophylactic implantation at the same time as the IOL surgery to prevent ND in the other eye. And we had 100% results. So how does it impact the clinical practice? A lot of people, even experienced surgeons, sometimes question me saying that does negative dysphotopsia really impact anyone's life, because we have not seen it in our practice. So statistically, there is a 6 lakh new patient adding to the burden of negative dysphotopsia in the world. And cataract surgeries are growing at a rate of 4.5% annually. So negative dysphotopsia is by far one of the major side effects after having taken care of PCO. In the times promising eagle vision from near to distance, managing dysphotopsia with life hacks is ironical, because at the end of the day, it is an iatrogenic effect, and every practitioner will agree that when the patient comes in hope of a solution for vision and ends up getting another nagging complication in exchange, he is disappointed. So my aim was to have a reliable solution so that we can have a confident surgeon in tackling negative dysphotopsia. At least one should have the option of offering a patient solution for something that they have inadvertently caused. So I have this testimonial from a patient, and let's have a look at how it has changed his life.
दिखाई देने में आपको दिक्कत नहीं, तो ये जाला सा या फोटो आप कहते हो वो क्या दिखता है? वो ऐसा था, ऐसा मतलब आप छोड़ा उसे छोड़ने के बाद जो यहाँ पर जो है जाला सा हो गया। अच्छा, हाँ, आपने हाल क्या जैसे ऑपरेशन के बाद हुआ था, तो 3 महीने में वो वैसा का वैसे ही बसेगा, तो उससे आपको अपनी आम जिंदगी में काफी अड़चन सी लगती है। दुकान बैठे थे, तो हमने उसे से बोला कि काम नहीं होता। फिर जब हमने ये उस दिन ये काम किया, आपका पट्टी हटाई थी, तब आपसे पूछा था, तब भी आपको महसूस नहीं होता, जब भी मैंने बोली ठीक।
So my message to everyone is that, you know, we are going to operate our maximum phacoemulsifications on the Gen Z, and Gen Z is not going to take compromises for an answer. So we have to be ready to them for every solution. Thank you.
Thank you, Dr. Prakyat. That is a very innovative talk, and thank you for presenting on this platform. I thought it's going to be a young session, so you presented such an innovation at this podium, so it's commendable job. So if anybody has any doubts, they can ask. Prakyat will be more than happy to answer. Okay, so then we'll move on to next speaker. Sorry.
So I was just asking Prakyat.
Yes,
so
sir.
most of your patients that you were talking about negative dysphotopsia, most of them were forthcoming about it, or you had to kind of lead them to tell you that this is a problem.
Sir, what happens is that in the clinics, when they come back to you, they actually have a little bit non-specific descriptions. So, but the hand gesture that I was describing is mostly their complaint. And it happens with those who have had a very uncomplicated surgery, a softer cataract. So they were seeing better, like they were 612, 624 maybe, with some quality problems like in the sharpness or their index, the lens index was higher, so they had refractive problems. So those kind of patients come with this complaint and they are forthcoming. They do tell, but you have to be really cautious that this is something that exists, and then you have to probe them further to describe their symptoms.
Right. So it's probably we only who miss it out actually, because we don't look for it.
Yes. So actually, my professors have so many times questioned me that, like in one center you found in a year 20 patients and we don't see any of them. But then I realized that we don't ask post-ops that well with our patients. When they are 6x6, we just tell them that the surgery has been very well, and we prescribe them near ad, and that's it. I don't think that we follow them up that much. We are so much confident with our phacoemulsifications now that we don't really probe them in their post-operative period or even care for their symptoms. It is a sidelined disorder because it did not have a treatment in the past.
Right. No, well done. Well done.
How long do you prefer to wait before you actually plan to intervene?
Ma'am, that depends on the patient's choice. Sometimes the patients are so annoyed with the problem that within 1 month they will come to you and tell you that I cannot adjust with it anymore. I'm ready to go undergo a second procedure. For example, the patient's testimonial that I shared, he used to go to his shop. He's just a shopkeeper, but it was so nagging to him that he got operated the very next month. Sometimes the patient will tolerate it for some months and may adjust with it, but that totally depends on the intensity of the shadow that the patient is facing.
Okay.
So it's the patient's choice. We can go in as early as a month and we can wait for as long as the patient does not want it to be intervened.
Okay, thank you.
Thank you.
Okay, thank you, Dr. Prakyat. We have next speaker, Dr. Bharat Mehta. He's a senior consultant at Visitech, and he has special interest in cataract and anti-segment surgeries. So now he is going to teach something about management of posterior capsular rent. Dr. Bharat, please.
Good evening. Am I audible?
Yes, you are audible.
This is something which every one of us faces. I think any surgeon who doesn't get PCR is not doing enough cataract surgeries. So I've made a very simple presentation, and I would like to thank Dr. Vinay Garodia, he's the director of our institute, for his inputs in this presentation. A cataract surgeon must know how to do an anterior vitrectomy and give intravitreal injection, because these are the two things we need in an armamentarium to handle surprises during and after the surgery. A successful cataract surgery removes the opaque lens. You implant an IOL without causing any complication, especially PCR. But PC rent is the beginning of most of the complications of cataract surgery. PC rent may lead to a nucleus drop, an inability to place the lens, IOL decentration, a drop, cystoid macular edema, retinal tears, retinal detachment, glaucoma, corneal decompensation, a chronic uveitis, an increased risk of endophthalmitis, and most importantly, insomnia and peptic ulcer to the surgeon. Now, emergencies do happen, and it is important that preparation is the key. And we have to prepare for everything and be prepared for anything. So do not be scared of the vitreous. Vitrectomized eyes can do well. We just have to know the principles and anatomy of vitreous and complications. Do not be in a haste. Do not be act on reflex. We have to be ready with instruments in every single phacoemulsification, and we have to have a plan of action in place. A PC rent kit should be kept separately in your OT with a sharp 25 gauge cutter and a new 25 gauge cutter, a new trocar, Viscode. You need to have an inventory of 3-piece IOLs, rigid AC IOLs, PC IOLs, and for a dropped IOL, a phacofrag tip and a handpiece in an ETO pack. Or you can just keep a 25 gauge total vitrectomy pack. PC rent management, the most important thing is to recognize it early, prevent the extension and release any undue pressure. If it is without vitreous loss, then you have to remember not to take out the instruments immediately. Push a little viscoelastic from the side port, then remove the instruments. It prevents upward thrust and vitreous loss. You can do a dry aspiration for the residual cortical matter, and then check the status of the vitreous and implant the PCIOL, whether in the bag or in the sulcus. That will depend on the size of the ring. If there is a vitreous loss, then there are two ways to go about it: either do an anterior vitrectomy or go through the pars plana route. Most important, it is to have a watertight wound. We have to suture if you have enlarged the wound. Use a good cutter. Do not do a manual anterior vitrectomy. It has to be done with an automated cutter, and it has to avoid any undue traction. So for a good anterior vitrectomy, have a nice sharp sterile cutter with a moderate suction up to 150 millimeters of mercury, with the maximum cut rate available for your machine. Depends on what instrumentation you have. Most good machines have a decent enough cut rate now. Do not use a coaxial irrigation. Irrigation should be done using a 23 gauge cannula, which controls the IOP. And the cutter tip should face anteriorly and should always be visible. There should be a separate port for irrigation and vitrectomy. Now, this visual will show how you go through the PC rent into the anterior vitreous cavity. This will prevent any traction of the vitreous. It will pull the vitreous inwards. So this should be the direction of the vitrectomy cutter. After we have cleared the anterior vitreous, we can tackle the cortical matter using only the suction, keeping the cutter off. We can turn the cutter on intermittently if we feel there is some vitreous. We have to avoid any damage to the residual capsule, complete the anterior vitrectomy, ensure a round pupil, and then implant an IOL. Alternately, you can use a pars plana route if you have a retina colleague, or if you are confident doing it through the pars plana route. Then you first implant a 3-piece foldable IOL in the sulcus, seal the wound, tighten the globe, and make sure there is no hypotony, and then we just go ahead and make a 25 gauge trocar entry, 3 to 3.5 millimeters from the limbus, and then put an infusion through the limbal side port incision. The cutter goes through the pars plana trocar entry, and we do a thorough anterior vitrectomy and residual cortex removal. This is a video courtesy of Dr. Vinay. This was a case done some time back by a colleague. Some lag in the video. There was uneven staining of the anterior capsule, and therefore there was a rhexis runoff. It was converted to a can opener capsulotomy. Subsequently, during phacoemulsification at the end of IA, there was a PCR, as you can see. A 3-piece IOL was implanted at this stage, and it was decided to go through the pars plana route to do an anterior vitrectomy. A 25 gauge trocar entry was done. At this stage, it is important that you use a very sharp and or a new trocar. It should not be twisted. It should go in straight away. So any twisting motion should be avoided so as to minimize vitreous disturbance. Irrigation is done through the gimbal side port which we have available, and then the cutter goes in and does the anterior vitrectomy. Once the anterior vitreous has been cleared, the same cutter can be used to remove any residual cortical matter. This route is much safer and has less complications, although it requires more technical expertise. As you can see, because the lens has been implanted perfectly, there are less chances of complications with this method. The advantages are that since we have implanted the IOL, it minimizes the danger of further capsular injuries and reduces the pull on the vitreous, minimizes traction, and it is easier to clear out residual cortical matter. It is best to avoid a PC rent, but a properly managed PCR can avoid most of the potential complications. Thank you. Any questions?
Thank you, Dr. Bharat. Any questions? Okay, so we have our next speaker, Dr. Ayushi Agarwal. She is a third-year resident at Guru Nanak Eye Center, and her thesis is on thyroid eye disease. And she is here to share something about advances in thyroid eye disease. Dr. Ayushi Agarwal, please.
Yes, sir.
Bolo.
Screen visible?
Bolo.
Sir, is my screen visible?
Yes, yes, your screen is visible. Please go ahead.
Thank you, sir, and Yossi and DOS for this opportunity. I'm Dr. Ayushi Agarwal, and I'm going to talk about advances in thyroid eye disease. I will be discussing the recent advances in the epidemiology, biomarkers, the advancement in management. So coming on to the epidemiology, much has been studied and talked about thyroid eye disease in the Caucasian population, but is the Indian clinical profile same as the Western? The answer is no, which is very much evident with few published articles in August 2020. Unlike the popular belief that the autoimmune disease is more common in females, there is slight male preponderance seen in the Indian scenario, and the unilateral disease is quite common. The inactive disease is more common than the active disease, with a higher proportion of euthyroid and hypothyroid. We have also studied in our residency that lid retraction is the most common sign, but this was all from the Caucasian population. The Indian studies have shown that proptosis is actually the most common presenting sign. A study published in August 2020 by Dr. Milind Nayak and Dr. Varshita Vasantpuram have given the concept of silent presenters. That is, out of 475 patients that were temporally active, that is, as per the Rundle's curve, they presented within 12 months. 70% of these did not elicit any signs of activity as per the clinical activity score. So there may be some factors that actually blunt the acute presentation of thyroid eye disease in India. Now, we are going to study about biomarkers in thyroid eye disease. Biomarker is any indicator, anything that objectively measures and evaluates a normal or a pathogenic process. So why do we need to study about them? So the evolution of thyroid dysfunction to orbitopathy is quite unpredictable. Like, we don't know which hyperthyroid patients are going to develop orbitopathy. In fact, some develop orbitopathy before actually developing thyroid dysfunction. So that is quite unpredictable. And why only orbital fibroblasts are affected, not the other fibroblasts in the human body? So the answers are not clear. So we need biomarkers, discovery of new markers that can actually assist in diagnosing the disease early and therefore predicting the prognosis and enhancing the healthcare outcomes. So these biomarkers have been widely studied in the traditional biological fluid, that is the blood. The TSH receptor antibody levels are commonly performed. However, the heterogeneous pattern of thyroid dysfunction, that is some are hyper, some are euthyroid, some are hypothyroid, this actually limits the clinical relevance of these assays. Now, cytokines have come up as potential diagnostic markers. It is seen that in the active disease, the IL-1 beta 6 and 17 actually increase. In refractory diseases, certain interleukins such as 4, 6, and 10 increases. In fact, this serum selenium levels decrease with increase in the severity of the disease, thus explaining the rationale behind the use of oral selenium supplementation in mild thyroid eye disease. So tears, surprisingly, this is the most poorly studied fluid as well as the most promising ones. It is a non-invasive method, rapid collection, easy, and a feasible option. Also, tumor necrosis factor alpha levels have found to be raised in patients with thyroid eye disease as compared to the controls. Now, orbital fat is actually a very relevant tissue for biomarkers because it is close to the location of the disease. But we know that it is an invasive procedure. In fact, it can be performed while we are doing the decompression surgery. Certain factors like platelet-derived growth factor have been found to be overexpressed in thyroid eye disease. Therefore, any drug that will inhibit PDGF will have a therapeutic role. So the understanding of these markers actually open new therapeutic options and insights into the disease. Now, coming on to the evaluation, we all know that whenever a patient of thyroid eye disease comes to us, we have to grade the activity and the severity of the disease. So the protocols we use are the clinical activity score, which was amended by UGOGO recently, which scores the disease out of 7, and the visa classification, which was modified by the ITDS. For the classification of the disease severity, we do the UGOGO classification: mild, moderate to severe, and sight-threatening disease. So in imaging, what is new? We already know the signs we see in the CT, MRI, and the ultrasound. So what is new is the navigation-assisted 3D reconstruction and the pre and post decompression volumetric studies. So in MRI, there are certain biomarkers of active disease that can actually help in predicting whether the disease is active or inactive. Newer signs have been developed, have been discovered, such as the stripe sign. And in the ultrasound, color Doppler imaging is gaining popularity. So coming on to the MRI, the biomarkers of active disease, we have higher signal intensity ratios on T2 and T1 with gadolinium sequence. So what is the signal intensity ratio? So it is a ratio. So it is the ratio of the signal intensity of the extraocular muscles when it is compared with that of the temporalis muscle. So it is found to be higher when the disease is active. Similarly, the ADC coefficient, the apparent diffusion coefficient, is actually a marker of the water content of the tissue, which increases in active disease. So this, an increased ADC coefficient on a diffusion weighted MRI will actually detect whether the disease is active or not. Now, this is this newly discovered stripe sign, which is best elicited on contrast enhanced fat suppressed T1 weighted MRI, as seen in this B picture. So we know that an extraocular muscle layer has two layers: the outer layer, the orbital layer, and the inner global layer. So this inner global layer in this picture is hypointense. And in thyroid eye disease, it expands progressively and terminates prior to the insertion on the globe. Whereas this orbital layer, it does not expand up to the same extent and thus gives us stripe kind of an appearance. Now in color Doppler imaging, basically we study the resistivity index of the ophthalmic artery and the central retinal artery. So it has been found that the resistivity index actually increases in moderate to severe cases of the disease. In fact, it can pre and post decompression resistivity index, color Doppler imaging has been used, and it is found that the resistivity index decreases post decompression surgery. So this actually helps in understanding that the hemodynamics in thyroid disease improve after doing a decompression. Now we'll talk about some newer advances in the management. So selenium is now being widely used in mild thyroid eye disease. we use oral sodium selenite 100 mg BD, which has resulted in significant improvement in quality of life, has reduced the disease and the progression at 6 months. However, one must be cautious as there is increased risk of diabetes. So at no point in time must the serum selenium level exceed 122 microgram per liter. Coming on to the moderate to severe active TED, we all know that the first line of treatment is the corticosteroid. But there have been certain advances in the steroids as well. Now people have started using local routes like peribulbar, fornical, and subconjunctival. In fact, a recent study has used perilivator LPS triamcinolone injection for lid retraction. Now, as we're talking about lid retraction, the other temporizing measures that we can take for lid retraction are the fillers and Botox. Now, teprotumumab, with the advent of development of teprotumumab, a new era in the treatment of moderate to severe active TED has emerged. So basically what this is the pathogenesis of thyroid eye disease. This is the orbital fibroblast, which is the major effector cell. It expresses the most commonly auto antigens, the IGF-1 receptor and the TSH receptor. So the auto antibodies against these will bind and will result in activation and enhanced antigen presentation. This leads to further recruitment of T cells and release of cytokines. This will lead to deposition of GAGs, hyaluron, and adipogenesis. So what teprotumumab does is it blocks the IGF-1 receptor. So it is a humanized monoclonal antibody inhibitor of IGF-1 receptor, and it is the only disease-modifying FDA-approved agent for moderate to severe active TED as of January 21, 2020. So it comes with the brand name of Tepezza. It is given as infusion, 10 mg per kg for first infusion and 20 mg per kg for subsequent infusion once every 3 weeks for 21 weeks. And this is from the study, the major trial that was conducted. As you can see that in the teprotumumab group, not only the activity, but the proptosis has also drastically reduced along with the enhanced quality of life as compared to the placebo. So this is the only drug. It is said that teprotumumab in active disease is as effective as doing a decompression in inactive thyroid eye disease. So as we are already talking about immunomodulators, we have already talked about teprotumumab. It is not available in India yet. Now rituximab. Now the rituximab has given some conflicting results. So its benefit in thyroid eye disease is actually controversial. Tocilizumab, on the other hand, an IL-6 receptor antagonist, has provided promising data regarding improvement in clinical activity score and enhanced quality of life, as well as reduction of proptosis. It has been seen that it has reduced proptosis up to 1.5 mm. Other immunomodulators like infliximab, adalimumab, etanercept are yet to be studied. Now, some surgical advances in thyroid eye disease. Traditionally, we all know that we do a staged procedure, like we first go for decompression, then we go for strabismus surgery, and then we go for eyelid surgery. In decompression, the indications are residual proptosis, or the indication for doing an urgent decompression is in dysthyroid optic neuropathy. Now, newer indications have come up, like some people also use it, also go for decompression when there is a long-standing congestion. Some people have used customized decompression, that is, they have combined stage 1 and stage 3 and have found good results. Endoscopic decompression is also gaining popularity along with popular non-invasive approaches such as transcaruncular and transconjunctival approaches. So despite these recent advances, thyroid eye disease remains an area of changing landscape and never-ending research. Ultimately, we need modalities that not only halt the progression, but also reverse the progression for enhanced patient outcomes. Thank you.
Thank you, Dr. Ayushi. So that was a comprehensive talk. Okay, that means you have studied your thesis in depth. Okay, anybody has any questions for Ayushi? Okay, then we'll invite our last speaker, Dr. Gunjan Saluja. So she has done some of the innovations at our lab, during pandemic for residents. So Dr. Gunjan, please.
Yes, sir. A very good evening, everyone. So I'll be discussing a small do-it-yourself model which we had made during this pandemic. Basically, it was targeted for training of the basic training of the residents. So we all know that surgical training is of utmost importance for training in the body of ophthalmologist. And ophthalmic surgeries are skillful procedures with a learning curve, and skills need to be transferred from an experienced surgeon to the residents and fellows. However, with the rampant of COVID-19 cases, the routine surgical procedures have come to a halt, and this has mostly affected the resident surgical training. Our aim was to perform the maximum surgical procedures on the animal eye model, which is conventionally just used for training of the cataract surgery. And secondly, to develop a new small do-it-yourself model, which anyone can make it anywhere, so as they can practice the basic steps of cataract surgery. So animal eye models, goat's eye, are easily available, they are inexpensive and can be bought from the local slaughterhouse. When mounted on the mannequin head, one can practice a large number of surgical procedures with a great ease besides the conventional cataract surgery. I would thank here Dr. Amar sir to providing me this idea and to help us perform the surgery and to provide these beautiful images also. So this is a corneoscleral perforation repair which can be done easily in a goat's eye. And but first we have inflicted a corneoscleral perforation and then repaired it with a 80 vicryl suture, 60 vicryl suture and 80 vicryl suture and a 10-0 nylon suture. Secondly, resection surgeries can also be practiced in goat's eye, which have attached extraocular muscles and gives one the experience of similar handling of the human muscles. Similarly, buckling surgery can also be practiced in the goat's eye. Trabeculectomy with releasable sutures can be practiced using goat's eye with a great ease. So the next thing what we thought was like, because there were certain days where goat's eye were also not available, especially during the peak of COVID-19. So we made a small do-it-yourself model. There are various eyes available in market like phaco eye and Ketaro eye sets. These are commercially available, but these options are for single use only and they are not cost effective. So, and they most importantly, we thought that we should design a model which is cost effective and can be used multiple times. So first of all, we took a rubber ball in which crater was created with the help of a sharp edge instrument, which could be a knife. And then the lens was made. Lens can be made with the help of combination of 2 tablespoons of cornstarch with the same amount of water and a drop of glue, all of which was heated for 2 minutes. This resulted in a dough-like consistency, which was then fixed into that crater. Above it, the next thing which we had to search for was the cornea. So one can, if your wet lab has the phaco eyes, one can extract cornea from that phaco eye model, or if not, then one can also use the nipple of a used milk bottle to create the cornea and attach it to the ball. So this is how the lens was placed in the crater. And this is the video which shows the hardness of the lens. It had a intermediate hardness and intermittent hardness, and the cornea is fixed to the ball with the help of heavy glue, and this created a watertight chamber, and all steps of phacoemulsification can be performed. So this video shows the basic step of sculpting being performed in the nucleus, and one can see that the scalp is now being created. Secondly, one can also practice steps like chopping using this model. And this is another video which shows phacoemulsification being performed and intraocular lens implantation in the eye. So following this, the residents were provided with a questionnaire at the end of practice session. We gave this model to 15 of our residents and recorded their response, and we found that they did gain confidence in performing this surgery. Although the tissue handling experience was not very similar to the human tissue, and that is true, any tissue or anything cannot replace the human experience. But yes, it did help them to gain experience and did help them to experience the sculpt and chopping techniques too. So wet lab models are simple and cost-effective way for training, especially in this era where residents are not getting enough cases and training has come to a halt. It is important for all the budding ophthalmologists to properly gain confidence in the basic surgeries which have to be performed. And do-it-yourself model is a simple model which gives a realistic experience and is really helpful for the residents who are learning to perform phaco emulsification to gain a proper hand-eye-foot coordination. Thank you.
Thank you, Dr. Gunjan, for presenting your innovation. I think that was the last talk. So I would like to thank all the young people, Dr. Prachi, Dr. Samreen, Dr. Shalja, Dr. Ashwini, Dr. Asha, Dr. Rahul. Of course, Dr. Rahul could not make it here. So Dr. Prakyat, Dr. Bharat, Dr. Aishi, and Dr. Gunjan. Thank you. So we can conclude this meeting and we can leave this one. Thank you.
Thank you, sir.
Thank you.